Thanks all. Let's take our seat and we can get started.
Make sure you go down the stairs.
Welcome everyone. Let's get started. Good morning all. We're ready to get started. Thank you. Good morning. I'm Deborah DeVoe, Chair of the Massachusetts Health Policy Commission, and on behalf of my fellow commissioners, let me welcome you at the annual Healthcare Cost Trends hearing. Welcome to all of our panelists and presenters today. We thank you for your participation, and we're looking forward to hearing from you all. Welcome to Attorney General Andrea Joy Campbell, who we all look forward to hearing from shortly and think of on a daily basis. We are very, very glad to have you as our Attorney General and to have you here today. Joining us on the dais are our partners from the Office of Attorney General and the Center for Healthcare Information and Analysis. Thank you. And I'd also like to welcome Senator Cindy Friedman and Representative John Long, chairs of the Joint Committee on Healthcare Financing, Representative Christopher Markey, and Representative Dawn Shand. And welcome to those here in person at Suffolk University Law School and to those joining us via our live stream. Really glad to have you all attend. This year marks the 13th annual Cost Trends hearing hosted by the HPC. It's a particularly notable year as it is the first Cost Trends hearing since the passage of significant healthcare legislation at the beginning of 2025 that expanded the HPC's oversight authority in a number of important ways and also reshaped the composition of the HPC's governing board. I'm pleased to be joined today by 8 new commissioners, and I want to wish each of you a very warm welcome to your first Cost Trends hearing as an HPC board member. I'd like to ask each person on the dais to introduce themselves, and commissioners, if you could please also include which statutory role you were appointed to represent. And could we start with you, Commissioner Caljo?
Yes, good morning, and thank you, Chair DeVoe. My name is Michael Caljo. I'm the Massachusetts Insurance Commissioner. I serve in this role ex officio.
Yes, good morning, everyone. I'm Kami Mahania, Secretary for Health and Human Services, and I believe that's the capacity which I serve.
Good morning, I'm Steve Walsh. I'm a gubernatorial appointment for a person with experience representing hospitals and health systems.
Good morning, James Wilmoth. I'm here as a commissioner representing the healthcare workforce.
Good morning, everyone. I'm Umesh Kurpad. I'm representing the Health Plan Administration and Finance sector.
Good morning. I'm Alicia McGregor. I am the commissioner with expertise in consumer advocacy.
Good morning. Marty Cohen, Vice Chair of the Commission, and I'm appointed by Attorney General Campbell, holding the behavioral health slot.
Good morning. I'm Sandra Cotterell, and I'm sitting in the nursing seat.
Good morning. My name is Keith Marzilli Erickson, and I am appointed by the Attorney General with expertise in health economics.
Good morning. Chris Leidman, appointed by the Governor with expertise in healthcare innovation, including pharmaceuticals, biotechnology, or medical devices.
Good morning. I'm David Seltz, Executive Director of the Massachusetts Health Policy Commission.
Good morning. Lauren Peters, Executive Director of the Center for Health Information and Analysis, otherwise known as CHIA.
Hi, everyone. I'm Sandy Walitsky here with the Attorney General's Office, where I serve as the Senior Health Policy Advisor in the AG's Healthcare and Fair Competition Bureau.
Thank you all. The theme of this year's hearing is working together to safeguard the Commonwealth's commitment to healthcare affordability, access, and equity. This hearing offers a critical opportunity to convene and discuss the pressing issues challenging the stability and sustainability of the Commonwealth's healthcare system. This year, these include barriers to affordability, workforce constraints, financial volatility, high and rising prescription drug costs, and threats to healthcare access and coverage, and the ongoing efforts to address them by the healthcare industry and our state partners. Amid ongoing federal action that is creating uncertainties within the healthcare landscape in Massachusetts, we still contend with existing affordability hardships facing the Commonwealth's residents. Today's hearing convenes Massachusetts healthcare industry and business leaders, clinicians, patient advocates, state partners, and community members to reflect on recent policy changes and invite further collaborative action in Massachusetts, advancing the Commonwealth's healthcare goals and values. I want to sincerely thank all of the dedicated individuals and organizations that touch the healthcare system for your commitment to creating a roadmap to a system that is affordable, accessible, sustainable, and equitable for all our residents. I can say personally that I have always felt very privileged to live in Massachusetts. I moved here 40-plus years ago. I have never felt more privileged than now, and never more grateful to be in a room with other people, as I look out over the room, who are committed to solving problems and to serving the Commonwealth in a variety of different roles. I don't think I ever took it for granted exactly, but I now feel it very, very strongly. So thank you for being here today, and to those of you online. Now I will turn it over to Dr. Alicia McGregor, our commissioner, to introduce the Attorney General.
All right, thank you so much, Chair DeVoe. I'm Alicia McGregor, and it is my honor and privilege to introduce Attorney General Andrea Joy Campbell, who will begin today's hearing with some opening remarks. Attorney General Campbell has been a champion for Massachusetts and our healthcare system in her role as the state's chief law enforcement officer. As many of you know, the AG's office holds several important law enforcement and oversight responsibilities with respect to healthcare, in addition to being an appointing authority to the HPC. And I'm honored to have been recently reappointed by the Attorney General to my role on this commission representing healthcare consumers, or the patients and the communities that rely on our healthcare system. Thank you again, Attorney General Campbell, for the opportunity to continue to serve in this capacity, and welcome.
Thank you.
Now, prior to taking office, Attorney General Campbell served as General Counsel at the Metropolitan Area Planning Commission, legal counsel to Governor Deval Patrick, and was the first Black woman to serve as the president of the Boston City Council. As Attorney General, she has made addressing healthcare access and inequities a top priority, standing firm in her commitment to those values, even as federal policies threaten coverage, affordability, and critical protections for residents of the Commonwealth and beyond. And I'd like to stop here just to take a moment to pause to acknowledge the Attorney General and truly the incredible and, in many respects, the heroic work that she's currently doing in coalition with leaders and other, well, actually, I meant to say co-leading and leading coalitions of attorneys generals and governors across the nation as we fight back against many of the harmful policies of this federal administration. And I want to echo some of what Chair DeVoe just mentioned, because let's face it, sometimes Boston and Massachusetts can be tough places to navigate. We have a high cost of living. We have a legacy of racial and economic inequities that we're still working to overcome. And again, unfortunately, we've been ranked as having some of the worst drivers in the nation, which has earned us a not so flattering nickname on the road, right? But with all of the challenges facing this,
Gotta keep it light.
Listen, I think we need a little comic relief at this moment, right? So with all the challenges facing this rich and diverse state, I also couldn't be prouder to live in the Commonwealth at this moment, precisely because we have an advocate like Attorney General Campbell, who tirelessly and expertly leads with courage and integrity, and who reminds us over and over that our democratic institutions can and must work to protect the most vulnerable among us. So thank you, Attorney General Campbell, for being a guiding force for justice in one of the most challenging political moments of our time. Thank you so much. Now, her accomplishments are many, and I certainly don't have time to mention them all now, but I'll mention a few in the domain of healthcare before I hand it over to the Attorney General for her remarks. So first, in the crucial area of reproductive justice, in 2023, Attorney General Campbell established a reproductive justice unit in the AG's office, focused on protecting access to reproductive and gender-affirming care, addressing racial and economic disparities in maternal health care, and working across state lines to respond to national attacks on reproductive rights. And just last year, the Attorney General's office played a critical role in protecting the interests of the Commonwealth's residents following the collapse of Steward Health Care. And this year, Attorney General Campbell, as I mentioned, has led coalitions of states fighting for SNAP benefits, research funding, and safeguarding access to gender-affirming and reproductive health care. And so the priorities and work of her office complement those of the HPC, and we appreciate our ongoing collaboration with the Attorney General and her team. And we're grateful for Attorney General Campbell for joining us, and we look forward to hearing from her today. So without further ado, Attorney General Campbell.
Thank you, and good morning, everyone. Thank you, Dr. McGregor, for that wonderful introduction. And also, frankly, having us start our day off with laughter. I think that is very important. You have to sustain your joy in this moment in time. And my middle name is Joy, so I just have no choice but to stand in joy
Yes.
every day and everywhere I go. So thank you. Delighted to have you as one of my appointees, along with Kevin and Marty as well. Thank you. And of course, you know Sandy is on my team and just in love with my Sandy. And then I have to acknowledge Toby, who runs, Toby, can you stand up, please? Unger? Who runs our healthcare bureau, who does significant work with all of you. So I'm grateful to my team and grateful to the entire commission. I can't tell you, it is a tough time to say the least, but I think Chair DeVoe said it best. We are blessed to not only work in Massachusetts, but to live in Massachusetts, the best state in the country. And I think when it gets hard, we have to remind ourselves of that fact. So delighted to be with all of you this morning and appreciate what you're doing along with the folks who are sitting in the audience. I'm grateful, extremely grateful. And every year, of course, I come here with the opportunity not only to testify, but frankly to engage and to express gratitude to each and every one of you. I would hope that you would bring that gratitude back to your teams and your organizations as well. Massachusetts, as you know, is known for having the best healthcare providers in the world. But we all know that care is becoming increasingly unaffordable for too many of our residents. From rising premiums to higher deductibles to reduced coverage, Massachusetts consumers are going to be paying more for their health care in 2026, and in some cases, getting less for their dollar. Right now, patients are making hard choices about health insurance for themselves and their families during open enrollment. Many are facing double-digit premium increases, and the rise in premiums is far outpacing growth in wages. As a result, many people will downgrade to less coverage or reduce other necessary household expenses just to keep up with the rising costs. This burden on consumers is a symptom, as you all know, of a larger systemic problem. Healthcare costs are rising at rates that far exceed our statewide benchmark. Today, as you all listen to the testimony from the community, clinicians, and industry leaders, I ask that you keep the patient impact of our healthcare affordability crisis at the forefront of your minds. Business as usual is not working. It's not working to curb the growth of healthcare costs, and patients are, as a result, are suffering. I am grateful that the HPC is kicking off today's agenda with the panel of community and clinician voices. This is where our conversation must be rooted in a year of unprecedented challenges for our healthcare systems and, of course, the patients it serves. I am deeply concerned, as all of you are, that millions of Americans who buy insurance through the Affordable Care Act may lose their healthcare subsidies, compounding our healthcare affordability crisis even further. We've also seen an onslaught of new federal assaults on healthcare access, particularly in our immigrant communities, and we are fighting back with every tool that we have. We filed a lawsuit against the federal government when they illegally tried to make certain immigrant groups ineligible for critical healthcare, education, and social service safety net programs. And so far, we've been successful. The court has blocked those changes from taking effect. We've also sued the federal government for illegally sharing personal health data with immigration enforcement authorities. A court ruled in our favor in that case, too. To supplement our litigation efforts, we're also fighting back with information and Know Your Rights trainings. We've released Know Your Rights guidance for immigrants, families, and communities so they know what they can and cannot do when ICE shows up in their communities. This includes specific guidance for Massachusetts healthcare providers about the rights of providers and patients and how they should respond to immigration enforcement action at a healthcare facility. We've seen the federal government levy hateful and horrific and unconscionable attacks on our transgender residents, including transgender youth, our kids, and gender-affirming care providers. When the federal government tried to intimidate these providers in stopping medically necessary care for transgender individuals under age 19, we sued them. And we released information from Massachusetts healthcare providers about the impact of executive orders and federal policies on transgender youth who are seeking gender-affirming care here in the Commonwealth. This care remains perfectly legal in our state. And when we see the federal government trying to scare our residents from accessing the health care they need, or our providers from providing the care to our constituents, we will fight back in every way we can. We have also seen federal attacks on our healthcare institutions through unlawful termination and delay of federal funding for medical research. Massachusetts is the medical research capital of the world, and we will continue to fight in court to protect that critical part of our healthcare sector. Indeed, our federal response has touched so many facets of healthcare, including funding for public health and reproductive healthcare services, and attacks on diversity, equity, inclusion, and accessibility initiatives. So our shared commitment to identifying and addressing these inequities in our healthcare system is more important than ever before. Black and brown Massachusetts residents continue to report significantly higher rates of healthcare affordability issues than other groups. That means they are disproportionately burdened by medical bills, foregoing necessary care due to cost, or spending a very high percentage of their income on healthcare. And the federal attacks we're seeing on our immigrants and insurance coverage only threaten to increase those disparities even further. Here in Massachusetts, universal coverage and access to care has been the North Star of our healthcare policy for the last 20 years. In a time when those principles are under attack, it'll take all of us to step up and do our part, and to do it in partnership and collaboration. Like I said, I am delighted to be here with each and every one of you. I know how hard you're all working along with your respective teams, including the folks who are sitting behind me. And I'll just end on this note. I know there are many folks who are frankly exhausted, maybe experiencing some burnout, who are mentally feeling anxiety, depression, fear, a whole range of emotions, including anger. But I think it's the time where we can look ourselves in the mirror and remind ourselves we live in Massachusetts. It's a blessing to live and work in the greatest state in the country. We are a small state, but we punch above our weight. We are Muhammad Ali. I feel like Muhammad Ali. We are punching above our weight every single day. And our leadership is what everyone is looking to. The best state in the country, they want to know, what are we going to do in this moment in time? And all states, including New York and California, will follow our lead. So delighted to continue that leadership on behalf of all of you and answer any questions you may have. Thank you again. And again, thank you to my appointees, Sandy and Toby, and the rest of my healthcare team who do tremendous work every single day. Thank you.
Thank you so much, Attorney General Campbell, for your service. And the Attorney General has said that she has time for a couple of questions from commissioners and us. Does anyone have a question? Please.
So
Good to see
thank
you,
you for your
Keith.
remarks. Good to see you. The Steward bankruptcy and its resultant disruption was sparked legislation, and we had a whole hearing about this last year. Private equity can provide really valuable capital, but their incentives diverge from patient health often. And so I'm curious about what is on your agenda for protecting patients and stabilizing our health system.
It's a big question. I first have to thank, I know Representative Lon and Cindy Friedman, Senator Friedman are here. We work in close collaboration with them and grateful for the legislation that was passed that would give us more tools to hold our steward and others accountable going forward. We remain concerned about equity and for-profit institutions taking over more parts of our healthcare industry, and the team is fully aware and looking at ways in which to combat that, especially when it increases costs and diminishes the quality of care of our residents. In addition, we are concerned about affordability, doing what we can in our part, and sometimes even putting out recommendations. I have to keep coming back to the report we did on ambulance cost in that system, and recommendations in there, and an opportunity to go back to those reports and not to have them just sit on a shelf, but to work with each and every one of you on tangible ways we can reduce costs for constituents, even if the federal government is stepping away. We're following everything happening with the government shutdown as well, and hopefully they get their act together. But also, of course, when it comes to the Affordable Care Act, as I mentioned earlier, we don't want to see premiums skyrocket or double. So we're doing what we can on the federal front in terms of affordability. In addition to broad issues around affordability, I'm actually confident that Toby is in this new role. The reason she took it over was not just to, as she would say, keep the trains moving on time with Sandy, but to look at ways in which we can look at the drivers of what continues to drive up costs under this affordability umbrella, and what are tangible things we could be doing in this moment in time to reduce those costs. It may mean we have to exercise some courage, be a little bit more bold, take a few more risks, revisit the benchmarks, question and conversation and more. And we're excited to do that. We're excited to play a role. We're excited to be a convening partner in this, whatever it takes on the issue of affordability. And then lastly, in terms of access, we've seen this quite a bit, obviously, in the context of the maternal health work that we do in partnership with all of you, as well as reproductive health care. Even before Dobbs, quality of care, access, and affordability were still an issue. When Roe was on the books. And so we're seeing that even in Massachusetts, you go to the central part or western part of our state, there are still gaps in accessing reproductive health care, for example, or gaps in the infrastructure to close the Black maternal health gaps that exist in Massachusetts and, of course, this country. We've put out grants and resources to be able to fund more community-based organizations who are doing meaningful work. But how can we have a real honest conversation about closing those gaps in other parts of the state, working not only with the legislature, with community-based organizations, and even using some of our tools to close these gaps, which of course still fall under the accessibility issue and affordability issue. But I'll end with this: make folks in those communities feel seen and heard, and that our action steps are responsive to issues they've been raising up for years. So I'm excited to deal with disparities all across the state, but especially in those communities that have often felt left out and left behind. I could go on and on, but I don't have that much time. Thank you, Keith.
Thank you. Yes. Question?
Yes, thank you, Attorney General Campbell. So just one follow-up question, somewhat related, and it's regarding what you've been hearing from residents of the Commonwealth with respect to recent federal funding cuts and other healthcare provider disruptions. So what are some of the main concerns that you've been hearing from constituents in general? And what are some of the highest priority needs that you've identified? And then I have another question, which is, how can all of us really kind of contribute? Because I heard your call to action, and I certainly don't want all the work to be on your plate, because a lot of it is on your plate. How can the rest of us contribute and play a meaningful role right now?
I appreciate the questions. I will first start with, it's similar to Keith or what was even remarked earlier. People are absolutely concerned about how much they are spending from their household budgets on healthcare. And that's not just premiums, co-pays, It's also, if you call for an emergency situation involving an ambulance and then you get the surprise bill that you didn't expect. So they are absolutely concerned about just how expensive healthcare is when their wages are not going up or keeping pace. They're concerned about the quality of care. We hear that too. I went to a provider and either I was not heard, I didn't feel like I was seen, I didn't have a great experience. So just that interaction, which I think institutions are working on every day to improve, but just the quality of care, not just how we would traditionally think about it, the experience as a whole of entering a community-based organization or a hospital that's larger in scale. What was that experience like for them? Some have pleasant experiences, some do not. In addition to the quality and affordability issues, access, as I mentioned earlier, and then the racial disparities. I think we've been talking about the racial disparities for a long time, Codman Square included, right? That was in my district as a city councilor. And I think folks are saying we are not only the best healthcare system in the country, and that is in the broadest sense, even the infrastructure that we have, including at HPC, other states are jealous of the regulatory framework that exists here to hold folks accountable, to put forth great ideas. We are the best in the world. And in my new landscape of the federal government, that's not just in the traditional healthcare space. It now involves global security, global reputation, of our state, because we were that good when it comes to healthcare, the healthcare system in the world, the biomedical research, the innovation. I didn't even get how significant Massachusetts was in the international landscape of all things healthcare in this broadest sense. And so how do we make sure that reputation that we take such pride in, that every single person, the average consumer that we serve on a regular basis, feels the same, that they are celebrating the system just as much as we are, that they know we're addressing Black maternal health disparities so that anyone who is going to give birth that looks like us will have the best experience and the best outcome. They know that we're taking on affordability. They know we're taking on accessibility. And they too are taking pride in our systems. They too are taking pride, of course, in our global reputation. Two other points I will mention because it happened recently. Of course, waiting, emergency rooms and just the waiting and the bed situation, same in the context of mental health. And then lastly, small businesses. I was just in Newton last week, and there was a small business owner who stood up and said, and I think she spoke for some others, I have dealt with 2 insurers, and right now my employees don't have coverage because of certain dynamics with insurance companies who are in a difficult spot as they're negotiating with various providers, given what's happening at the federal level. So I wanted to lift those up. And then lastly, what can folks do? One, I will just say, I think it's important to stress that you are enough as a person in this time. I think people are discounting their humanity. People are feeling under threat and attack to their humanity and who they are, whether as an immigrant, a person of color, as a Massachusetts resident who lives in a blue state. We're all under attack. Even those folks who support our president and I say we do this work regardless of your political affiliation or demographic. The attacks, whether we like it or not, continue to come, especially in the context of SNAP. We're seeing that crystal clear. So I've been reminding folks that you yourself are enough. And 2, that what you're doing is enough, because to your point, it's all collective. So if you woke up this morning and exercised some courage, got yourself dressed, did your hair, your makeup, found an outfit, put it on. I think everyone came in clothes, thank you. That is an act of resistance in this moment in time. When we think about just how difficult this time is, it is unprecedented. We've never seen anything like it. That's an act of courage. That is enough. If you can do a little bit more, you show up and you lead your organization. You encourage your team members and employees to keep fighting the fight. You encourage them to take time for themselves and their mental health. You offer some flexibility in your job so people can work remote if they filed a brief at 11:55 at night. All of that should be counted as enough. You go to a rally, great. You vote, great, right? You exercise civic engagement, wonderful. You help us with some of our lawsuits. Our briefs aren't just coming out of nowhere. It's people and organizations on the ground that are informing what we file. We're working with our state agencies, including our incredible new secretary and his team, on all of these lawsuits all really important and significant. So it is a collective response. I think I just want folks to know, while we may be doing a lot more of it because we have the most impactful tools, namely our litigation tool, each of us is doing our part. And if we were to do a little bit more, or those who are doing absolutely nothing, maybe they're just sleeping in bed, wake up, find your joy, we're all here to support you, then the collective is what will win the day. It will be a long road ahead, there's no doubt about it. But I think it's an opportunity to reframe what are the opportunities to do something new, innovative? How can we actually address affordability in a greater way than we ever have before? The same thing with accessibility, the same thing with diversity in our provider pipelines, the same thing working with our higher ed institutions. I just see this as an opportunity if we are able to reframe. And the only way we reframe is if people really feel as though they are enough and they are doing enough. So I'll end on that note just to say thank you all. It's an honor and privilege to be your Attorney General, but it's not about me. It is about this great Commonwealth. It is about all of us doing our part, and me representing the voice of close to 700 folks who work in my office. And that does not count my board and commission appointees, all of us working as a team to really get something done that is meaningful, impactful, not pie in the sky, but substantive that people can wrap their head around and be proud of all of us, just as proud of all of us of what we're doing here in Massachusetts. Thank you.
Thank you so much, Attorney General Campbell, and your words challenging us to do a bit more and to think in terms of innovation and new approaches is a perfect start to our day. And also challenging the joy, which, interesting, it's your middle name, and the fighter of Muhammad Ali.
That's right. I'm doing a lot of recordings these days with a frame of Muhammad Ali behind me.
Yeah.
You'll start to see more of that as I'm also trying to work out to look like Muhammad Ali in his prime.
Yeah.
Ongoing,
Yeah, yeah.
but
Good.
delighted
Yeah,
and grateful to each of you.
I like the combined image. I'm going to really hold that in my mind. And thank you so much for
Thank
your
you.
reference to the 700 people in the Office of the Attorney General. We are really appreciative of your ability to both attract and retain the best talent, and certainly in Sandy and Toby, but also many others.
Thank you.
So thanks again for
Thank
being
you all.
here today.
Thank you all. Have a wonderful day. Thank you.
A wonderful start to our hearing. I'd now like to turn things over to our Executive Director at the HPC, David Seltz, who's going to walk us through our agenda and plan for the day.
Great. Thank you, Chair DeVoe. And thank you, Attorney General Campbell, for joining us today and for all that you do and for inspiring us to think courageously and innovatively as we think about solutions today. And while Governor Healy wasn't able to join us today, we're grateful for her leadership on efforts to promote healthcare affordability in Massachusetts, and we're really thrilled to partner with her team to advance that work every day. Thank you, Mr. Secretary and Commissioner, for being here on behalf of the Healy-Driscoll administration and for serving on the HPC board. Good morning, everyone. I am thrilled to welcome you to the HPC's annual healthcare cost trends hearing. This is our 13th annual cost trends hearing. Thank you for attending or tuning in. As Chair DeVoe said, alongside welcoming all of you in person, we are live streaming this event on our website and YouTube channel, and we are encouraging viewers to engage with us on social media. We have the hashtag CTH25 going. I also want to express gratitude to our friends at Suffolk University for hosting us here at the annual cost trends hearing. This is our 10th time that we've been here at Suffolk. We love this venue. Thank you to the team here for accommodating us, all of our unique microphone and video needs. You guys are really the greatest. We have a full and fantastic agenda today. But first, as Deb mentioned, this is the first hearing since the passage of historic healthcare cost laws that passed earlier this year, chapters 342 and 343 of the Acts of 2024. These laws represent the most meaningful advancement of Massachusetts healthcare cost containment laws since 2012. And additional kudos to Speaker Mariano and Senate President Spilka and Healthcare Financing Chairs Lawn and Friedman, who are here with us today, for working to pass these laws before the end of the legislative session. Many of the most important provisions of these laws are directly responsive to challenges that we have identified and conversations that we've had at previous cost trends hearings. The need for greater transparency in prescription drug costs, greater market oversight of private equity investment in healthcare, the need for revitalized health planning, the imperative to strengthen primary care, just to name a few, are all reflected in these new laws. At the Health Policy Commission, we have been focused this year on standing up 2 new offices to execute on much of this work. The Office of Pharmaceutical Policy and Analysis and the Office of Health Resource Planning. These 2 new offices will play a critical role in identifying new challenges, opportunities, and data-driven policy recommendations to improve the performance of our healthcare system. Recognizing that many different healthcare market participants have an important role to play in our healthcare system, and that discussions such as this at the cost trends hearing should include more of these voices, these laws also expanded the number and type of entities required to provide public testimony to the HPC and to the AGO. These new entities, shown in orange on the right, include pharmaceutical manufacturers, pharmacy benefit managers, significant equity investors, real estate investment trusts, and management service organizations. And some of them will be providing testimony in person here today. But to complement the live testimony that we hear today and ensure that we're getting a broad range of different perspectives from all these different organizations as directed by the law, we also require a select number of entities to provide what we call pre-filed written testimony. And so this written testimony is a public record that's generated by the annual hearing, and it helps inform the work of the HPC and inform the work of the public. So this year we identified 50 different organizations and asked questions on a range of topics as shown on the slide here. And all of this written testimony is available on our HPC website. So I just wanted to highlight some of the key themes that we heard from the written testimony. The key themes that we heard from the written testimony really align well with the themes of today's hearing. Uncertainty and concerns about federal policy changes was noted by a number of organizations, specifically impacts on healthcare affordability, access, coverage, and equity. Many organizations submitted concerns that these changes would only exacerbate existing challenges on these dimensions that already existed in Massachusetts. Many organizations wrote about the need to continue to focus on affordability, something that we just heard about from the Attorney General. And some of them writing that we had reached the point of an affordability crisis in Massachusetts. Organizations suggested that we should focus on affordability both at a system level, such as by recommitting to the principles of the healthcare cost growth benchmark, by rebalancing the healthcare system to shore up primary care, by addressing administrative complexity, by shifting care to lower cost settings, for example, and by addressing affordability at a patient level, such as by addressing prescription drug costs and high deductible health plans. My main takeaway from all of the testimony is one of consensus. Healthcare organizations, big and small, from across the state, representing a range of different perspectives, by and large agree that major challenges, both existing and new, exist in our healthcare system, and that new thinking and systemic changes are needed because the status quo is not working. Or as the Attorney General just said, business as usual is not working. So on this final slide, here are just some quotes underscoring these themes pulled from the written testimony. From point 32, as we continue to navigate the challenging environment created by evolving federal policy changes, It is time we move forward with a real affordability agenda. And then finally, from C3, Massachusetts has been a national leader in health policy thinking before. We can and we must do it again. Our panelists and presenters today will further outline the challenges we face across the healthcare system, provide insights on strategies and collaborative solutions, and I hope offer new commitments for collaborative action that will help make Massachusetts that national leader once again. I want to thank Chair DeVoe and the commissioners for help leading today's discussion. And I would now like to turn it over to HPC Commissioner Sandra Cotterell to introduce and set up our first panel of the day. Prior to her appointment by Governor Healy, Commissioner Cotterell recently retired as the CEO of Codman Square Health Center. She brings a deep understanding of community-based primary care and the importance of wellness and addressing social determinants of health to the work of the HPC. So Commissioner, over to you.
Thank you. So we'll now welcome the members of our first panel, a call to action, community, clinician, and employer voices on current healthcare challenges. This panel will provide a platform for community voices, including clinicians, employers, and advocates, to share personal experiences of the impact of rising healthcare costs, barriers to access, and persistence inequities in care and outcomes across Massachusetts. This panel will help frame key themes and challenges that will be discussed throughout today's hearing. Their testimony will serve to ground our conversations in lived experiences, reminding us that policy impacts our businesses, healthcare institutions, healthcare workforce, and most importantly, how policy impacts the lives and health of our residents. These panelists represent a diverse range of experiences and sectors within our Commonwealth. Their insights will help illustrate how the challenges in our healthcare systems affect individuals, families, businesses, and healthcare workforce. I'd like to note that today they have volunteered their time before us here today. They were not pressured into testifying today, so their willingness to be here and share their perspective is greatly appreciated, and we are grateful for their commitment and engagement. So on the panel, we have Dr. Catherine Gherkin Barnett, Vice Chair of Primary Care Innovation and Transformation, Boston Medical Center Department of Family Medicine. Dr. Elelliana Stenson, Emergency Room Medicine Physician, President of New England Medical Association. Liliana Patino, Senior Director of Community Impact and Development, Elliott Community Human Services. Julie Freyer, RN, Quality Improvement, Edward M. Kennedy Community Health Center. And Neil Abramson, Business Owner, ECI Consignment Stores, Leominster, Massachusetts. So we'll start with Neil Abramson.
Good morning. Thank you for having me here today. I really appreciate it. ECI Stores. Our flagship store at Cutie Patooties in central Massachusetts is now in our 28th year, employing over 30 team members with an average tenure of 6.5 years. Not what you think of, really, when you think of a retail job. The stories I'll share with you today are all true. Anyone that knows me will tell you I'm just not that creative enough to make them up. But let me be clear about one thing. I share them not to elicit sympathy, but to evoke action and change. Yes, change that Massachusetts business and families not only need, but deserve. I grew up in healthcare. I'm the oops baby of 4. It's only weird when your aunts and uncles talk about it at a family gathering. But I grew up behind the counter at my father's pharmacy in upstate New York. Okay, he was the town pharmacist. He was the community driver. He was the connector in our community growing up. And I would get even dropped off there on the school bus every day to work, filling out health insurance forms. When you filled them out by hand, pen and paper, and mailed them in. So I have a lot of long-standing history with healthcare. You may think of resale and consignment stores as just another store, but resale and consignment stores sit at the very heart of every community they're in. They're not just another store. When you walk into a resale store, you're walking into the living rooms and closets of that community. Resale stores like Cutie Patooties are the connecting points of our communities, meeting our customers where they are, in store, online, at the curb, and everywhere in between. Because that is small business putting people first. I was incredibly proud 15 years ago when we were able to start offering health insurance as a benefit for our family of employees. Not just insurance, a robust plan with all the bells and whistles. Yeah, it was a little bit of a stretch, but we do that in business. We stretch. We stretch our team, we stretch our resources, we make things happen. But it was incredibly gratifying to be able to provide that for our team. The single mother that works for us so that she could have that for health care for her family, good health care. But I know some of you here like to go to Panera for lunch, and healthcare has become like lunch at Panera. It's a pick too, and there's no getting around it. When you go and access healthcare these days, it's pick two. Your costs either hit the copay, the deductible, the fancy healthcare cost sharing term, or it's just not covered, and it's always pick two. It's not pick one. Businesses like ours and our employees are spending more and getting less from their healthcare. Small business is under attack with an average price increase of 11% the last 2 decades, actually. Sad. But fear not, Massachusetts is shooting for above average. In 2026, our increases are projected to be over 13%. But it's not just cost. Cost is one aspect. It's a huge aspect. It is a debilitating point of care. Earlier this year, I had to have surgery. It is what it is. We all meet the need for it, and cancer does not discriminate across race, income, or anything else. And I had a tumor removed. Not a big deal. Happened really fast. Found it, did it in surgery. That was great, quick recovery, relatively speaking, and back at it. What wasn't great was when I got hit, when the bills started coming in. I didn't know in advance that I was going to get, just from that one day, not even the follow-up care or the pre-care, over $4,000 in bills to pay. And that was a challenge, okay? People don't have, whether you're a business owner or a family that works for me, they don't have an extra $4,000 just sitting around waiting for that. The scary wake-up call for me wasn't as much the $4,000 as it was knowing that if my employee had to have the same procedure, if they told my employee that it was going to cost them over $4,000 before they had the surgery, they wouldn't have had it. The barriers to health care are huge. In the next room to me, okay, any of you that have had surgery, or there's so many healthcare people in here that are incredibly smart, know that when you have surgery, they don't let you drive there. I'm a lifelong driver. I love to drive, even on the crazy roads of Massachusetts, but they don't let you drive there. Okay, so they tell you, you have to have a ride. You can't drive to your own surgery. The person in the next room from me was told that too. Okay, but they didn't, and they solved that problem. They walked to the hospital. They walked to the hospital, okay, 3.5, 4 miles from their home. They walked to the hospital because they knew they couldn't drive home. Why did they walk to the hospital? Not because they didn't have a car, but because they couldn't afford the parking at the hospital. Okay? They could not afford the parking. That was a barrier to care. That was a barrier for that family, just the parking. Okay? They obviously weren't going to let him walk home 4 miles. We got a room here of incredibly smart people, doctors, educators, PhDs. I don't have a fancy degree. I'm just a business owner. But I do have a PhD in hard knocks. I'm passionate, hardworking, and determined. But all of that knowledge can't help me make sense of my health plan. This is my renewal book, okay? This is the summary book, not the big book, not all the appendixes, okay? The only page that I understand in this book is how much it's going to cost me. How much it's going to cost me. I don't understand the rest of it, and I'm a smart guy. Okay? This is not a Republican or Democrat issue. This is a public policy issue. And more than that, it's a good neighbor issue. It's time we started caring for our neighbors more than we do healthcare as usual. Massachusetts needs to look at itself to not only design healthcare that works, but to be the leader that other states look for. Let's be real. Recent events show that the federal government isn't coming to save us. If we want to fix healthcare, we have to be the change. In our store, we have a saying, WWMCW. WWMCW, what would my customer want? We ask ourselves all the time, if we're answering how we have our policies, what we do for our customers with that in mind, we are winning. We are doing the right thing. We need everyone in healthcare to be asking this question. We're their customer. When you log into my chart, okay, and you see scary words next to your blood work, and their doctor tells you, yeah, not my lane, I'm going to send you to a hematologist. They'll see you when they see you. In 10 months or longer, you go to the only doctor that you have access to, Google. Google's not a doctor, but it really scares the heck out of you. And that's where people are going for care. That's where people are going for care because they don't have access to their doctor, because they can't go to it, because the policies they have prevent access to care or cost too much money. Have you spent the night with someone recently in the ER? I know the Attorney General talked about access in the ER. I had that opportunity a couple months ago, okay? And you know it was bad when my adult child said, I need you to take me to the ER because I'm not the touchy-feely one. I'm not the one that people call for that, okay? But their doctor wanted them to go to the ER. And, you know, they got their room, you know, the bed in the hallway. The room next to us had to make the choice of staying by their loved one or leaving them to go to the work so they didn't lose their job. Have you ever gone to the pharmacy to pick up a prescription for your mother-in-law? And they tell you, or retired senior citizen on a fixed income, have you gone there? Do you really want this? Do you know how expensive this is?
Thank you.
You know, give me one more second.
Yep.
In business, I value relationships. I have with my team, the relationships we have with our customers, the relationships we have with our partners. I thought our insurance carrier valued our relationship as much as I did, but letters like the one I received telling me my doctor doesn't matter, my relationship doesn't matter, okay, telling me they've assigned me another doctor because they can get a cheaper price, okay, doesn't matter. We have a saying in retail that inventory shouldn't have birthdays. Let's be real. This hearing is a birthday for the cost of healthcare. Okay? I wasn't invited here last year. I wasn't invited here any of the previous 13 years, okay? But we shouldn't be celebrating the cost of health care, okay? We should be finding solutions to it that make it more affordable and give greater access. I came here, I actually flew in last night back here to Boston. I got in about 1:30 this morning from holding my sister. Holding my sister while she buried her son, who suffered from mental illness, didn't have the care he needed, and committed suicide. I held her and buried my nephew with her. Families shouldn't have to do that. People should have access to care. We should provide that. We deserve better. The people of Massachusetts deserves better. Small business deserves better. Thank you.
Thank you, Neil. I'm sorry for your loss.
Thank
you. Julie?
Good morning. I am the Quality Improvement Nurse at Kennedy Community Health, the only community health center in Massachusetts currently funded under the HARP BP investment program. I'm also the only nurse you'll be hearing from today, which is an honor. Thank you for having me. It amplifies the frontline perspective that's sometimes sidelined in these rooms. For over 20 years, I've dedicated my career to caring for marginalized patients. 16 of those years were caring for incarcerated women, navigating a system riddled with gaps. And it was there that I truly got to know my patients, not their symptoms, but the deeper layers of their lives, their unspoken struggles, and their unique needs that shaped their healthcare journey. Those insights followed me to Kennedy Community Health, where I've built equitable, scalable programs with empathy at the core. You've invited me here today to speak plainly about access, affordability, and equity, with a spotlight on pregnant and postpartum patients. But to speak plainly, I must speak personally, because the crisis we fight isn't just in the data, it's the lives of the mothers that we care for and in my own. My story is that I had no risk factors, I was healthy, I was active, and then I had a placental abruption. My last thoughts before general anesthesia were, will my daughter have a mom, or will I have a daughter? I gave birth without knowing it, without being part of it. We both survived, but I also lived 3 minutes away from the hospital. And then this wasn't the end. Weeks later, my blood pressure was 210/110, another ER visit, multiple visits to the follow-ups, 3 blood pressure medications for 2 years till I could come off of them, time stolen from my children, and all laced with anxiety. I had insurance, I had knowledge, and I had proximity to care. One of the leading causes of placental abruption is maternal hypertension. The cost of my care alone could have funded 1,000 remote blood pressure devices. Now, imagine a mom that's an hour away from OB care, or even a half an hour. Transportation barriers, moms who can't miss work for their postpartum follow-ups. Community health centers serve over 1 million patients in Massachusetts annually, many at risk for hypertension, heart disease, stroke, and hypertension. Our nurse-led self-monitoring blood pressure program, or SMBP, began in 2021 through a HRSA-funded grant. We partnered with a vendor using cellular blood pressure monitors, so there's no Wi-Fi needed, no barriers for patients without internet. We integrated our dashboard seamlessly into our EHR. Every reading flows directly into the patient's chart. There were challenges. One of the biggest ones was the vendor didn't have a large size cuff. That was a problem for me, for our patients, but I pushed and the vendor listened. I collaborated with them as they developed a larger size cuff, and we didn't stop there. They asked for feedback on the on-screen prompts. I was able to get those prompts down to a 4th grade reading level and incorporate icons and pictures, because the lower the reading level, the more patients you're going to reach, and that's equity. It's a cuff that fits, and it's a patient that understands. We began enrolling patients in 2022. Since then, we've had a 16% increase in blood pressure control. Currently, 72.6 of our patients have controlled hypertension. This year, the larger size cuff has finally launched, and thanks to the HPC Heart BP funding, we began rolling it out last week, beginning with our pregnant and postpartum patients. We're enrolling all pregnant patients with any risk factors. We're also keeping them enrolled 12 weeks postpartum. And then if they have continued hypertension, they're being transitioned into our ongoing SMBP program. We don't have maternal outcomes yet, but I'm confident they'll be positive. We don't treat by insurances at community health centers, and we don't turn anyone away. If you have hypertension, you're going to get a blood pressure cuff for free. But affordability crumbles without sustained funding, and time again, we secure these grants for vital programs only to watch them falter when the funding fades. My goal was to make our SMBP program sustainable, and it is, through nursing reimbursable visits. But the demand is growing. We urgently need staff to expand without compromising care. Scaling up means staffing up, and that's not always easy in community health centers. When grants end, community health centers ration, create wait lists, or shutter programs completely. In community health centers is where prenatal care begins for Black moms, undocumented moms, moms facing maternal morbidity 2.5 times higher than white moms. It is the entry point for high-risk groups, and we are coordinating preventative care with remote monitoring before hospital-level crises. But what about if we also had community-based educational programming integrated with remote monitoring, childbirth education classes, culturally appropriate in multiple languages, to cover breastfeeding, newborn care, infancy PR, postpartum health, sibling support, how to spot postpartum depression before it's a crisis, and how to ask for help without shame. Because knowledge just isn't power, it's prevention. So I ask, shouldn't every community health center in Massachusetts have a nurse-led, cellular, self-monitoring blood pressure program to protect every heart statewide? It's not novel, it just works. This is proof, this is equitable model that we can set for all, because nobody should perish from a cuff that doesn't fit, from a grant that fades, and we certainly shouldn't wait for a $100,000 bill before we say we could have done better. Thank you.
Thank you.
Good morning, and thank you for having me. My name is Liliana Patino, and I am a mental health clinician. I am actually very fortunate to lead a community, a family resource center in the community. Prior to my experience as a clinician, I was a home visitor. I work with early intervention. I work as a clinician at an outpatient clinic, school clinician, and then director of a program. I've been invaded with some of the changes in the state, including the CBHC, the CBHI changes, and definitely making sure that families understand those changes in the community. I think it's very important for us to acknowledge the systems are extremely complicated. I think that all of us have a master's degree on trying to understand how to complete a registration, how to find a pediatrician, or how to refer someone to a service. And I think that is something that we really need to focus. How can we make systems and accessibility a little bit easier for regular people? As we heard already in the panel, understanding a manual is pretty much impossible, especially when you are dealing with all of the other factors, such as mental health needs, such as physical needs, such as poverty, lack of housing, or lack of food. So for me, that is something that it will be extremely important for us to start thinking about it. Access. And as we heard at the beginning, finding appropriate care is almost impossible. Finding a therapist with language accessibility is almost impossible. So I will say that I'm always the unicorn in the room. Where is the information going? I think that lately that is something that many people in the communities are struggling. one of the complaints that we hear constantly is, I complete applications, I complete applications, I complete applications. Where is my information going? And especially with the changes with the new government, that is something that many families are struggling. Not only families that are here undocumented, and I really want to say that, families that are here legally are experiencing a lot of stress, wondering where their information is going and how their benefits are going to change. Delays in services. Finding a PCP, finding a pediatrician, finding any kind of access is extremely difficult. And what we see is that there's no continuing care. There's a significant increase in families going to the emergency room, which at the end of the day increase costs not only for the families, but increase costs to the state. Not having that continuum of care is going to decrease the well-being of the family. Increase in coverage, definitely delays in treatments, emergency department, and other costs make families almost impossible to receive services. Behavioral health is even more complicated because, again, the idea that you need help, we all know, is really hard to get there. And then trying to navigate services is extremely difficult. We're still adjusting to the idea of the CBHCs. We're still trying to understand, I call it the urgent care for mental health, but we know that a lot of these CBHC agencies are not really equipped with the linguistic capacity and the cultural humility to understand patients at the level that they need. In addition to that, I think that we have to focus on the workforce. And I really want to say these out loud. Community agencies are overwhelmed. Community agencies are trying to support families, individuals in a way that they do understand. So for community workers, trying to simplify the knowledge that we are receiving from the state can be overwhelming. I think that community workers and local agencies, they need extra support. They need extra workers, they need extra training, and they need anything that you can do for them in order to do the work even better. Community agencies are not only dealing with the mental health or the physical need, but they are dealing with all the needs that a family might have. When a family comes to see their PCP, their mental health clinician, or the healthcare worker, or their nurse, they're going to be talking about the lack of food. They're going to be talking about housing insecurity. Schools are calling us because kids don't want to go to school. They are afraid to be out. So those are some of the things that we see in the community. Definitely the increase of fear, the increase of anxiety, the PTSD that is coming back for many families, not feeling safe, not feeling welcome, and definitely being overwhelmed. Thank you for having me.
Thank you.
So my name is Elelliana Stenson. I'm a board-certified emergency medicine physician currently practicing at Boston Medical Center. Formerly employed at Kearney Hospital, which was part of the Steward system, so I've been through the changes and loss of resources and understand what these cost challenges can cause on healthcare systems. And I worked there for 7 years. I served on several roles at Mass Medical Society and currently serve as the president of the New England Medical Association. In my 15 career as a physician, I have focused primarily on working in underserved communities intentionally and doing work in the policy space and being an advocate for people who don't have a voice. So advocacy and policy is my passion, and I'm happy to be here before you to share my experience, not only as a physician, but also as an advocate and community member of the Roxbury neighborhood. I'm also from Georgia, originally from Alabama, and I say that intentionally because I bring a different perspective, having worked in those areas in very different healthcare infrastructures. So I'm extremely privileged to be able to work in Massachusetts, where people actually genuinely care about the community and the state in which we serve. And for this, I am grateful to be here. I get to work among people at Boston Medical Center that truly care and strive to always do the right thing. And I also want to mention that I am speaking on behalf of myself today and not for other organizations that I may represent. Having come from the South, I am starting to see the seams of our healthcare system come apart, and I am very concerned. I'm starting to see similar gaps that I once experienced back home, experiences that patients back home often didn't get to interact with their healthcare system the way people here do. And as emergency physician, we are the front door to the community. And in recent weeks to months, I've been seeing more and more patients come into my emergency department unable to afford their medications. And these are basic medications, diabetes, blood pressure, cardiovascular meds. But fortunately, we're able to provide them meds to beds and services that other facilities may not be able to provide. In more long term, over the past few months to almost year, we're starting to see more and more people flood into the emergency department, unable to be seen by their primary care physicians. So we're starting to serve that role for the primary care space. Unfortunately, we don't provide continued continuity of care, so we oftentimes see these people returning to the emergency department for basic chronic disease management. My fear, their diseases will worsen over time. And also my fear is that this will lead to higher costs, delivery of costs of care that we're giving. As you know, emergency medicine services are very pricey. Not my fault. I also recognize that being able to work in this infrastructure provides support to people to get their medications, whoever shows up at our door. So we know that people who fall through the gaps are going to get services. They may not get the preferred chronic disease management over a long period of time, but they will have access to some sort. And with rising costs, this will not only impact affordability to vulnerable communities, but as mentioned, it will also have rippling effects on the business community, and overall economic well-being will be in jeopardy. And the high costs will also open the door for more for-profit institutions to try to enter into Massachusetts, and we all know how that ended before. It'll also drive more disparities among more vulnerable communities, which will reverse years of work that we've been putting in here at the Commonwealth. I'm also afraid that as the rising costs of premiums may present over the years, we'll start to see younger people opt out of healthcare insurance, which means they'll forego and delay care. They'll start to show up in our emergency departments. In addition to that, as Attorney General mentioned, we're starting to see longer wait times and higher volumes in emergency departments around the Commonwealth. And with this, we're going to see more and more people in those wait times increasing. We'll start to see sicker people as they delay their care, and this will be more admissions to hospitals and fewer bed availabilities for people who actually need care. And then because they're delaying care, it'll also require more specialty services that could have been avoided in the first place. I am also very privileged to be at Boston Medical Center because we also have a lot of social services that I'm afraid that with rising costs in care could also impact the services that we'll probably have to reduce over time, and how the infrastructure of my current facility will not be able to continue to maintain other services that we provide, such as meds to beds, substance use services that we're privileged to provide at our facility, as well as rapid referrals. We'll have, and also what I've seen in other facilities is reducing specialty services, which I'm, just from prior experiences, always weary of potentially losing services that have been previously available due to rising costs that we'll no longer be able to provide. In addition, the one that's near and dear to my heart is worsening workforce shortages that could potentially result from all of this, as we'll probably start to see more burnout as volumes increase, wait times increase, and having people opt out of entering into medicine and seeking other careers. Now, we will continue to provide life-saving care, but will not be able to address these issues of financial burden. So I'm happy to be here and answer any questions that may come.
Thank you.
Good morning, commissioners and colleagues. My name is Catherine Gergen Barnett, and I'm a family medicine physician. For the past 20 years, I've had the honor of caring for patients at Boston Medical Center and training the next generation of physicians. The words that I'm sharing today are shaped by the stories of my patients and the direct insights I have had from my decades on the front lines of primary care. And while these are deeply shaped by Boston Medical Center, I'm speaking today in my own capacity and not as a representative of BMC. Serving as a family medicine physician is a gift. I have cared for patients as young as a few weeks old, whom I've cared for while in utero, multi-generational families, where I learned the family history of illness and strength and love and trauma, not just from questions asked, but through my care for each member of the family. I have patients whom I've shepherded into hospice and those who have crawled back onto the shores of wellness from illness. Practicing at the largest safety net hospital in New England poses its own set of opportunities and challenges, but until recently, it's been a deeply rewarding profession. However, the path to providing high-quality, whole-person primary care built on continuity and trust is in grave danger. Today, I would like to speak to two of the gravest dangers facing the health of citizens of Massachusetts. The first is access, payment, and burnout in primary care, and the second is the looming crisis of Medicaid enrollment. As many of you know, studies consistently show a relationship between better primary care and improved health outcomes, including lower all-cause mortality, heart disease mortality, stroke mortality, infant mortality, and increased life expectancy. However, access to this foundation of health is crumbling. In Massachusetts, the percentage of residents with a usual source of care has dropped from 88% before the pandemic to just 83% in 2023. And as my colleague and new friend, Dr. Stenson, has alluded to, that means more in the emergency rooms. Wait times for new patients have soared, now averaging 63 days in Boston, among the longest in the country. These gaps are not distributed equally, as we've heard. People of color, those with Medicaid, and low-income residents are the most likely to lack consistent primary care relationships, precisely the people who benefit most from longitudinal, preventive, and trust-based care. Primary care further suffers from the economics of undervaluation, where only 6.9% of total healthcare spending in Massachusetts goes to primary care. This is a fraction of what is needed to keep people healthy and prevent expensive downstream care. Systems investing 10 to 12% in primary care deliver better outcomes and lower total costs. Yet our fee-for-service structure continues to undervalue relationship-based primary care. It rewards volume over value, visits over continuity, and throughput over trust. I've witnessed firsthand talented primary care colleagues with years of wisdom leaving the workforce early, heading for an early retirement, a more lucrative position not involving clinical care, or concierge practice with reduced scope. I've also trained many talented residents who leave some of their primary skills behind, deciding instead to specialize on the higher paid procedures in order to make ends meet after the high tuition of medical schools. My direct experiences mirror what we see in the statistics of the Commonwealth. More than half of Massachusetts primary care clinicians report burnout, and the top causes are all too familiar: administrative burden, EHR overload, unrealistic productivity demands, and the moral injury of knowing what patients need but not having the time or systems support to provide it. 1 in 3 primary care clinicians plans to reduce hours or leave the workforce within 5 years. If we want to protect access, we must protect the people who deliver the care. I'm extremely grateful to Senator Friedman over there and her tireless advocacy for primary care, and the championing by Governor Healy for primary care for Massachusetts and Secretary Kiami. I'm also grateful for the creation of the Primary Care Access, Delivery, and Payment Task Force, spearheaded by the HPC, to define services, create data, set spending targets, propose payment models, and improve workforce conditions. But this work is far from done. Compounding the fractured delivery of primary care is a looming crisis of profound losses in connector care coverage in 2026 and mass health coverage in 2027. Blue Cross Blue Shield Foundation and the Urban Institute recently reported the estimate number of people who will lose Medicaid coverage in Massachusetts. It will range from 141,000 to 203,000. I know that behind each of these numbers is a human with a story, a family, and a community. When I had patients lose Mass Health in the unwinding of the pandemic coverage, I saw the direct, profound impact on their health and the health of their family. I penned a piece for the Globe sharing the story of one of my patients, a middle-aged gentleman who, when I first met him over 10 years ago, had undiagnosed diabetes, high blood pressure, anxiety, depression. He established primary care with me, and we worked to find creative solutions to increase his physical activity, healthy foods, sleep, and new medications in his life already complicated by multiple jobs to support his family. Slowly, his physical health and mood improved. Over the years, however, he started to miss appointments, and when he did come, his diabetes and blood pressure numbers were high. Each gap in care was one when he had fallen off the Medicaid rolls and was not able to get access to his medications or to care. Each time, we were able to assist in re-enrolling him, getting medications delivered to his home, ensuring he had the support he needed, both physically and emotionally. However, these long lapses of high sugars and high blood pressure took a massive toll on his body, and his kidneys deteriorated to the level that he is now on dialysis several times a week. His insurance churn left him physically and emotionally vulnerable and financially strained, and has probably been far more costly to our state and country than if he had been able to maintain his Medicaid coverage. His story will be more common than not if we sit aside and do not act immediately to address the loss of Medicaid for our state's most vulnerable. We have done hard and heroic things as a state, and have learned many lessons the hard way, most recently during the pandemic. Kudos to leaders like Amy Rosenthal, who deployed Healthcare for All and developed a roadmap for state-funded COVID vaccines, as well as Medicaid redetermination. We have the tools and expertise we need, and we do not need to reinvent the wheel to help the citizens of Massachusetts to continue their Medicaid coverage. Here in Massachusetts, where we pride ourselves on universal coverage, this moment tests our values. We must ensure outreach, assistance, and policy flexibility so no one falls through the cracks. The path to a healthier Massachusetts requires 5 urgent commitments. 1, invest at least 10 to 12% of healthcare spending in primary care. Treat it as an infrastructure, not as an afterthought. 2, expand value-based and team-based models that support clinicians and patients alike. 3, reduce administrative burden in primary care by streamlining and simplifying the number of value-based metrics. 4, improve the pipeline of primary care physicians by adopting a loan-free medical training path for those committing a career in primary care. And 5, protect coverage continuity for every resident in Massachusetts as we navigate the Mass Health work requirements. Perhaps, while none of what I'm saying for you today is new information, I'm very much hoping that you are hearing it anew. This is not business as usual. Primary care and the health of Massachusetts depends on urgent action. None of us can do this work alone, but to the members of the Health Policy Commission, without your active participation, we cannot move forward. Thank you again for your time. I'm eager to learn from each of you in the room here today and to answer any questions you may have for me.
I'd like to thank the panel. We do have time for one question from the commissioners, so Does anyone have a question or?
Thank you. Oh, try to get this microphone closer. Julie, this is a question for you. I heard you say that, I think you said sometimes, I would add too often, the frontline perspective is not heard. We have an afternoon full of panels with presidents, CEOs, executive directors. We don't have another nurse. I'm not sure we have another frontline healthcare worker on our panels today. So I just wanted to give you one last opportunity, now that you've heard from your fellow panelists here, to talk about sort of, what that they've said resonates with your frontline experience. What else do you wish you had time to talk a little bit more about today? And I guess what's the number one, number two issue that you see every day as you're doing your work?
I think one of the other big things is mammogram screenings and not having mammography in our health center, which would be fantastic. But also nearby, for those that are not insured, they have to come to Boston Medical Center to get screening mammograms, and so the access for that alone is not easy. But I think I can agree with all the panelists here, especially the care should start with primary care. It's the center, it's the medical home, it's where we have everything. And so starting there and working up from there and building.
Thank you.
Thank you. I think this was very powerful testimony from all of you, so thank you for your time. And I'd now like to turn it over to Chair DeVoe for the next presenter. Thank you.
Thank you. Want to add my thanks to the panel. As I look around the room, the folks in this room are all committed to their work because they wanted to serve the patients and to sustain the healthcare workforce. So I think starting our day with a current understanding of what is changing in the situation for patients and workforce is incredibly important. And thank you so much for coming today to share that with us. We'd now like to turn to our next agenda item and invite Audrey Shelto to come to the front table. And welcome to Audrey, and I will turn over the introduction to Commissioner Caljo.
Thank you, Chair DeVoe. It's a distinct honor to introduce my good friend and former colleague, Audrey Shelto, President and CEO of the Blue Cross Blue Shield of Massachusetts Foundation. Audrey will be sharing her insights and recent research on the dynamic federal landscape today, and the news is going to be pretty somber. Audrey has led the foundation since 2013, and for over a decade, she has set the standard for collaboration with public and private organizations, working to broaden healthcare coverage and reduce barriers to care. Audrey has walked the walk and not just talked the talk. She has advanced health policy for decades, including her leading work on the Roadmap to Coverage initiative that led to Massachusetts' landmark universal healthcare law. Audrey serves on the boards of the Women's Lunch Place and the Massachusetts Health Policy Forum, and the advisory board of the Heller School of Social Policy and Management at Brandeis. Today, in some ways, is a valedictory for Audrey. She will be retiring from the foundation at the end of this year. On behalf of the Health Policy Commission, and in fact our wider, quite unique Massachusetts fabric of healthcare stakeholders, I wish her the best of luck as she begins her next chapter. And we all look forward to our work with her successor, Caitlin Kenny Walsh. Please, Audrey, with that, take it away. Your findings will certainly help frame and inform today's panel.
Great. Thank you, my dear friend and Commissioner Caljo. Good morning, Chair DeVoe and everyone on the commission. It's a pleasure to be here. Thank you for the opportunity to present this research. I am going to focus primarily on the recently passed federal legislation. As you may know, the administration called it the One Big Beautiful Bill Act, which, in addition to sounding somewhat redundant, also is certainly not what I would call it. And so I'm going to refer to it as the state has recently been calling it OB3. It is big, for sure, and it's very complex, but it is far from beautiful. It is very ugly. So, as Commissioner Caljo said, unfortunately, I don't think I have a lot of humor in my presentation, so I apologize for that. Usually I do try to insert some, but it's a hard one to do for this. So I thought, maybe, can you hear me okay?
Yes.
I thought I might start with just a really brief primer just to remind us all of where we're starting from as we're embarking on the changes that are coming with this bill. Just some really quick basics. So, as many of you know, 1 in 4 Massachusetts state residents receives their health insurance through the Mass Health program. So we are talking about a really big program. Most of you will all probably know someone in your lives who has at times received coverage through Mass Health. Most folks are eligible for Mass Health because of their income, primarily those that are under 133% of the federal poverty level, which in plain English is about $21,000 for an individual. And for other populations, the maximum income is higher. So in addition to the 1 out of 4 you can see on the slide, there are other populations for whom the enrollment rate in Mass Health is much higher. In addition, I would say that we have tons of data about the Mass Health population. You know, we really have a good understanding through the data about who these people are, what their conditions are, where they live, geography, et cetera. But you can kind of get numbed by all that data, so I always think it's helpful to add some personal stories and understand, as Dr. Gergen-Barnett said, who, and many of the other panelists we just heard from, who are the real people behind these numbers. So just a couple people that we recently talked to for a publication that we released, I just want to quickly highlight for you. One is the family that you see on the right. This is a woman who lives outside of the Boston area with her mother and her son, who has severe autism and many other complex medical needs. She was working as a school bus driver, but her son's condition caused him to become increasingly aggressive, and he was not allowed to continue in the program that he was in. So she left her job in order to take care of him full time. Luckily, they are both covered by Mass Health, eligible for and covered by Mass Health. So not only is he able to get the clinical services, the support services that he needs in order to live independently in the community, but his mother is also able to keep herself healthy enough to be his primary caregiver. On the other hand, there are people who use Mass Health very briefly. We also talked to, a woman who returned to Massachusetts after living out of state, but she found herself unemployed, uninsured, and with a major dental issue that was progressively getting worse. So she was eligible for and got Mass Health. She was able to get treatment for the dental condition, which would have deteriorated and ended up in something much more not only painful but expensive. She got a part-time job, but that didn't offer health insurance, so she was able to stay on Mass Health, and then ultimately was lucky enough to find a full-time job that offered health insurance, and she went off of Mass Health. So there are also people where this is just a bridge from a condition that they find themselves in, unemployed, without access to affordable insurance, until they can get back on their feet. So I think it's always helpful to think about the folks that we're really considering here when we talk about these big numbers. The Mass Health program also is, as you know, a federal state program. So the federal government pays at least 50% of the total cost of the Medicaid program. And for certain populations like kids and the recent expansion population, they pay a much higher percent, up to 90% of the costs for the expansion population. So this has truly been a partnership all across the country between state and federal governments. The Mass Health program is also a huge source of federal revenue for our state, so huge impact on our overall state budget and economy. The program brings in $12.3 billion in federal revenue to support the state economy every single year, and that is 86% of all the federal revenues that come into the state budget. So again, much bigger impact than solely care to specific individuals. And then lastly, and we'll dive into the topic for the day, just briefly, in terms of the connector, which many of you know is our state-based health insurance marketplace. There's about 400,000 individuals and families who receive their care through the connector. Some of them get unsubsidized care, some of them get advanced premium tax credits, and some of them get deeper and broader, more people even get broader coverage through the connector care. And I will just say as a preview for what we'll be talking about later, the folks that are in this advanced premium tax credit column and some of those in the connector are the people who are at the core of this debate at the federal level about the shutdown, the government shutdown. But we'll talk briefly more about that. And I should add, you're going to have a fantastic panel right after me of people who run these programs, so you'll be able to get a lot more information. The key provisions of OB3, we sort of bucket them in three main areas. One is Medicaid eligibility. This law makes it unbelievably harder to qualify for Mass Health, to get enrolled in Mass Health, and to stay enrolled in Mass Health. And then when you look at Medicaid financing, it makes it much harder for states to generate their share of the Medicaid budget, which would then draw down a federal match, and also makes it much harder for the state to pay enhanced rates for programs that address specific needs in each state and, again, draw down federal revenue. And the marketplace, the connector, the law restricts eligibility for certain immigrants and also makes it much more difficult to enroll and has a lot of the same flavor of administrative burdens and hassles that you find on the Medicaid side. So starting with the Medicaid eligibility cuts, you heard from some of the folks on the previous panel, the two biggest areas are related to work requirements and 6-month redeterminations. This is going to sound kind of wonky. I wish I could, I will try to make this as plain English as possible. But these two new provisions in this law are separate, but they compound on each other. People could be affected, many people will be affected by both. The work requirements require the state to implement really a documentation requirement that people show that they have been engaged in either work or volunteer community activities for 80 hours a month. Now, we know that that many people in Massachusetts who are receiving Mass Health benefits are already working. 3/4 of people who are who receive Mass Health are in families working families, but some are not. So this is going to be not only people will lose coverage through this requirement, not only because some might not comply with this requirement, but others may be very, very likely working or volunteering, but they are not able to, they don't know what paperwork they need to generate. They don't know whether they're even required to generate this paperwork or not. They don't get it in time, and they could very easily fall out of coverage or not get it in the first place because they don't have the documentation, even though they are eligible and working or volunteering. The related new aspect of this law is the 6-month redetermination process. As, again, the previous panel mentioned, it's not easy to get on Mass Health. It's not easy to get on any kind of insurance, as we also heard from the first panel. There's a lot of work involved, a lot of documentation, a lot of paperwork. And once you're on, you have to renew your eligibility every 12 months currently. This new law changes that to every 6 months. So basically just doubling the burden on people for pulling together all the right information, getting it in on time, and having continuous coverage. These two components apply primarily to what we in Massachusetts call the expansion population, the people that received coverage through the Affordable Care Act expansion. And you can see the characteristics of those folks below in the where it says requirements. We are still, in the state, is certainly still sorting through with the federal government exactly who is going to be affected by this, but you can imagine how complicated that's going to be for individuals who are today worried about, does this apply to me or not? Another big area of cuts is in terms of immigrant coverage. And this bill, when you look through it, has definitely got immigrants like right in the middle of the bullseye. It eliminates Medicaid and CHIP eligibility for many lawfully present immigrants. So I really want to stress that these are people who are lawfully present. And as a result of this change, pretty much everyone that you see in the right-hand box up there on the screen who is eligible for Mass Health coverage today is not going to be eligible for Mass Health. And the state estimates that about 2,500 people will lose coverage because they're in that category on the right. Now, moving on to Medicaid financing cuts, it gets really complicated. I've worked in jobs that involved the Medicaid program for decades, and this was, I have to admit, but I will, this is new to me. There are these two mechanisms are ways that the state generates its own share of Medicaid funding and also uses Medicaid dollars to really achieve goals for the Commonwealth and get federal matches for both. So the first are provider taxes. So what are provider taxes? These are taxes that are assessed on certain healthcare providers. Actually, all the types of providers: hospitals, nursing homes, ambulance, and Medicare managed care organizations that contract with the state to provide care to Medicaid recipients. This is not any obscure. Well, it is obscure, but it's not any odd thing that Massachusetts uses. Every single state in the country, other than Alaska, uses provider taxes as a way to generate their share of the Medicaid combo of state and federal funding. These provider taxes bring in $2.3 billion a year into the Medicaid program. Medicaid then takes those funds and puts them back into the delivery system, thereby triggering the federal match. The new law says that there will be a moratorium on any new or increased provider taxes and requires that states that have a provider tax rate above 3.5% reduce their rates starting in fiscal year 2028. They also they have rules in there about how the dollars are allocated across different types of providers. The state, again, you'll hear more from them later, but the state is still sorting through what exactly this means in terms of our vulnerability here in the Commonwealth. We think probably the MCO provider tax is most at risk, but there's a lot more to analyze and understand about that. State-directed payments are rates that Medicaid programs, pay managed care organizations. It require them to pay managed care organizations to then pay providers for certain services. So these are typically used when there's a goal or a policy agenda that the state's pursuing, like trying to increase access to behavioral health services, so paying more for behavioral health, like trying to catalyze more equity programs and trying to address healthcare disparities, trying to get more implementation of value-based payment models. So they're usually tied to a very specific agenda. The Medicaid department will tell the MCOs, you need to be paying more for this. Again, these draw a federal match. The OB3 restrictions on state-directed payments limit the the payments for these services to a rate that is equal to 100% of the Medicare rate. Today, the state uses, as do many, the average of commercial payment rates. So again, getting kind of in the weeds here, but in many cases, probably through this law, requiring the state and the MCOs to reduce the amount that they're paying providers for the services that are aligned with these agenda items. These kick in a little later than some of the workforce and some of the eligibility initiatives, but so they're going to sort of grow in terms of their portion of the overall impact, whereas in the beginning, the previous two slides, those are where you'll see the most damage in the first couple of years. So lastly, in terms of the description of the law, for now anyway, marketplace eligibility changes. As you can see up here, there are several changes, again, targeted to lawfully present immigrants. And as a result of these changes, the state estimates that about 60,000 people are going to lose their coverage. The first is that lawfully present immigrants with incomes under 100% of the poverty level, that's about $16,000 for an individual, who don't qualify for mass health due to their immigration status will no longer be eligible for subsidized coverage through the connector. And then beyond that, further, many lawfully present immigrants with incomes above 100% of federal poverty level will no longer be eligible for subsidized coverage in addition. And then there are a lot of, as I mentioned earlier, administrative changes related to enrollment and maintaining eligibility that are going to make it really hard for the marketplace connector members as well. Lastly, although it's not in OB3, sorry, I didn't keep up. This is the issue that is pending in the middle of the federal shutdown, government shutdown, so I thought it was worth highlighting. The enhanced premium tax credits were established by Congress in 2021, and they deepened the subsidies available for people who were already receiving subsidies, and then broadened the pool of people who were eligible for premium subsidies. Then in addition, so the expiration of these tax credits will result in really, really significant premium increases for some, and for some of the people for whom it's an elimination of all of the subsidized coverage, and even larger increases. So as you probably have been reading in the paper and hearing about the open enrollment, and Director Audrey Morris-Gasteyer, the other Audrey, as we call each other, can talk much more clearly to this than I can, but people have been receiving eligibility notices with the premium information over the past month or so, and the increases that they're seeing are just horrific. And this is, all driven by the fact that they have to now reflect the elimination of these subsidies. If they get extended, things will be different. But as of now, I don't think the state has any choice other than to assume that they're not going to be. So you can see that, again, this is some people will no longer be eligible for subsidized coverage. Some of them may be able to, they'll be offered unsubsidized coverage, but whether that's going to be affordable for them or not is not clear. So for a lot of people, they'll have to make that determination as to whether they can afford the new coverage and may, in fact, become uninsured as a result of not being able to do so. So, pretty ugly bill, in my opinion. And these are just the sort of lowlights in terms of health care. There's obviously a lot of things around SNAP and other benefits, as the Attorney General referenced earlier in here. So what does it mean for Massachusetts? First of all, I have to say, and I think anyone would say, there are a lot of unknowns in here. Some of the language is really vague, so it's not clear exactly what they're trying to do. Some of the provisions are going to require regulations, so we don't know exactly how they are going to be implemented. And of course, a lot of the impact depends on what the state is able to do to try to mitigate the harm. There's also a lot of different numbers out there. A lot of people, including our foundation, have done different analyses. For this presentation, I'm using the state's numbers just for consistency to make sure that we're not adding to the confusion by having other numbers out there. So in terms of coverage, the impact is huge. These losses will begin in 2026, and probably all of this will probably hit full bore in the mid-2030s, maybe like 2034 will be about the point in time where everything is in place. But the state estimates about 300,000 people losing health care coverage either through Mass Health or the connector as a result of the coverage impacts, which are primarily the work requirements and redeterminations that we just went over, and the changes in eligibility related to immigration status. I will say the work requirements and 6-month redeterminations in and of themselves are projected, sorry, not both predicted and projected, to double the rate of uninsurance in Massachusetts. In addition to the people that are actually losing coverage, this bill is going to have a huge impact on our state economy, on the Medicaid program, on our state economy, on providers, lots of hard choices that we're all going to be having to face. State estimates that Massachusetts will lose $3.5 billion in federal revenues annually once all the provisions of this law are in place. So again, let's say that's sometime in the early or mid 2030s. You can, just to remind you on the left-hand side, the federal revenue that comes in from the Medicaid program, from Mass Health, from the feds, is a huge portion of the federal revenue that comes into the state. And if we're bringing in $12.3 billion today, and we're going to lose 3.5, you can see the magnitude of the cuts that we're going to be facing. So the state is going to have to make some really, really hard decisions. This is not a number that I think I can speak for the state in saying this is not a number that they can make up. I'm sure that some of the decisions will be, what holes can the state close? But some of the decisions are going to also have to be who gets covered. What do they get for coverage? What do providers get paid? And then again, the impact on the overall state budget will trickle out to a lot of areas beyond healthcare. I would also point out, if you look at the right-hand side of the slide, is when people lose coverage, they're not going to stop getting sick. And they're not going to stop going to emergency departments or hospitals or federally qualified health centers. They're going to get sick and they're going to show up, but they're not going to be insured. So you can see on the graphic on the right, the significant percentage of Medicaid revenue, Mass Health revenue, that each of these different provider types rely on in order to operate. So again, our provider system is going to be facing some really, really hard decisions. Do they stop providing certain services? Do they reduce their workforce already, even further when they're already struggling? Do they close sites? And I think that the main message I'm trying to convey here is the impacts of this bill are terrible. They're horrendous for individuals, for families, for providers, for the Commonwealth. They're much broader than the disaster of people losing coverage completely. But losses of this magnitude and the decisions that the state and the provider system is going to have to make are going to affect all of us. I mean, if providers stop providing certain services, if their staffing levels are lower, so the wait times are even worse, if sites are closed, it's not going to matter if you're receiving Mass Health as your insurance or you have Blue Cross Blue Shield or .32 or anyone else. That place is not going to be available to you. So this is really not a Medicaid problem. It is a state problem that's going to affect all of us. So in closing, I will try to end on a more optimistic note, which several of you, including Chair DeVoe, you started with, which is, there's no sugarcoating this in terms of what's coming at us. But if any state can try to mitigate the harm that's coming our way and try to be really, really creative and bold and not just tweak, but think really differently about how we deliver healthcare services here in Massachusetts, it's Massachusetts that can do that. We do have a track record of working together, of having lots of trusted relationships, even if we're competing, we trust each other, I believe. We've got this concept of shared responsibility that we used so much when we were expanding coverage that we can still use, I believe, and will be critical to recognizing this problem affects all of us, so we all have to be part of the solution. And we have incredibly talented and creative people. I mean, all of you on the commission and Shia and other staffs, the leaders of the programs that we're talking about here, Mass Health and the Connector, and everyone in this room and many, many others. So I think going back to what was said earlier, I think if I had to live in any state, I'm really, really glad I live here and I work here. I think that the years ahead are going to be incredibly challenging. When we did healthcare reform in the early 2000s, and then further with the federal government, the federal government was our partner. They were there with us every step of the way. They enabled, through the federal match that we were just talking about, the expansion of Medicaid, the development of the Connector program, through which we were able to get almost universal coverage in Massachusetts. The situation we're in now is so different. It couldn't be more different. We're looking at the federal government withdrawing support, not just in terms of dollars, but in terms of policies. But I forgot about the optimistic part. It was that, sorry, I sort of digressed there for a minute. It's hard. But we're all in this together. So it's not going to be, we know it's not going to be great when we come out the other end of this, but who knows? We may be able to turn this crisis into an opportunity. That we may be bold enough to do things that we wouldn't go near before because they were just too hard. But the urgency and the potential devastation here is just so imperative for us to really do that. I'm looking forward to, in some way, either watching or participating in all the work going forward. So I'm happy to answer any questions or move us along. I timed myself at home, which I never do, twice yesterday. Once I was at 18 minutes and once I was at 21. So I think I didn't blow through it completely.
That's great. We actually do have at least one question. I'll turn it over to the secretary, and thank you for that sobering presentation.
Yeah, thank you. I actually have 5 Audreys in my life, so.
That's unusual.
Yes. Thank you for your comment on the boldness that's going to be needed in the coming years in order for us to address this crisis. But I sort of have through your research, is there a red state insurance or healthcare marketplace that the federal government is basing their sort of changes on? Like, meaning that, do they have a vision of where they want us to land? And what do you think, which state do you think is closest in terms of the kind of marketplace and healthcare market that the federal government would like to see?
We have not seen, and I in fact have never heard anyone be able to point to a red state that is sort of more near the model that would result from what the federal government's talking about. The only thing I've heard repeatedly is, if you go back and look at Project 2025, you see all of this laid out.
Yeah. One quick question I have. In listening to your presentation, you, I think, cited to shared responsibility and the ethos that really made the 2006 law come together. And it seems like we're moving into an era of shared pain based upon a lot of different factors. Do you have any observations on what modeling could look like so that that shared pain doesn't extend all the way down to the patient level? And what would that sort of be at a very high level?
That's a good question. I think I have 2 thoughts about it. One is that in some previous work we did, that some of you were involved in around state health planning and trying to look at where is the delivery system today not aligned with the needs of the consumers in Massachusetts, not even the demand, because we know there's a lot of sort of repressed demand because people just give up on even trying. And unfortunately, we ended up mapping out pretty much the whole delivery system. So that didn't actually help us in terms of prioritizing our work. But I think that with the recognition that came through that is it is all so interconnected. You know, every part of the system is either the recipient or the source of people moving through the healthcare delivery system. So I think we have to keep the patient at the core, because it's not about any one of our sectors. It's really about the whole system and how individuals experience that and move through it. And therefore, I think the solutions can't be tweaking something in any individual system. There are improvements and efficiencies and different ways of doing things, I'm sure, in each sector. But it really has to be broader than that when you think about the patient's experience and how are we going to manage the cuts of this magnitude and not make our access, quality, affordability issues worse for consumers in Massachusetts.
Marty?
Great, great presentation, Audrey. You and I started our careers at the Department of Mental Health. I know through your work at the foundation, you've been very focused on behavioral health needs. Any thought on the impact on behavioral health of these changes that you just outlined?
I think the impact is going to be really, really bad. Some of the things I think of, and we're actually going to try to do some more work on this with David Mattiotto and Lydia Conley, but a couple things. One is, you know, so many of people who are in the DMH system, let's say, in Department of Mental Health system, receive a lot of their services through contracts from state government, through to, large providers and small providers across the Commonwealth, but for their health care, they're Mass Health members. And for a lot of them, they may not even know they're Mass Health members, not because of any inability of themselves to be able to think about that, because just they're immersed in a much bigger system. And for a lot of them, and for a lot of these provisions in state law, there are certain exemptions for people who have disabilities. So many people in the behavioral health system would qualify for exemptions based on disability. But it's in many cases, because people with serious mental illness also have very low or no income, their enrollment in Mass Health is based on income, which is not going to make them exempt. So again, not to get too much in the weeds, but there's going to have to be a real strong effort to make sure that people who have disabilities like serious mental illness or substance use disorder get certified if necessary in order to not have work requirements applied to them, for example. And then I think the other thing is, if you think of outpatient mental health services or substance use services, those providers, those organizations are going to be facing all these same cuts, and on all these same issues in terms of people losing their eligibility. So how is a community behavioral health center, or how is any other kind of integrated primary care and behavioral health program going to serve patients who no longer have insurance?
I think we have time for one more question. Steve?
Thanks. And thanks, Audrey, for your leadership. And I know you've been bringing stakeholders together through your work in the foundation, which has really, I think, been an extraordinary process. Just from your vantage point, the delivery system's challenge in many ways is that it's reactive in nature. But in this instance, we know the universe of people that are going to be impacted, and we know the provisions that are going to impact them. What can we do in the next 2 months to see if we can try to get a handle on the number and reduce the overall impact on the system between now and January?
So I think in terms of getting the numbers, there's a lot of work that we need to do with the state to be able to figure out geographies, et cetera, where to do where the people that are going to be affected are and how many of them there are. I think in terms of what we could start doing now, there's a few things. One is we need to make sure that everybody who's eligible stays eligible and keeps enrolled through really aggressive outreach, enrollment, navigator support services, so that people, those numbers in terms of people losing coverage, we could do better than that if we can really capture people who are at risk of losing their coverage. And again, Healthcare for All did a great job with that at the end of the pandemic coverage extensions. I think also trying to get a better handle on exactly how many people are just going to lose coverage, because categorically, according to especially these immigrant provisions, they're not going to be eligible. And to start thinking about how are we going to pay for health care for people who don't have insurance? Are we going to, I'm old enough to go back to the uncompensated care pool days. Do we go back to paying providers for services? Do we think of a health plan where we're paying organizations, accountable care organizations, others, per member per month amount for people who are uninsured? How do we think about the fact that we're going to have a lot more uninsured people, and they're going to be showing up for care, and we've got to figure out a model for paying for them. Those are the two most obvious, but there could be others. So I think just trying to, so many hospitals and FQHCs I know, we're already on the path of trying to find more efficiencies, trying to reduce costs because of the strains that everyone has been under without all this. So I think from what I would say, it's going to take just thinking even more now about, are there consolidations that can happen? Are there administrative functions that can be eliminated? Are there administrative functions that can't be eliminated but that could be done centrally? We're really, I think, going to have to think about restructuring. And we have to start doing that now, because even though a lot of these provisions don't kick in for another year or two, that's going to come really fast. And anything we do, think of the situation that the connector's in right now. You have to give people notice. So anything we do, the further along we can get in getting it in place before people start having to be, thrown to the wind, is going to be all beneficial.
Great. I think one more question.
Thank you. Just had one question. Thank you so much for your presentation. It was informative and very clear, which clarity I think is what we really need at this moment. So my question touches on some of the themes of the previous panel, as well as the question that was just asked, which really I'm struck by the extent to which the cuts that we're facing very soon will be created by really just administrative snags, right? So as you mentioned, there's really the need to make sure that people who are eligible remain eligible. Dr. Gergen Barnett mentioned really just the harmful impacts of churn, people sort of falling off of insurance coverage even though they're eligible because of redetermination and other factors. These can be harmful for folks, especially if they're undergoing care, they're pregnant, or they're undergoing chemotherapy, and many more examples. So one, just wanted to highlight what I think it was it the doctor from the Elliott Community Health Center? It was, yes. So I'm sorry, I don't have, okay, yes. Mrs. Patino, what Mrs. Patino mentioned around really just the need for not only language accessibility, but for the state to educate community workers and advocates so that they can sort of translate and effectively and appropriately communicate policy changes and such to staff. So those sort of low-hanging fruit, so to speak, was what really kind of struck me about the previous panel, ranging from things like coverage for parking at the hospital. These costs that might not be prohibitive for us are prohibitive for many low-income and low-wealth folks. The blood pressure cuff, I was really just horrified by how long it seemed to take to get a larger blood pressure cuff. That seems so basic. Yep. So if there's a way in which your foundation or others, and even the state, I know we're responsible too, can just ensure that we're finding ways to fund and take care of these very low cost, relatively speaking, measures that will ensure access, ensure affordability, and really prevent folks from delaying care and leading to some of the issues that Dr. Stenson mentioned. Would welcome any ideas you might have on that.
No, I could not agree with you more. I think, we've done a lot of work in the state, and many providers are doing this work, but I think both in two areas. One is, your sense of whether it's physician assistants, nurse practitioners when you're in a clinical setting, or especially community health workers in the community. Lots of community health centers themselves use them, but community health workers who are people who are trusted and like the people in the communities, who are much better able to do outreach to people about their coverage options, their coverage situation, about their health. We're at the foundation experimenting with a mental health initiative through which we train community health workers to be able to, non-clinicians, to be able to deliver 5 sessions of a really low-level intervention that has been proven on the statistically significant basis to help people reduce their self-reported mild depression and anxiety. So really thinking about how do you think of workforce differently and really engage community members who are working in different types of organizations to be able to be that front line or that front back door when someone's coming out of the hospital to provide some supports at a much, much lower cost. And then I think all of the remote work and the technology work, remote monitoring for people at home, like the blood pressure monitors. There's so much of that available now. And I'm reminded before the pandemic that we were probably the worst state in the country in terms of telemedicine adoption. We were doing a report on telemedicine, and I think it was in behavioral health, and there was some certifying agency that gave Massachusetts an F in terms of the use of telemedicine. And then the pandemic hit, and overnight, everybody was eager to go to telemedicine, which is great. But that's only one example. But there's so much that can be done remotely now. I'm no expert on it. But thinking about different types of workforce and about remote and technological components of a delivery system, I think is going to be critical.
And I don't know if that's something that your foundation might put an RFP out on.
Yep,
or,
we're
or something
doing
like
some work
that.
in it now, and I'm sure we're going to be doing more.
Okay, great. And also, just to mention, I don't mention this as a substitute for the large-scale sort of policy changes that we need to make now to cover the folks who are going to lose coverage and to pay for those individuals, just as something that's also needed.
Yep, totally agree. It was needed before this and even more urgent now.
All right. Thank you.
Thank you so much, Audrey. And I just want to mark this moment as you transition by saying thank you for all that you've done and your leadership. You know, it's actually, as I think about your contributions, of course, Audrey Shelto is brilliant. She has a huge heart. But the unique thing that I've experienced with Audrey is she goes from where the rubber meets the sky to where the rubber meets the road. It's a very difficult thing to do. And being able to always focus on these huge complex problems and bringing data and research to understand where the rubber meets the sky, but always bringing it down to something actionable and real and understanding what's happening, it's just been tremendous contribution. So thank you. And I look forward to seeing you around.
Thanks, Audrey.
Good, and we welcome our next panel to join us. Obviously, want to encourage attendees to step out as you need to. We will take a break after this panel for lunch. Welcome, and I'd like to introduce Vice Chair Marty Cohen, who's going to moderate and oversee the discussion of this next panel.
It feels like these chairs are pretty slidey.
Stretch.
We'll just wait for our panel to be sworn in. Great. All right. If we could have quiet, we can begin our next session. Our panel is entitled Leading the Way, State Strategies to Promote Affordability, Access, and Equity. We've already heard this morning how current healthcare access and affordability challenges are impacting employers, patients, and providers. And Audrey Shelto's presentation paints, I had troubling picture, I'll use her word, horrendous picture, of the impact that recent federal policy actions will further have on access and the cost of care in the Commonwealth. This panel brings together Massachusetts healthcare leaders who, by the very nature of their positions, have the unenviable task of trying to mitigate the negative impact that these policies will have on residents of the Commonwealth. Through their testimony today, we hope to gain a better understanding of how the state can position itself to safeguard access to quality care and drive meaningful progress toward a more affordable and equitable healthcare system in Massachusetts. Our witnesses today are Michael Curry, the president and CEO of the Massachusetts League of Community Health Centers and co-founder of the Health Equity Compact; Michael Loff, president and CEO of Cape Cod Healthcare and the current board chair of the Massachusetts Health and Hospital Association; Michael Levine, Undersecretary for Mass Health in the Executive Office of Health and Human Services; Audrey Morse-Gasteyer, the Executive Director of the Massachusetts Health Connector; and Amy Rosenthal, the Executive Director of Healthcare for All. Welcome to all of you. I'm going to start by asking, and we'll go right down the line, starting with our state officials. All of you represent patients and members who will be impacted by the federal policy changes that Audrey just laid out. Tell us what steps you are now taking to plan for or plan to take to minimize the impact of these changes, and what additional policy solutions could help to mitigate the threat posed by these changes. And Michael Levine, since this is all about Mass Health, we'll start with you.
I'm not sure it's all about Mass Health. Thank you, Vice Chair, and thank you for the opportunity to be here today. There's been a lot of conversation already this morning around work requirements and 6-month eligibility, and that is, those are the two policies that we project will result in the most coverage loss beginning in 2027. So we are very hard at work at Mass Health, taking every step we can to ensure as many people remain covered as possible. That is job number one. I think it's probably helpful to take a little bit of the mystery out of work requirements. There are 4 things we can do, are planning to do, and will do. The first is figure out who does not have to comply with a work requirement. Audrey spoke a little bit about this, but we are actively working with our federal partners and other states to provide clinical exemptions to as many people as possible. If you are too sick to work, you should not have to comply with a work requirement. I think that's very important. So we are actively figuring out who does not have to go through the process. The second piece is sorting out how many people we can automatically determine are already compliant with work requirements. I'll give you an interesting statistic from our redeterminations effort 2 years ago. We managed to get our auto renewal rate up by over 20 percentage points just by doing a better job of data matching and linking people to income records so that they never had to fill out a form or get an envelope. They just got a piece of mail saying, "You're good, we'll see you in a year." We want to do that with as many people as possible for work requirements and take advantage of as many data sources through income, higher education, volunteer associations, you name it, so that people don't have to lift a finger. The third step is engaging in communities and with individuals who do have to take action. And again, we have a playbook for this. It was the campaign that Healthcare for All, the Connector, and Mass Health ran 2 years ago to get out into communities and help people understand what steps they need to take. We were very successful in the 15 cities and towns, and I'll let Amy talk more about it, but we saw much lower rates of enrollment drop in those communities where we had people actively engaging their neighbors to help them understand what steps had to be taken. The fourth and final step is that if someone is not compliant with a work requirement because they aren't working or they're not engaged in a qualifying activity, how do we link them to a qualifying activity? How are we connecting people to job opportunities, to volunteer opportunities, so that not only are they able to remain covered, but they're also engaging in community. So these are all things that we have the next 14 months to get right. We're not doing it alone. We're doing it in partnership with our colleagues in the legislature, with many colleagues in provider associations and nonprofit organizations represented on this panel. And it's the most important thing we can do to make sure that the coverage impacts are as small as possible.
Great. Audrey, same question.
Thank you, Vice Chair and all the commissioners. As was noted in Audrey's presentation earlier, the connector really is at the tip of the spear in terms of some of the first coverage impacts resulting from OB3. And we didn't really have the benefit of a lot of time to get ready for that first wave of eligibility, categorical eligibility rescissions. So this January, about 37,000 individuals that we currently cover who are under the poverty level will be losing access to their subsidized coverage. So in terms of what we're doing on the ground to mitigate those harms and to respond to them, it's really been a ground game of very clear communication with those individuals to let them know what is happening and that it is the result of federal policy. We've tried to be very clear with people so they understand what the origin of these changes are. So we have really ramped up all of our efforts through our Navigator program, our call center, to make sure that we're able to respond to the very real, very palpable fear and worry that those folks are experiencing. I will note we have been inundated in our call center. We're today 12 days into open enrollment. Our call center has been experiencing very heavy volume. We are hearing from people in duress. We have seen an uptick in threats of self-harm. The degree of duress that is out there as folks contemplate losses of subsidy and these really striking premium increases is profound. So we see it as our job to support those individuals in understanding how they can continue to access care. I'm sure Michael will speak about that and other colleagues around how that will shake out in the provider system. So these first waves of categorical subsidy losses, we see it as our duty to support people with whatever mechanically they can do to update their account information if there's something that's changed that allows them to continue to be subsidy eligible, or other switches they may be able to make in order to stay in some kind of coverage or otherwise continue to access needed care. The other dimension of this, and Mike spoke to some of the administrative burden changes that are coming down the pike, and certainly on the Mass Health and Medicaid side that manifests in work requirements. There are similar analogous policies coming down the pike on the marketplace side a few years out. And I would just note, I think that's a place where creative, forward-leaning states like Massachusetts will have the opportunity to out-hustle and outmaneuver the intent of some of those policies. But I think what's going to be most challenging up front is just the removal of federal dollars and eligibility for folks that we're looking at, and that is hitting first in January at the connector.
And from our provider representatives, Michael?
This Michael or one of the others?
We'll start with Michael. This is the Michael panel. We'll start with Michael Curry.
First and foremost, good morning. I think, one, I want to just start with just additional recognition of Audrey Shelto. I did have the honor of working at Blue Cross for 16 years and was there when the foundation was launched. And through Andrew to Sarah to Audrey, phenomenal work that she's done. So I just want to, on behalf of community health centers, just recognize her significant contribution to health and healthcare in Massachusetts. It's interesting that we're having this particularly cost trends hearing today. This is the 60th anniversary of the first health center in the country. Was launched about 3 weeks from now in 1965. Interestingly enough, also 60 years ago, Medicaid and Medicare were launched, in part as a way to integrate our hospital systems in this country. And I just think the historical context of that is important as we now use federal funds to prevent people from getting access to care, when in fact 60 years ago it had the opposite intent. So we are, as has been mentioned, preparing for a wave of uninsured patients to come into health centers beyond the patients that we currently serve. As their coverage ends and the care that they get as patients, they lose access at different sites. The changes of what we call OB3, the coverage loss for 300,000 Massachusetts residents, is deeply concerning for us. 43% of our patients are on Medicaid. 50% community health centers nationally serve Medicaid patients. That's approximately 377,000 people in the Commonwealth that'll lose access to coverage, of those who might lose access to coverage. Community health centers also serve 66% of the state's uninsured population, and the marketplace impacts. Our Capital Link organization, that's an affiliate of the league, estimates that near 18% of privately insured patients are at risk of losing coverage due to marketplace changes and reduction in premium tax credits. So close and dear to me is all these changes and what it means for what we fought for in the Commonwealth. Recently announced priorities from HRSA challenge the way we deliver care and the services we offer. Deprioritizing health equity, going after DEI, gender-affirming care, harm reduction, and potentially our federal mandate to see any patient regardless of their ability to pay. That's a chilling effect that is having on both our communities and the patients that we serve. Additionally, the ability to cancel grants, quote, unquote, for convenience adds instability to federal support. And I just need people to realize as I talk to Fenway and I talk to Boston Healthcare for the Homeless about some of the tough decisions that folks are having to consider and in some cases make, to understand the Django effect of we get significant dollars in the Commonwealth in federal grants to community health centers. We rely on the Federal Tort Claims Act to provide coverage for health centers. We access the 340B pharmacy program. We get loan repayment through our federal relationship. And if you pull any of those out, you will essentially see health center systems across this Commonwealth collapse and across the country. The impending 340B rebate model on the federal level is a change that we're deeply concerned about. It would require us to have the upfront dollars to purchase drugs, and we are concerned as health centers rely on the margins that they get from 340B to quite frankly, finance the rest of their organizations and meet their mission. And then lastly, the staffing challenge. One of the things that I think many people don't know is that CMS just a few months ago issued some guidance or decision that when we get ready to renegotiate our 1115 waiver, we no longer can access the federal workforce programs and initiatives that we go into this waiver negotiation with, or any new programs. So when we as community health centers have relied heavily on our Medicaid program, our 1115 efforts, I should say, to really be innovative about how do we recruit, retain a workforce, and particularly a diverse workforce in the Commonwealth, that CMS decision concerns me. So fast forward to what are we doing, shifting costs across shared services. I think as Audrey mentioned, health centers are deeply engaged both with the league as well as with their other partners, including their ACOs, about how to save and create greater cost efficiency. We are continuing to advocate for the 340B savings, pushing for commercial rate equity as we talk about the importance of primary care and ensuring our future by preserving workforce pipelines to keep staff and clinics open. There's a lot going on, but I again want to harken back to 60 years ago. It is disturbing that 60 years ago we were celebrating the fact that we were expanding access to coverage, and now we are watching across this nation are drawing back on that commitment.
Michael, how are hospitals reacting?
Well, thank you very much, and thank you for having me, Chair DeVoe and Vice Chair Cohen and the rest of the Health Policy Commission. Really grateful to be here today to represent, I think, our organization, Cape Cod Healthcare, as well as the greater hospital and healthcare community. I'm not going to regurgitate all the facts that have already been presented today. They're quite compelling and they're quite true. But what have we learned in the last 5 years, right? Necessity really is the mother of invention. And what we've learned since COVID is anything is possible. And given the grave situation happening at the federal level and what it means to us at the local level, we understand the financial ramifications of the loss of 300,000 lives, right? Off the rolls, $350 million in the health safety net this year, $300 million, potentially growing by another $500 million in the coming year. We're so grateful to the legislature. We're so grateful to the governor. We are so grateful to the lieutenant governor for your partnership in helping us remediate that crisis. But the fact of the matter is we have to change what we do in order to meet the changes that are coming. We have to be bold, and so many people use that, but what will we do? What we will do and what we have done is we've enhanced what we've done with our workforce. We have gone out and begun to create our own, to invest in people that I've just heard mentioned here today. We've reduced the job openings by 5,200, and we continue to go and create new and innovative programs to make sure people are there to take care of people. Because no matter what we do with technology, no matter what we innovate, we will still need people-to-people contact. And I'm so proud of the healthcare community for doing that. We need to continue to go and create that access because access and affordability are not mutually exclusive. They can actually be together. I heard a great statistic earlier about the investment of primary care, 10 to 12%. That's factually true. And what can we do to make sure that primary care is more accessible? I love the idea that we make tuition assistance so real for primary care physicians. Because why aren't they choosing it? Because the federal government, through the model of reimbursement and payment, does not value them the same as they do a lot of the other proceduralists. So what can we do educationally? And not only for all primary care physicians, but if you choose to go into an underserved community, you can get full tuition reimbursement and assistance. We need to go and make sure that telehealth and hospital at home, and also invest in new value-based payment methodologies. How do we incorporate access? How do we incorporate preventive medicine rather than just paying people to do a service? We need to come together to partner with you, all of the constituents, payers, providers, patients, government. We should be at the same table. We actually are all aligned when you really think about it. How can we create access to improve the care that we provide to people? Those are the strategies that we need to put in place. Lastly, administrative simplification. This year alone at Cape Cod Healthcare, we will go through 51 surveys. The Joint Commission was supposed to be here yesterday. I really thought I was going to miss this meeting. I wasn't so lucky. But in all honesty, 51 surveys annually, biannually, monthly, bi-weekly, weekly, daily, that we have to report. It's too much. We can take over $1 billion out of the system alone by streamlining, by partnering, by making sure that we understand patient outcomes are at the forefront of all we do. Frankly, how we're going to prepare for tomorrow is by doing what we do today and only do it better, by creating that access, by investing in care teams, investing in innovation, and partnering with the likes of this panel and the Health Policy Commission. Thank you.
Thanks, Michael. Amy?
Hello, everyone. Thank you for having me. I felt very confident when I saw who was on this panel that Mike and Audrey and others would be talking about some of the things that Healthcare for All is deeply concerned about, and I feel obviously they've covered it well. And so I want to focus a little bit differently on thinking about the immigration issues that are happening with the ICE raids and the enforcement that's happening, and thinking about this particularly from an equity lens. Two quick stories I'll share with our Connecting Communities to Care program, which is the program we do with Mass Health to get enrollment assisters out in the community. One of our enrollment assisters recently told us that she had been talking to a couple, both of whom were sick, but they were afraid to see a doctor because they were scared of ICE and, quote, getting in trouble. We then had a call just recently on our helpline from a couple who had come here under humanitarian parole. The husband told us that he was diagnosed with cancer in his blood and he was hospitalized for several weeks. Because ICE was all over their neighborhood, when he got discharged, they got scared to leave their home, go to the doctor, or do what they needed to. Ultimately, they did end up disenrolling from health insurance and then ultimately self-deporting. But we're hearing this all the time from people who are not self-deporting and staying here. This is really important from the patient perspective, and that's where Healthcare for All grounds itself and sits. But we also ground ourselves in sitting and think about the cost perspective. And whether I'm talking to colleagues at Mass Health or at hospitals or insurers, we consistently hear the same thing, that people are showing up and getting care and they're more sick than they've been before. And this is bad for patients, this is emotionally bad for providers, and it is expensive to our system. And so when I think about what's happening from the immigration front and think about people deferring care or not getting care, I worry that this trend is going to continue far out into the future. So we're thinking a lot about how we create safe spaces for people to be able to feel comfortable to ask questions, to understand what health insurance programs or health insurance support they're able to get. We think about this in two ways. One is our helpline. Some interesting statistics on that. We took 27,000 calls last year. We are seeing a noticeable dip in our calls this year. And even though our community partners tell us that we are a trusted source, that we are someone that they feel they can trust, we are worried that calls are not coming in because people are so scared. A second statistic on that is that last year, 70% of our calls came in a language other than English. This year, that's down to 60%. So it tells us who's self-selecting and not even calling the helpline to get the help to figure out, can we help them feel comfortable in getting care and not avoiding care? And then the other thing I will say is about this importance of outreach and engagement and enrollment. As Mike alluded to, Healthcare for All was just really privileged to be able to work with the Health Connector and Mass Health and so many partners here on the redetermination campaign. The stat that I love to say is our 15 campaign communities fared 4% better in keeping people covered than the non-campaign communities. We can do that again, but again, it's about talking to people and meeting them where they are so that they understand what they can do, how they can be safe, and how they can get the care that they need.
Thanks. Let me open it up to my fellow commissioners, and I think Commissioner Wilmoth, you have a question?
Sure. I have a prepared question, which is, what do you see the impact of these changes on the healthcare workforce? Just to expand on that a little bit, I want to say that we really haven't heard much about the federal government's immigration policies. That affect the workforce, that affect the deportation of the workforce in Massachusetts, which I'm very concerned about. Like Amy said, my day job, I focus on the workforce and here on this commission. But I also want to talk about sort of the impact of those changes on the diversity and the cultural competence of our workforce. I see, Michael, you're wearing your Health Equity Compact button. So, yeah, I'm sure. But I'd be curious to hear from the provider representatives, sort of what do you think the state could be doing more to help you recruit, retain the workforce that you need. And from the state folks, which Amy, you'll be soon, I think. Do you think there's more the state should be doing here to respond to the federal attacks, to generally build upon what, Michael, you were talking about, the work that the hospitals and others are doing to build back up their workforce post-pandemic? Whoever wants to go first.
Well, I'll jump into a little bit of workforce because I think led by MHA and by our healthcare community, as I mentioned, we've reduced the number of job openings by 5,400. But let me give you an example. When we think about diversity, right? When we think about equity, the healthcare workforce of today is vastly different than it even was 5 years ago and 10 years ago. And how can we go and penetrate and provide career ladders and opportunities for these communities in which we serve that look just like us? What we've essentially done is incentivize these training, these apprenticeship programs in which we're paying people to train them. We're partnering with tech schools, high schools, community colleges, universities, the government. We're partnering with labor unions. We have such an impressive apprenticeship program with the 1199 SEIU at Cape Cod Hospital, right? You don't have to go and be adversarial. How do we invest in the future? We no longer have a workforce crisis in healthcare. Are we still vulnerable? Yes, we are. But because of this hard work put in on the front side, we are making strides. But it's not just about doctors and nurses. It's not just about primary care and nurses, but what about all the other healthcare related jobs and giving people the opportunities to not only progress for that career ladder, but function at the top of their licenses. There's so many jobs that others can be doing. There's so many different spaces that we can be doing it in. Whether it be in the community, whether it be at health centers, whether it be at urgent care centers, off license, on license, there is a role for so many. And by us getting rid of that fixation of the past, the expertise economy, and really moving more into the internet-based economy, and that's code for just being more nimble, being more progressive, understanding what the opportunities are, I really think we can excel. We are no longer behind. We're certainly not ahead. But I think the model that Massachusetts has put in place, the governor has been a big supporter. I think this is something that should be replicated across the country because I know that we're doing it well.
I'll
Go ahead.
I'm happy to just provide a quick state perspective, and I'll speak as the primary payer for long-term services and supports in the Commonwealth. So most LTSS is paid for by MassHealth, true of any Medicaid agency in the country. I think we are seeing a significant impact on workers in the LTSS space, both in the nursing facility realm as well as in the community-based realm, for people who are losing their work authorization based on the I would describe as chaotic, unpredictable, and frankly just hard to follow on any given day, which work authorizations remain in place. So I think that is a challenge, and it is one we have to continue to work through together, both so that we're kind of communicating clearly with workers, providers, and the patients who rely on their care. So that's one piece. I will also say, and I know, Michael Curry, you mentioned earlier that we're going to be losing some authorization that we have for workforce funding in our next round of the 1115 waiver. I will just note, again, like what a blessing to be in Massachusetts. Most of the dollars that have gone out for workforce in the past couple of years have been authorized by the legislature, all state funds, mass repay. We've put over, I think, $250 million with thanks to Michael Curry and his team at the Mass League to invest directly in primary care and behavioral health. And it's a real testament to the legislature and the governor's leadership on that. So, I think the natural question is what's next, and I defer to a lot of smart people in this room to sort that out. But we have made a lot of progress, both providers, the state, and it's just unfortunate that the environment around immigration is going to make it challenging to sustain that, I think particularly within the LTSS space.
Michael, did you want to add?
Yeah, maybe so one is to echo Michael, just congratulations and thank you to the state and to the administration on the support in MA repay. Game changer in the Commonwealth. This time next week, I'll be sitting in Minneapolis, St. Paul for a meeting with health center leaders from across the country. And we are still the envy of the nation because we do try to do the right thing. And workforce is a great example of that. People often will call me or email me and say, tell me more about that MA repay program to see if we can model that in the states where they are. I will say this, that there is a crisis in workforce in health centers. I'm not sure how it looks in other parts of the system, but when I talk to my members and they tell me that it takes up to a year to recruit for providers and nurses, for doctors and nurses, and that they're competing with higher paying systems, that's a crisis. And we can identify that if a doctor is missing from a health center or nurses are missing from a health center, that has an impact on our capacity to see patients. So the reality is and it's even more extreme if you go to rural communities, where they have a harder time recruiting and retaining providers because of a myriad of issues like housing and transportation and so forth. So I think we do have a crisis. I think the state, again, is a model for many others in trying to solve for that. I am deeply concerned, though, about the diversity of the pipeline. Not to get into a historical perspective on this, Dr. McGregor, but I often refer to the doctors like you and Dr. Thea James and Dr. Cheryl Clark as exceptional people who had to withstand the gauntlet of discrimination to get into those roles. We need to make sure that in Massachusetts, we create a pipeline where Black, brown, women, and others are ascending into these critical clinical roles. And we need not to retreat from that just because of the shifting federal policy. So that is a DEI comment, that it never made sense that we didn't have these folks represented in our clinical workforce, and Massachusetts needs to remain committed to that.
I think Lauren Peters from CHIA had a question.
Sure, thank you. I would first just want to shout out and thank you all for your ongoing efforts to mitigate the impacts of the federal government. I know that you all are working around the clock to plan and prepare for that. So I have a question for whoever wants to take it. Thinking about the broader coverage landscape, I think many of us are familiar with the continuous trends we've seen over the past decade of the declining commercial market, specifically the merged market. And so as the federal government continues to erode these public programs, benefits, eligibility, how can we collectively, sort of the royal we, think about this moment as an opportunity to reverse those trends that we're seeing in the commercial market as one way to sort of maintain coverage, but also stabilize the provider financial system?
I'm happy to, thank you, Lauren, for the question. Happy to take a first crack. I think some other folks today have noted the opportunity that comes with a crisis to really think more sharply and clearly about challenges, as you noted, even predating this particular federal administration that we've been facing in the commercial insurance market, which is really an affordability crisis. And obviously that's the work of this commission. So I see this as a moment where it just becomes that much more urgent that we try new solutions we might not have had the stomach to in the past. I will note, just in terms of some of the specific additional challenges that kind of just got thrown our way in the commercial market. We've talked a little bit today about some of the lawful, with an L, immigrant populations that are losing their access to subsidy. Those are people who are in the commercial market today. They are some of the healthiest people in the commercial insurance market today. So when we think about what's coming with 37,000 people leaving the merged market come January 1st, presumably, because we don't think they'll be able to afford coverage without that subsidy, another 30,000 January 1st, 2027. Again, we're just talking connector. This is not the mass health cuts. Those are all people coming out of the commercial insurance market, the merged market, who are cross-subsidizing probably everybody else because they're younger on average. So these are trends that have been coming, and I know we're all very clear-eyed and sober about the challenges that were already in play in the commercial market. And then with these added destabilizing factors, I think it just becomes that much more urgent. A lot of the types of policy interventions that the Health Policy Commission has been advocating and now has even more tools around, I think just becomes that much more important as we're looking at the next few years in order to keep people in the merged market and to keep that a healthy risk pool.
I think Commissioner Erickson has a question.
Yes. So administrative burdens reduce access, and this is a question I think I'm going to aim at Audrey and Michael, thinking in your roles there. Work requirements are going to increase administrative burdens more than they'll probably increase work in any particular way. I've had the opportunity to work closely with the connector to reduce administrative burdens and increase healthcare enrollment, and I'm curious about what kind of actions we can take as a state to reduce administrative burdens, what kind of IT investments might be necessary or helpful, what kind of other state agencies might be helpful to coordinate with in reducing those burdens on people who need to provide information to the state.
You want to go first?
Thank you for the question. We're very passionate at the Health Connector about reducing administrative burdens and have been for some time. We actually conducted what we called a sludge audit on ourselves a few years ago to try to look with fresh eyes and tease out places where we were creating frictions or administrative burdens for people that were not absolutely necessary under federal or state law. And we did find places where we could improve and have been really pleased to implement a lot of those changes. We're now in an environment where we have, frankly, hostile to that effort, federal government that is trying to impose administrative burdens, really introducing this, for lack of a better term, kind of a skepticism towards people's eligibility, the onerousness of people having to prove who they are, that they are truly eligible, so above and beyond in ways that those of us with employer-sponsored insurance would never expect or encounter, and creating a real hostility around access to public insurance programs. So as we look over the next coming years with some of these new burdens that will be coming our way, first I would say there will be federal rulemaking on that. So we will do everything we possibly can to influence what that federal rulemaking looks like. We are already coordinating with other like-minded states to try to anticipate what that might look like and influence course with all of the data and research and experience we have in states like Massachusetts who take this kind of work very seriously. But whatever comes out of that rulemaking process, I think we will stand ready to be as creative and forward-leaning as possible. Mike noted some of the things they're thinking about on the Mass Health side. I'll let him speak to that. But we can use technology, we can use processes, we can use engagement with consumers to try to make sure that people are not essentially frictioned out of the process and not able to access coverage and subsidies that they are in fact entitled to. So I think we have some learnings from what we've done over the last few years proactively, even in advance of this more challenging period.
Yeah, so just to reiterate some lessons learned when we had to redetermine 2.4 million people in 1 year after having not done any redeterminations for 3 years during the pandemic. The most important thing we can do to keep people covered is to prevent eligible people from ever having to go through a process. We are going to be doing more income data matching. We want to data match with the National Student Clearinghouse so that any college or grad student, we happen to have a lot of them here in the state on Medicaid, can just count those hours. They don't need to send us paperwork. We want to, there is technology being piloted at a national level that helps gig income workers click a button, allow us to access an account, and we will know exactly how many hours they're working for Uber. All of those IT investments are really just about back-end data matching that I hope not a single Medicaid member ever sees or knows about. All they're going to know is they will be automatically renewed. So that's the most important thing we can do. The second piece is, if the auto renewal rate is, the most important fraction to get as high as possible, the second most important fraction is the response rate for people who do have to take action. That was pretty stubborn during redeterminations. I mean, it stayed in the 40 to 50% range where it had been prior to the pandemic. We did a lot. I mean, we cut our forms for older adults by 75%. We took dozens of pages out of it. We've cut our Medicare Savings Program form down to a page and a half. You can do a lot on the kind of form clearing side, but it's so important to keep people from ever having to take that step in the first place. So we are going to make the IT investments. We are going to take out every question we don't have to ask, everything you can do on a smartphone. That will remain the case. But I think the key is going to be doing as much back-end data matching as possible to keep people from ever having to go through the process in the first place.
Commissioner Liebman?
Yeah, first off, thank you to the entire panel. Genuinely appreciate not only your perspective, your voice, but I think what's come across most importantly this morning is the passion and the urgency behind these issues. So maybe, Amy, I offer this question to you, recognizing that this is my first cost trends hearing, and my hope is that 3 years from now we're talking about different challenges, and you're back talking about new challenges, and it then brings me to reflect what would we have been talking about 10 years ago and the challenges then, and hopefully we're not repeating them today. and the treatments are different, the approaches are different, the cures are different. And so I don't want to lose what's not said this morning, which is, where are we having success? As we make difficult trade-offs, we don't want to do harm. And so I just thought you could offer maybe a unique perspective with regards to, there's got to be some things going right. There's a ton of challenges, we're all facing them, and we want to make pivots to get there. But what things do you want to ensure, let's not change the progress we've made?
Thank you for the question. I've heard a couple people already this morning say, thank God we're in Massachusetts, and I think that would be my key takeaway of what we're doing right is, I feel very lucky when I talk to my colleagues across the country who don't have relationships with industry partners, and they don't have the ability to pick up the phone and talk to folks. And the fact that we do that here in Massachusetts is the first step, I think, in really helping us solve these very difficult problems ahead of us. I also think about some of the leaders who were kind of a generation before, the Rick Lords and the Mike Whitmers and Rob Rastuccia and others who really talked about and lived by the shared responsibility philosophy. And I do think in the conversations that I've had with healthcare leaders recently, that there is this real desire at this moment to just bring the entire costs in the system down. And I think I've been really heartened by the fact that so many different players are willing to come to the table and have those conversations. I think today is going to be the first time we're going to hear from pharmaceutical manufacturers and PBMs coming to the table. I think that is a phenomenal step forward, and I'm excited to hear that panel later today. I think having a wide range of new commissioners and others is a step towards continuing that partnership of working together. So I am hopeful that that's the way we're going to move forward and address affordability and so many other issues. It's just going to be very hard, and I think the trust that we all have with one another is something that we can really look forward to. I think the last thing I'll say is I think regardless of what industry people are in, people do really work on centering the patient, and I think that it's not just consumer advocates that do that. So whether it's a hospital or a physician or the quote we saw from the pharmaceutical industry, there's so many things that I think people want to center the patient, and that's something we should hang on to too. So I'm very grateful for that. Hope that helps.
Thank you.
Can I add to that, Chair? Just to reinforce what Amy said, I think one of the things that I'm most proud of when I travel the country and have a conversation around our challenges is, to Amy's point, that we actually have conversations here. So I got Steve Walsh, Steve on speed dial from a hospital perspective, so we talk often, or MAP, or the business community, Brooke from AIM, and all of us are constantly having a conversation. Just sat on Jim Rooney's Eds and Meds panel that he had about 2 weeks ago. So I think one is we have to continue to have conversations. And what I credit Mike Levine, Robbie, and now Kiame for is making sure that we're part of the conversation. A lot of government entities don't include key constituencies early enough in the conversation. Trust me when I tell you, that is a problem across the country. So when Robbie calls me and says, Mike, we have a challenge, can I get you and your health center members in to have a conversation? When Mike and Steve Walsh says, hey, we need to figure out this health safety net challenge, let's have a conversation. I want us to center that and continue to do that, because we cannot solve these problems if we do them in dark corners and in isolation. The other thing is, I think in Massachusetts, just to lift this up, as I wear the pin, we are also the envy of the country on our effort to try to address health inequity in Massachusetts. What happens when you have these cuts in federal dollars is people have to make really hard decisions. People often make a comparison in this moment to COVID. And for us in the health center movement, it feels like COVID. The challenges, the stress, the precipitous decline in revenue, all those things become what we experienced just a few years ago. I urge us, when we make some of these really hard decisions, that we don't forget about the people that are most impacted, which Amy would reinforce. When we cut benefits, when we cut access, when we disinvest in these critical programs and services, those are the patients we serve, and they have real consequences for families. So I want to encourage our continued focus on health equity in the Commonwealth. That's through the legislature, That's through the governor and Kiame and his team. We have to make sure, because this too shall pass. And on the other side of this, I think there's a story to tell at Massachusetts. We stuck to what we believed in.
Commissioner Walsh, did you have a question?
Thanks, thanks, Michael. This panel is really extraordinary to listen to, and it makes us think about what could be better, which we want to think about, but I'm going to focus on the now for a moment. And excited that in Amy's new role, she'll take the compassion and care and centering of the patient into what's happening in the state. And Audrey has been doing so much around an insured population that is vulnerable. Michael is leading generational work, and we have a bit of a mutual admiration society, but it is real. We really care about each other and work well together. And the way you heard Mike Loff talk this morning is the way he talks. He wants to change the delivery system for the better. So I won't focus on them other than to say the work is inspiring, and I hope we can get to all of that. And I'll focus on Secretary Levine for a minute. Secretary, you are the single most important person in healthcare in the entire Commonwealth at this moment. Apologies. It's all on you. As Dr. Barnett said on panel 1, we have to fix Medicaid first. Medicaid drives our entire economy. Everything else is built upon it, and all of the other things that everybody wants to do and all of the goals around affordability hinge on it. And you're really good at it, and you're really thoughtful, but you can't do it without all of us. So the real question is, from a global perspective, what are you looking at, and what can all of us do to help you be successful so we can get to the other work that people are focused on?
Thanks, Steve. I should have told my dad to watch. So there's, I think we've had ample doom and gloom around some of the federal changes coming our way. I'll say our biggest challenge right now, today, November 2025, is that our cost is growing faster than state revenue grows. So it's not a terribly different story than what you'd hear a commercial insurer tell you, that costs are growing faster than they feel they can, pass on to employers and employees with premiums. But you take a $23 billion budget and you grow it by 10 percentage points faster than state revenue grows, you have a $2.3 billion problem every year, and that's not an easy way to start the year. So when you take that and you take the fact that you are going to have more people entering the ranks of the uninsured, and we don't have a health safety net fund that is currently adequately funded, it all comes back to what are we doing to provide care in a lower cost way? How are we going to keep the 2 million people on Mass Health, which, harkening back to Lauren's question, is 250,000 more people than are on Mass Health prior to the pandemic, who are no longer commercially insured. How are we going to keep them healthy? And how are we going to continue to make progress on closing disparities and everything else at a cost that we, and when I say we, I mean the government, I mean taxpayers, can afford? And so there are really, tough decisions to make. There are obvious things one could do. You can pay less for services, you can cover fewer services, or you can cover fewer people. And none of those are things that anyone in this room wants to do. But it is the path you have to take if you can't figure out a more cost-effective way to care for people and keep them home. Now, we've done a lot of things at Mass Health I'm proud of. I'd love to do more of, right? We've managed to reduce the number of people waiting for an inpatient psych bed in the emergency department. We've cut that by 2/3 in the last couple of years because we've invested in outpatient behavioral health. We've gotten 3,800 moms connected with doulas, which we know reduces the cost of delivery and perinatal costs. Even our nutrition costs, which I think most people would say, what's a Medicaid program doing covering food? That's the last thing we should be funding in a budget crunch. Well, turns out it saves $1,700 a year. We just published that article in Health Affairs for the medically complex adults who have benefited from medically tailored meals. So that's the challenge. I think we need a couple things. One, we need providers and people who care about patients in a room together, figuring out how to deliver care at a lower cost. There are a lot of good ideas out there. There are things that have been tried in the past, but there's no substitute for an empowered primary care model that's going to keep people getting care where they want it. And again, we're fortunate to be in Massachusetts, but we need to figure out how to take little pockets of innovation that are happening around the state and scale them up really fast, because we can't wait. Every year that goes by, that $2.3 billion problem is just going to keep cropping up and accumulating. The second thing we need to just consider is, pharmacy costs grew 18% per member last year. So how do we make sure, again, that we're able to sustain access to really effective, excellent therapies for our members, but at a rate that, state revenue can support? And then I think the third piece, we made a big bet on accountable care organizations 8 years ago. We have some evidence, which we're hoping to make public soon, that we'd be in a deeper hole if we didn't have ACOs. They do seem to be working and saving money, so that's good. But they're not containing the rate of cost growth. This idea that you have an ACO that puts primary care in the driver's seat and you wrap all these supports around it. It's the right way to deliver care. It's the right way to take care of people. But I look at our trend and I say, boy, what are we going to do in ACO 3.0 to start to flatten that curve? We have a lot of levers at the state that I want to make sure we're partnering with providers and plans to take advantage of. And I just need people to sit at the table and take their hats off and think about what's going to be right for the system so that we can, make adjustments where we need to make adjustments and look back at a program in 5 to 10 years that we said, okay, well, we put it back on an affordable trajectory, because unfortunately that's not the trajectory that it's on right now.
Thanks. I agree with Commissioner Walsh that Medicaid's job one. Job two would then be the connector. So Audrey, give us an update on where we are with the tax subsidies and also your sort of sense of rate projections going forward.
Sure. So I think folks know, we've been all kind of white knuckling through the show in DC over the last month plus with the shutdown, and that the fate of the enhanced premium tax credits have really been at the center of that. And, it looks like maybe there will be a vote in the Senate in December. I don't think any of us are holding our breath as we look at the dynamics down there. Just to ground people in the implications here in Massachusetts, we've spoken a bit about OB3 and the eligibility and subsidy losses stemming from that will hit the connector. The enhanced premium tax credits, it's very difficult to overstate how significant they've been nationally and here in Massachusetts in terms of really bringing so many more people into, bringing coverage into reach from an affordability perspective for so many more people, particularly middle-income folks and older individuals in the individual market who are sort of pre-Medicare eligibility. It totals to about $425 million a year coming into Massachusetts, and that includes both enrollee contribution reductions that have happened as a result of the enhanced premium tax credits, as well as offsets to state spend on connector care. I sometimes describe what enhanced premium tax credits did was for lower income individuals. It made the whole country through the Affordable Care Act look more like what we had done here in Massachusetts. But it helped people to lower income level here, and then there were whole groups of people that got brought into this new help. So looking at those going away, we know it's going to result in really tough choices for a lot of households across Massachusetts. It has implications for the connector care expansion pilot that we've had in place for the last few years that has brought the 300 to 500% population, 300 to 500 FPL population into connector care. If the enhanced premium tax credits go away, folks over 400% of the federal poverty level will no longer have access to premium tax credit or connector care. So it is significant, and those are a lot of the folks we're hearing from in our call center who are trying to make heads and tails of what it means for them and their household budgets. Can I afford to stay covered? What are the implications for my rent and my grocery bills and my child care obligations? The other piece to note is it's not just about the premium increase, it's also people being newly exposed to really high cost sharing, deductibles, et cetera. So we will have to see how that shakes out. Again, we're not holding our breath. We have pulled the trigger on an open enrollment period that's responsive to what law is, and what law is that these expire on midnight on December 31st. So we are very fortunate, as folks have said, to be here in Massachusetts. We have the buffer of connector care for a lot of folks, but this will still be pain that people are feeling that is very real and how that shakes out, over the long haul. And we're so fortunate to have Commissioner Caljo at the helm at the Division of Insurance, but what the implications are for the risk pool and how that shakes out for carriers with respect to pricing and the composition of the commercial market, I think we'll have to watch really carefully. But right now at the connector, from an open enrollment perspective, our immediate need is supporting people with clear facts, clear information about what's happening and what they can do to try to navigate their way through the hard choices that are in front of them.
Thanks, Audrey.
I just have one quick follow-up, and thank you, panel. This has been terrific. I want to follow up on a comment that the Undersecretary Levine made relative to the rate of cost and affordability in Mass Health, and reflect back on those same patterns of conduct in the commercial market. The numbers that we're seeing are not sustainable, and I want to stress that. That's not just an adjective. Unsustainability is something that means the system's broken. We cannot have a system as we look to the future that continues on the same path that we have now. So all of the mantra and the real belief of working together needs to be tested and translated into action, and soon. I have the benefit, or in this case, the terrible misfortune of seeing the future in terms of premium increases for the next year. Those premium increases are essentially double of what they were a year ago, and they're going to continue to grow unless we make systemic changes to the system. That is going to require pain and a different way of doing things. And so I'll just reiterate, we need to find a way to protect the patient and the care, but there's going to be a changed system, and we need to create that dialogue right now. So it's really not a comment, or a question rather than a comment. If anyone wants to respond, have at it, but it really is very sobering.
I'd love to just jump in and say, I think as a consumer health advocacy organization, people are just always expecting us to say, like, how do we expand the programs? How do we do more for patients, which of course we do want to do, but you can't protect the patients if you're not looking at the overall cost. I think that's where we've been so fortunate here in Massachusetts that we have the data from HPC and CHIA, and I think, we've talked a little less this time than we usually do about what those trends are, and about, I think we heard from Mike about prescription drug costs going up so much, outpatient hospital costs, price variation. And it's not just, those are the leading causes, but it's not just those. And I think we need to be looking at this system holistically, because that is the way you protect the consumer. That is the way you use the resources wisely. And I think just like when we did Chapter 58, the patient has to give to some extent, and the industry needs to give to some extent, and finding that middle balance is important. So I did just want to reiterate that.
Thank you.
I'm going to give the last question to Director Seltz.
Thank you. Well, it's been alluded to a few times by some of the questions here, but Amy, you are transitioning away from Healthcare for All. You're going to be joining us in the state government. For those of you who don't know, yes. You're going to be joining the Executive Office of Health and Human Services at this critical moment. First, just want to say, I think we're all just incredibly grateful for your leadership at Healthcare for all of these years. Healthcare for All is just nationally recognized as, I think, the premier consumer advocacy organization in the country. And you have an incredible team in terms of talent that you have been able to grow and collect and retain. It's just top-notch organization. And you and your organization in your advocacy, I think, notched a pretty big win earlier this year with the PACT Act and some of the prescription drug work that was a huge priority for the organization. So first, want to say grateful, and I think we are all heartened that you're choosing to join government at this time. I'm not going to ask you what you're going to be doing in your new role, but I did want to ask, reflecting back on your time at Healthcare for All, what is one insight about policy or people that you're going to be bringing with you into this role?
Well, thank you, and thank you to all of you. I think this is my 7th time in 8 years appearing before you, so I appreciate the many opportunities to share the thoughts of healthcare for all, and really appreciate that. I also do just want to say Healthcare for All is going to be left in great hands. Ashley Blackburn will be stepping in as interim, and I feel very confident that you all will continue to have a very strong partner at Healthcare for All. I am deeply grateful to the governor, lieutenant governor, and secretary for having the trust in me to bring me in to play this role at this difficult time. Looking forward to working with my colleagues here and many others in state government. January would have marked 20 years for me as a consumer health advocate between my time at Community Catalyst, national partner, and Healthcare for All. And so, people are always centered in the way that I think about things. I think I will be wearing a different hat with a different set of responsibilities, and I think you can still do that and center people by working with new partners, by collaborating in new ways, but not forgetting kind of what is core and center to the healthcare system. So I will be eager to bring that, and I know I will be working with many, many people in this room in this new role. So again, thank you to the governor, lieutenant governor, and secretary. So thank you.
Well, we are out of time. I also want to add my congratulations to Amy and thank you for the leadership at Healthcare for All. It's always been a pleasure working with you. I also want to thank our panel. This has been really insightful. You, as I said, have the unenviable task of trying to figure this out, but I think we are in good hands. And so I'm deeply appreciative of the work that you do, as I think my fellow commissioners are as well. So thank you very much.
Thank you. Thank you, panelists. And Michael Levine, I want you to tell your father to watch that segment on YouTube. And I'll just say, on behalf of the Health Policy Commission, tell him that was good parenting. So we're now going to take about a 30-minute break for lunch. We'll reconvene at 10 of. And there is box lunch, catered box lunch available for anyone who is interested. And also, of course, attendees are welcome to leave Suffolk and get lunch nearby. See you in half an hour.
No. We tried to do good on the day we met her later in life, so it didn't actually work out. But there was some
I mean, I understand why she left, but it would have been great.
But yeah, 3 and 5 is
I think
fine.
everything worked out the way it's supposed to. Yeah. You're right where you're supposed to be. We'll see what happens next.
Yes, but I would have loved to keep working.
Yes.
Yeah.
Plus, it was a cushy job compared to this one.
Yeah.
I'm not kissing your feet.
No.
I'm going for the.
There you go. I think it may be way over
I was
here.
starting to get worried.
Yeah,
no.
Got it?
Yeah, exactly.
Yeah, we
I
have
know.
a niece who is 16.
Right.
You don't have to do yoga today.
Always wishes me good health.
You're all
I
set.
like it. Thank you all. Let's go ahead and get reconvene.
So are they? Are our friends getting
We'll
ready?
reconvene for.
Really?
There's some glimmers. I will say it that way.
Okay. Like the shutdown.
Yeah.
Good afternoon, and welcome back to the Massachusetts Annual Cost Trends Hearing. As we return from lunch, I'm pleased to tee up our next panel. This is something new that we're doing this year. It is a spotlight focus on an innovative, promising care delivery model that is being pioneered right here in the Commonwealth by two of our leading health systems. And this year, we're focusing on the Hospital at Home program. Commissioner Walsh is going to lead this panel discussion. Commissioner Walsh was appointed by Governor Healy, and he brings his deep knowledge of the Massachusetts healthcare system and his unique perspective as a policy leader that helped shape Chapter 224 to the work of the Health Policy Commission. But before I turn it over to him and to this panel, we recently released a report and a study of the Hospital at Home program that's available on our website. What a great website. And prepared a short summary video on the model, describing the model and its uptake in Massachusetts to help provide a quick background primer before this panel. It's just a few short minutes, and we're going to play it for you today.
Hospital at Home has emerged as an innovative and promising model that allows hospitals to provide hospital-level services in a patient's home rather than in a traditional brick-and-mortar setting. This model differs from other home-based services, such as home health care, in that it is a substitution for a hospital stay. Hospital at Home is for patients who need hospital-level care, but are clinically stable enough to receive care at home. Patients are admitted to hospital at home following an emergency department visit or a transfer from a traditional hospital inpatient setting. Hospital at Home provides services that are normally provided in a hospital, like diagnostic testing and specialty consultations, and services like meal preparation and delivery. Services are provided in the patient's home by clinical staff, and patients also have 24/7 telehealth connection. Nurses and community paramedics are often important members of the care team. Compared to traditional hospital care, family caregivers may play more of a role in providing their loved ones care and assisting with daily activities such as eating or bathing, but the patient and family may also prefer the experience of being at home. A national study of the Hospital at Home model of care found largely positive patient and caregiver feedback, and patients described feeling at peace and more comfortable while being cared for in their own space. Although hospitals have experimented with providing inpatient-level care at home for years, this model of care gained traction in 2020 when the Centers for Medicare and Medicaid Services launched its program for Medicare beneficiaries. This was amidst concern about hospital capacity during the COVID-19 pandemic. This program allowed Medicare to pay for hospital at home care at the same rate as traditional inpatient care. Although hospital at home programs represent a small share of total inpatient discharges in Massachusetts, these programs are growing rapidly. From 2020 to 2024, hospital at home discharges in the Commonwealth rose nearly tenfold, reflecting both the entry of new hospital programs and existing programs increasing their capacity. In Massachusetts, 9 hospitals had an active hospital at home program in 2024. About 2/3 of hospital at home patients in Massachusetts have Medicare coverage. In 2024, nearly 80% of patients had Medicare or Medicaid coverage. As such, hospital-at-home patients tend to be older. In 2024, more than half of patients were at least 70 years old, which is consistent with the average age of the Medicare population. While national analyses found hospital-at-home patients were more likely to be white and have higher income, patients that utilize hospital-at-home in Massachusetts appear to be similar in terms of race, ethnicity, and income to patients receiving traditional inpatient care at the same hospitals. As hospital-at-home programs continue to evolve, it will be important to consider possible policy implications, including appropriate admissions. To ensure that hospital-at-home is not used as a substitute for lower-cost, lower-intensity services such as home health care, program requirements should ensure that patients enrolling in a program require hospital-level care. Hospital capacity. The state should monitor the impact of these programs on hospital capacity, including the potential to relieve hospitals from emergency department crowding and discharge delays, as well as potential spending impact from hospital bed expansion. Other important issues include continuing research on the benefits of patients, including care quality and patient and caregiver experience, determining appropriate payment rates, standardizing data collection, and financial sustainability. To learn more about these policy questions and about hospital-at-home in Massachusetts, read the Massachusetts Health Policy Commission's policy brief, Hospital-at-Home in Massachusetts, Trends in an Emerging Clinical Model, available on the HPC's website.
Thank you, and thanks to the HPC team for the great video, but really for the great policy brief. And we have a little moment here in time after lunch to do the aspirational part of our day. It's the shortest part. It's a mini brief. But after a little sustenance, hopefully we can be positive and talk about one of the innovations that really is working. And as it talked about decanting people from the ED, what we kind of talk about in the provider world is if you're entering the healthcare, if the front door to healthcare is the emergency department, we've all done something wrong. And that was the discussion this morning around primary care. And we have a couple of tremendous leaders from two innovative programs in the Commonwealth to talk a little bit about their experience. So let me welcome Danny Metzger-Traber, Vice President, Strategic Business Operations for Mass General Brigham Healthcare at Home, and Dr. Konstantinos Taki Michaelidis, Medical Director at UMass Memorial Healthcare Hospital at Home program. These are two of the leading hospital at home programs in the country. And I'll open it up with just kind of a general question and then get a little more specific next. Just tell us about your program. How did you start it? How has it evolved? What can be the capacity of it? And then what are the federal changes that have happened now recently, and have they altered the way you operate the program? So let's start with Danny.
Sure. Well, first I'll say good afternoon. Incredibly grateful to have this opportunity to talk about hospital at home. Just appreciate Health Policy Commission. The video is great, but as you said, Commissioner Walsh, the brief is even better and just highlights, I think, what is a really bright spot and innovative moment for the state. Master Brigham Hospital at Home started in 2017. We had 2 pilot programs run out of Mass General Hospital and Brigham and Women's. In 2020, when the pandemic hit, those hospitals were 2 of the first 8 waivers that were given to bring hospital at home more broadly. In 2022, we merged into 1 service line across MGB. In 2023, we expanded to 3 of our community hospitals, Newton Wellesley Hospital, Brigham and Women's Faulkner Hospital, and Salem Hospital. And since then, we've continued to grow. So we've moved on from caring for traditional medicine patients, so congestive heart failure, asthma, respiratory virus. Now we're taking care of patients postoperatively. We're taking care of oncology patients. This year we opened up to OB patients. We've treated over 100 patients with postpartum hypertension, helping new parents get home more quickly. We've done all this with amazing quality results. We have lower readmission rates than those same patients from the brick and mortar. We have less post-acute care utilization. We have a net promoter score that's 20 points higher than the brick and mortar hospitals that we're drawing these patients from. And I would say where we are today, but we're in a funny moment today where the waiver that allowed us to provide this care, that provided that parity, it expired at the end of the continuing resolution that happened, that this government shutdown. So for the past 5 weeks now, we've been operating without that waiver. So before the waiver ended, we had a capacity to treat 70 patients at any given time. In the month of September, we treated just shy of 400 patients, 390 acute care inpatient level patients. Right now, we are operating on an ambulatory basis. We treated around 200 patients in the month of October in this ambulatory setting. We're taking patients later in their course of care. We're taking them after they've been discharged from the hospital, still providing that hospital throughput, but not nearly the level we were before the waiver expired.
Thank you so much, Commissioner Walsh, and to the Health Policy Commission. It's a total privilege to be here, and everything that Danny said, I just echo 100%. And when I think about gratitude and the efforts that have happened in our state to care for patients who have acute care needs, we talk to colleagues in health systems in states all over the country supporting their work in home hospital, and I think the number one thing we hear over and over again is, holy cow, you're so lucky to live in Massachusetts. We have a supportive DPH, a supportive Mass Health. We have a supportive OEMS, a supportive MIH regulatory environment. We would not be here without folks helping at every step along the way. The Health Policy Commission work and that focused spotlight on our work has been incredible. So thank you. Let me start just saying that. So to step back for the moment and tell me if I'm too close to the mic, we basically launched our program in 2021 to address a real challenge in emergency department boarding at the time in our main tertiary care center at UMass Memorial Medical Center. It was not uncommon for us to start the day with 100, 120 patients boarding in the ED, and that was pre-pandemic. And so the pandemic only exacerbated these challenges. And we use the word boarding, and I think that's got a sterile sort of connotation. Boarding has a lot of challenges for safety, quality, cost, patient satisfaction. So we launched our program in August 2021. Just like our colleagues at MGB, we are a CMS waiver-approved inpatient hospital home program. We have to meet every Medicare condition of participation except the one that was waived. We can talk more about that. And so this is inpatient hospital care. This is not home health on steroids or mobile integrated health on steroids. This is really inpatient substitutive acute care. So since we've launched, we've cared for almost 4,000 patients in the model, and actually it's almost like we could steal each other's outcomes. We've had very similar outcomes. So 5 to 15% lower readmissions, 80 to 90% reductions in skilled nursing facility utilization after care in our home hospital program. Our top box recommend is 90 to 93%. That's about 20% on an absolute basis higher than our brick and mortar benchmarks. Patient safety has been outstanding. We've never had a CAUTI, never had a CLABSI. Our falls and C. diff, all of those rates are below our hospital benchmarks. And I would say that where we are in this moment, to Danny's point, is really asking for our federal colleagues in Congress to extend with some certainty at least a 5-year extension of the CMS waiver for us to continue to be able to invest in our programs and grow the programs and meet our community needs. A great example for us is that we have our Community Hospital Health Alliance in Northern Worcester County that cares for a large population, and that hospital has been further pressured by the closure of Neshoba Valley Medical Center, as we all know, one of the Steward facilities that closed. And so that facility wants to expand our home hospital program. We want to move up there and care for patients in that model. Unfortunately, right now, we've actually had to pause our program due to the statutory gap with the government shutdown, and that's obviously been really challenging for lots of obvious reasons. We've seen our boarding rise in our main medical center, and we can talk more about that ad nauseum for sure. The good news is we're hearing that we will, with the continuing resolution, have a short extension, probably through January 31st, but obviously that is not the durable extension we need to be able to invest in and grow the program and care for our most vulnerable populations. And I should say, too, that to the point in the Health Policy Commission report, from an access and equity perspective, we compare our brick and mortar hospital services with our home hospital services, and we see no daylight between, no differences in race, ethnicity, gender across the populations, which is exactly what we want to see. And so we feel very confident that this is something we want to grow and build. And actually, some of our best outcomes are in our most disadvantaged population. So on our patients who have Medicaid as primary or secondary payer, where instead of that 5 to 15% reductions in 30-day readmissions, we're seeing probably closer to 20 to 30% reductions. And a big part of that is that we believe that being in the home is by definition pro-equity. We're understanding challenges with food insecurity. We're seeing signs of mild cognitive impairment. We're seeing that they couldn't afford some of their medications. And so I think we hope to continue to grow and expand in how we care for patients in this moment once we get past this little bump in the road from a statutory perspective.
Thank you both. And let me ask one follow-up question. It's a bit of a harder question, I think. You know, I often say the one thing that all of us have in common is that we're all patients, or we're loved ones of patients, right? And I think when we learn the most about our healthcare system is actually when we're in it or experiencing it. And neither of you knew this until I just told you that my dad's now been in hospital at home twice. And it was from the policy brief, the quality of the program was extraordinary. The care was incredible. It was great for him to be home. But I'm questioning the affordability. And as we look at the charge of this group and we're thinking about what is scalable in terms of how we can save money, and it doesn't mean that every innovation has to save money, but if this one is going to be an affordability innovation as well as a quality of care innovation, how would you scale it in a way? Because there was a lot of equipment, a lot of one-to-one care. It did open up a bed for someone. It did make his experience better. But do you have an answer to that yet? Or should we not be looking at it as an affordability idea?
I think for our system, when we look at our why for home hospital, I think a big one is capacity, right? Shortly after we had to halt our inpatient operations, Mass General Hospital was in Tier 3 capacity disaster for the first time in months and months. We were not able to take the same 20 to 30 patients that we can take from there on a regular basis. When we look at how we're delivering that care and what the costs of care are, so where home hospital does provide savings is on some of those indirect costs that we're not maintaining a facility, that environment, all those different pieces we don't have to pay for. I think you're right, though. We are providing sort of a higher level of care with one-to-one time, clinicians that are in your home. So overall in that mix, we see actually around the same cost for us as a hospital system to provide the care to a patient between whether it's in a brick and mortar facility or at home. But the benefit for patient care, the benefit for capacity are huge. The ability to reduce readmission rate, the ability to make sure that patients can be at home and discharged to home and not have to go to a post-acute care facility, those are all savings to the system that are going to accrue. We think there's a lot of opportunity to get more and more efficient in how home hospital is delivered as we grow, as technology catches up with us. But this is still nascent, and so we need to have more of that runway. At the moment, though, we think there are so many benefits, and the fact that we are delivering care at around the same rate as a brick and mortar, that gives us more than enough reason to keep investing, growing, and making this model work for more patients.
This is an incredibly important question for sure, particularly in this moment. I'd say that stepping back, when we look at colleagues in urban environments, rural environments across the country, I think increasingly many folks, and certainly our own leadership in our health system believe this as well, is that we have a capacity challenge in an aging population, and we are not going to build our way out of this crisis. There's just not enough money. There's not enough in rural environments, critical access. Hospitals are closing. In urban environments, we have a single hospital bed costing $5, $6, $7, $8, $9, $10 million per bed. And so to our why is very similar. It was about capacity and meeting our community's needs with many very strong quality, safety, and ancillary benefits. So there are certain unique costs for home hospitals. So we invest in resiliency and redundancy. So for instance, we have leased four-wheel drive vehicles. We have to be able to get up a hill in the middle of the winter. If a patient loses power, we have to have backup oxygen canisters in their home. We bring in every single thing the patient needs, food, redundant internet. They don't have to have anything. We bring all of that to the home. And so that resiliency and redundancy, of course, there is a cost, but actually very similarly, we have seen when we look at from a total episode basis about the same cost for patients who experience any time in their home hospital program versus patients admitted to a hospital service who don't spend any time in a home hospital program. We do believe, and we've shared this with our colleagues in our payer community, and we've had some really amazing payer partnerships, to say the least, including a big shout out to Mass Health for sure, and Fallon and all of our colleagues, is that 80 to 90% reduction in skilled nursing facility utilization is a material cost savings. As we all probably know, a single skilled nursing facility stay in Massachusetts can fluctuate somewhere between $20,000 and $26,000, and so those are material savings, as well as, of course, the 5 to 15% reductions in readmissions, creating total 30-day cost savings. And so what we've seen is that, for instance, the Congressional Budget Office, when they looked at the bill that would extend the home hospital program, they actually scored the bill, probably conservatively, might argue, as budget neutral.
it was in my dad's living room. I was thinking, there's got to be someone within another mile that's in the hospital. So can we set up a grid system, just bring UPS in to run the logistics of it and make sure you're delivering services in an efficient manner? But I think Secretary Mahoney had a question.
Yeah, I think I have sort of two questions. Number one, as you're gaining more experience with hospital at home, are you gaining insight in terms of like, oh, we could be doing this totally differently? I mean, I think of that anytime I do a telehealth visit with one of my patients. I'm thinking, oh, it really should be that the camera is looking at their fridge so I can tell like what they're eating, like not at them, right? There's something that is very different about a telehealth visit that we're not leveraging in primary care because we're sort of treating it as a different form of in-office visit. So I was wondering, are you starting to see, oh, we could be doing things completely differently instead of just trying to reproduce what we do in the hospital? So that was sort of the number one. And what impacts does it have for health access and equity? And also what impacts that it has where you're thinking, oh, we could do things differently if only there wasn't this rule or this policy, or if we had this policy in place, we could do things really differently. Sort of in terms of as we're thinking of innovation and change. And then the second question, if that wasn't enough, was how, other than Commissioner Walsh, how have other patients, families experienced this? Do you have to convince them? Are they thinking, oh, you just don't want me in the hospital? Like, how are they responding to this invasion of people in scrubs coming into their house?
Thank you so much for these questions, and so grateful to have a chance to talk about what that experience is like from a patient and a family caregiver perspective in particular. So maybe let me just start there at the end, and then I'll work backwards. And Danny, please chime in for sure. Stepping backward for the moment, you might imagine if you're a family giver or a patient and your loved one is hospitalized, there are some real challenges to that experience. Perhaps you don't like driving at night. Perhaps the hospital is 40 miles away. Perhaps the hospital has tried to make parking free for 30 years, but there's compliance challenges, and they want to make it free, but they can't. And believe me, that's a real discussion. And so you're driving 30, 40 miles away, you get to the hospital after work, it's 7 o'clock at night, you're trying to find the main doctor, but the main doctor is at home, you're trying to find the nurse. And when we think about the value of telehealth, to your point, and what we can learn from what we're doing at home hospital and bring back to the brick and mortar, a couple things I'll share. The first is that, first of all, we're bringing all the care to the human being in their lived environment, and that's a real context. And so there's a couple things that we learned that we'd love to bring back to our colleagues in the brick and mortar, and I think increasingly we are. The first is about mobility. So our patients in the home, they're standing up and walking to the kitchen and making their favorite cup of coffee or tea. And so they're not losing some of that muscle mass, which means they don't need the skilled nursing facility afterwards, for sure, 100% categorically. The second thing is that because we're using telehealth as well, there is operational mandates almost by the virtue of interdisciplinary care. And so what I mean by that is me as a physician who was on service recently caring for patients, I cannot care for one of our patients without our patient in the home, their loved one sitting next to them on the couch, and our nurse or paramedic in the home facilitating my exam and my telehealth visit. So that is fundamentally interdisciplinary care in a way that sometimes it's just hard for the brick and mortar to have happen. The nurse is really busy and they're seeing other patients. And so there's some lessons that we're bringing back to the brick and mortar from what we've learned in the home, as well as, of course, informing care teams on the ambulatory side around some of those challenges. So I think I probably addressed two of the questions, but Danny, please feel free. What did I miss?
Sure. I will say maybe just on the caregiver and patient experience, and I'll start there as well. There is a hurdle in education with it, right? I think what we like to say is the hardest time to introduce somebody to the home hospital model is when they're in the ED, because they've made a decision that they don't feel safe or comfortable at home. They've come to one of our country's best academic medical centers, and you're saying, actually, we can deliver even better care back at your home and take you back there. And so one of the things we're looking forward to is when we raise the profile with sessions like these, when we have more and more patients, you saw the growth and more folks that are experiencing this personally, it makes it easier, and folks realize, so Commissioner Walsh, your experience of this is such a nice care, how you're affording this, is pretty universal, because it feels really good to get that level of care. It's truly patient-centered care, which not a lot of patients get to experience. I'll then pick on that one point of what are some things we could change. Patients that have sort of state-funded personal care attendants, that is a group where home hospital makes so much sense for them to be in that space. But the way that we are treated is when somebody is home with home hospital, from a financial perspective, it looks like they're just in the brick and mortar hospital. So of course you don't want to double pay for a personal care attendant, some of those services that, that you wouldn't provide in a brick and mortar hospital you don't have there. But there's this great set of patients. We could do even more for them. We could provide a better continuity experience if we took advantage of the fact that, you know, they are home. They could have that PCA there supporting them. There are ways we could figure out to finance this. It's really how do we do it in a way that works for everybody, but that could provide such a great benefit to a truly underserved population.
And I think to your question as well regarding the acceptance on the patient side, what we've noticed is that our number one predictor of acceptance from the patient perspective is whether they've experienced home hospital before. So if we've cared for them before and they understand us, they're typically asking to come to us often, sometimes even before we've had a chance to reach out to them in the hospital. So the other part is in the screening process, patients and families are both duly and equally involved in that evaluation for appropriateness. It's not a mandate, it's a choice for sure. And then we're also sharing with them, to Danny's point earlier, what PCA services and home health aid services we can offer to support a very broad range of folks that have functional challenges as well. I think your question is around the statutory piece. I would say the number one thing we've asked from in terms of unlocking barriers to support our community and from a growth perspective, a couple of things. The first is obviously the federal waiver extension. We've asked for at least a 5-year extension. And from a really, you know, on the optimistic side, this is a tough moment for sure. On the optimistic side, there's been incredible bipartisan support for the telehealth and hospital home waivers across the country. And so that's very encouraging. And then in our state legislature, I just want to say a particular shout out to Representative Donahue and Senator Patrick O'Connor, as well as Representative Michael Finn and Senator William Driscoll, who have supported 2 state bills that would help support our mobile integrated health paramedicine program, sort of like an emergency department at home type service, as well as coverage for a home hospital across the state. So some really encouraging areas on the statutory side.
Thank you both. I think we have time for one more question. Commissioner Erickson?
Sure. So thank you for speaking to some of the regulatory changes that you'd like to see. I'm curious about where you see the gap between financial incentives and social value to be, and to what extent potential admissions to the home hospital program are constrained by payers like commercial payers as opposed to, say, Medicare or Mass Health.
I would say, and this is just on the constraint piece first. Taki touched on this a bit, but we both get to speak with home hospital programs across the country, and they all wonder how we've been able to grow, how we have this hotbed in Massachusetts of home hospital growth, innovation, development. And a huge reason is not only do we have one of the 13 state Medicaids that is reimbursing the service, our local payers get it. They're working with us on this. They've gotten it for a while, and so having that support and partnership has been incredible, where we can be payer blind, and we approach all of our patients and offer them, if they're meeting our clinical criteria, we are offering the opportunity to receive their care at home with home hospital. So I think that's incredible. That's just such a huge piece that allows for the equity results that the Health Policy Commission briefing saw for us.
Completely agree.
Thank you both very much. Thanks to the team at the HPC for shining a light on this important issue and for the work that you're both doing. Appreciate it. Turn it back to you, Executive Director Seltz.
Thank you.
Thank you, Commissioner Walsh, and thank you, panelists, for that great panel, great discussion. I had the opportunity to see the home hospital program in action, both at MGB and UMass, and can say, seeing it firsthand and seeing the patient experience was really powerful. I think there was some aspects that they didn't get a chance to talk about, but I think are really important that you can see when you're in the home. And Dr. Mahania, you talked a little bit about this. Some of the clinical team can see some of the social determinants of health and can think about other ways that they can support these patients. One of the things that Taki said that I think was really powerful to me was being able to do some prescription, reconciliation for patients who, had all these different types of prescriptions, and being able to have someone say, okay, let's take these all out, let's put them on the table and say, okay, where did you get this one from? Where did you get this from? And what do you need? And those are things that can happen so readily when you're in the home and being able to do that. So I think there's these other benefits that come from being able to really be able to see into someone's life in a way that being in the brick and mortar doesn't allow. So thank you again for that great panel. So before we dive into the afternoon panels, I did want to spend a few minutes today to you commissioners and to the public to ground some of these discussions in some additional data and facts. We love data at the Health Policy Commission. We love data and we love PowerPoints. And really just to emphasize a point that has already been raised multiple times today, that healthcare affordability must continue to be a focus of the Commonwealth's policy agenda. So I'm going to share a few slides, about 10 slides, just on some of the most recent data that we have to underline this point. So first on this slide, when we review our state's underlying growth in total healthcare trends, you can see that for the first 7 years or so after the passage of Chapter 224, our growth was generally moderate and was in line with the economic growth, in line with the benchmark, and at or below national trends. However, in recent years, this cost growth has accelerated, and unfortunately, there's little indication that those rates will return to the 3% and 4% of the 2010s. So these cost trends contribute to long-run affordability challenges for employers and families in the commercial market. And I'm going to focus specifically on the commercial market. In Massachusetts, you can see here the premium costs for employers and families have grown much faster in the orange lines than the growth in the overall state's economy, than the median household income, or inflation, as shown as in the blue lines below those. And these premium costs have accelerated in recent years and have outpaced national trends. So something different is happening here. And this is a reversal from the 2010s. So this slide shows the delta in family premium costs between Massachusetts in the orange and the US in the blue. So in 2012, that's the second set of bars from the left, you can see that the average family premium in Massachusetts was about $1,600 higher than the US average. And if you keep going over, by 2019, 7 years after the passage of Chapter 224, Massachusetts was making progress in closing that delta and was only $938 higher than the US average. However, in the period since, that progress has eroded, and by 2024, Massachusetts family premiums were $3,600 more expensive, and according to the latest national data, the highest in the country. Those family premium costs that I just showed you do not take into account out-of-pocket costs like deductibles and copays, which we also know are increasing significantly as employers have shifted more healthcare costs to employees in reaction to the premium increases. So in 2014 in Massachusetts, about 1 in 5 commercial enrollees was enrolled in a high deductible health plan. And by 2023, that number is close to 50%. And just so you know, a high deductible health plan is defined by CHIA in the most recent year, is a plan with a deductible greater than $1,500 for a single and $3,000 for a family. This shift in enrollment into these plans has important downstream impacts on care utilization patterns. Survey results tell us that patients and residents who have high deductible health plans are much more likely to have medical debt, and they're much more likely to report having gone to the emergency department for a condition that doesn't need emergency department level of care. And we've talked about this and we've heard this over and over again today from the panelists about patients going to the emergency department who don't need to go to the emergency department, but worried about the cost of care, or that they can't afford the care, or they're worried about their deductible. On this next slide, Director Peters teed me up on this earlier. This is showing some data about the small employer market, the small business market, where these trends are even worse. And she mentioned it earlier, the bars here are showing the declining enrollment in the small group market from 2010 to 2024. You can see that enrollment has almost dropped in half. In this market, the merged market, average family premiums are higher, the average family deductibles are higher, and the percentage of enrollees that are on high deductible health plans is much higher. About 76% of enrollees in this market are in a high deductible health plan. And most employees in this market do not have a choice of a health plan from their employer. So they don't have the ability to shop or compare prices. And I want to zoom out to the broader employer market for just a second. The Massachusetts Taxpayers Foundation recently highlighted healthcare costs as a top concern for all employers in their 2025 Economic Competitiveness Index, with Massachusetts ranking 48th among states for employer healthcare costs. And the report stated that healthcare costs were one of the state's most notable competitive disadvantages. So adding together the average family premium cost and that average out-of-pocket cost and the copays and deductibles, and the annual family healthcare costs in 2024 was over $32,000 for a family in Massachusetts, around $2,700 a month. And this is the average, so there are some families paying much more. So we put all of this together, high and rising premiums, out-of-pocket costs, all of which are outpacing income, inflation, and economic growth, and healthcare is contributing to the affordability challenge of living and working in Massachusetts, of growing and establishing a business, especially a small business. And this slide compares the basic average cost of living expenses for a middle-class family in 2 counties in Massachusetts compared to their middle-class income. And as you can see, for a middle-class family in Suffolk County, these basic living expenses already exceed that middle-class income. And unfortunately, this budget equation is getting a little bit worse. In this current environment where cost of living increase, the cost of everything is growing and premiums are growing faster than that, we can see that middle-class families are falling further behind. So in this slide, we modeled a scenario. We said with healthcare costs growing 7% a year, as they are today, even with an above average increase in compensation from an employer, in this scenario we modeled 4%, the take-home pay from that increase, as shown on the left, compared to the increase in the other costs of living, shown on the right, leaves this middle-class family falling $50 further behind each month. This is the slide that the Attorney General talked about at the beginning of the day, the dynamic that happens when premiums grow faster than income and inflation. This final slide I want to show you takes that same concept and envisions 2 potential futures for Massachusetts families. One in which premiums continue to grow at 7%, and alternatively one in which premiums could moderate that growth rate to the overall long-range growth rate of the state's economy. As you can see, that delta in take-home pay grows over time, and by 2030, an average family in Massachusetts would see a reduction in the take-home pay of more than $600 per month by 2030 on that 7% trajectory. I know that the word affordability has been in the news a lot in the past week, and for some people that is a new word, but not for the HPC. We have been making affordability a central theme of these hearings and our policy recommendations for many years. In 2019, in our cost trends report, we included a recommendation that stated healthcare affordability must remain a central focus of the Commonwealth's healthcare agenda. In 2021, we recommended setting affordability targets and standards. In 2023, we recommended setting an explicit affordability benchmark. And while there has been some progress on the policy side, for example, DOI can now consider affordability in their rate review process, there's still much work to be done. As has been stated so many times today, there is so much to be proud of in our healthcare system: the quality and innovation, the dedicated workforce, the committed leadership, and the commitment to access and coverage. But in this moment, we are being tested, and with nearly 40% of Massachusetts residents saying that they can't get the care that they need because of cost, we need to renew that commitment to affordability. That's what the data tells me, at least. So thank you for allowing me to present that data and that information, and I'll turn it back over to you, Chair DeVoe.
Thank you. An important grounding, as you indicated, for our next two panels. Our next panel is new to the annual cost trends hearings, and we'll ask our panelists to come to the table, and I'll turn it over to Commissioner Leibman, who will introduce the panel's purpose and goals.
Thank you, Chair DeVoe. And as the panelists come forward, I'd like to welcome them for the next panel, which is Navigating Pharmaceutical Market Trends, Balancing Innovation and Sustainability. As Chair DeVoe said, this panel is new to the annual healthcare cost trends hearing, and it's the first of its kind. And I have to say it's an absolute privilege to moderate this important discussion focused on pharmaceutical trends, particularly at this pivotal time as Massachusetts implements new policies to expand oversight and transparency across the healthcare system. As commissioners, part of our charge is to understand how each segment of the healthcare system contributes to the broader goal of improving health outcomes for patients. The pharmaceutical sector plays a critical role in that ecosystem, not only through scientific innovation, new cures, new treatments, but also through its potential to support system-wide savings and ultimately sustainability. The purpose of this panel is to examine the evolving dynamics of the pharmaceutical market, including trends in drug development and innovation, much of that innovation notably happening right here in our very own state of Massachusetts, which is a world leader for that ecosystem, and to explore how these forces shape healthcare access, equity, and affordability in the Commonwealth. The discussion brings together leaders and experts from across the healthcare system to share their perspectives on how to balance and ensure that we're catalyzing new innovation, new discoveries, while doing it in a sustainable way. I look forward to a robust discussion about how we can align policy data and a diversity of stakeholders' perspectives to deliver on that shared goal. On this panel, first, Sarah Emond, President and CEO, Institute for Clinical and Economic Review. Patrick Gilligan, President and CEO, Point 32 Health. Marissa Schlafer, Vice President, Policy and Regulatory Affairs, Optum. Tracy Sims, Executive Director of Corporate Affairs, Eli Lilly and Company. And finally, Matthew Vino, Executive Director, Group Insurance Commission. Welcome. So, as the moderator, I get the opportunity to serve up the first question. What we'll do for the first, before I turn it over to other commissioners, is ask a question for all of you to go down the list. And perhaps, Matthew, we'll start with you and kind of go down from there. And I give you an opportunity just to both introduce your organization, but also the importance of this topic. And the question that I'd like you to focus on is, pharmaceuticals are essential for treating, preventing, and curing diseases and improving life expectancy, health outcomes, and quality of life. As stakeholders, all of you across the healthcare system work to balance this innovation, access, and affordability. It's important to understand the respective roles and responsibilities of each participant in contributing to patient outcomes and system sustainability. Broadly, please share, what is your organization doing to promote the goals of innovation, access, affordability, and also equity with regards to prescription medicines? And perhaps, what do you view as the most significant challenges in achieving those aims?
Thank you, and thank you for the opportunity to be here. Thank you, Chris, for that question. So at the Group Insurance Commission, as I'm sure most in this room are aware, we provide health insurance and other insurance benefits to 427,000 public employees, their dependents, and retirees. We do that through 4 different health plans and 1 PBM that we work in partnership with to offer those benefits on the health insurance side. So we, as part of that, we select vendors that we believe help us to achieve our goals on our 3 core priority areas of affordability, health equity and behavioral health access. And we have structured a plan, a health plan that we think meets the needs of our membership. So if you think about public employees across the state, whether they're state employees or municipal employees, they are of relatively modest income. And we have a relatively diverse group of members. And so we have delivered a benefit that has relatively low cost sharing. We have broad formulary on the prescription drug side. We do have tiered copays on the prescription drug side, $100 deductible, but relatively much more comprehensive coverage than you would typically see in the rest of the insurance marketplace. That's what our members expect, and frankly, it's what they deserve for the public service that they do. So that's been very important to us, continues to be very important to me in my role. That is, however, becoming a lot more difficult to sustain. We have kept our deductibles and copays flat for 7 years. So when we see data of the type that Director Seltz noted there about rising member out-of-pocket costs, as a percentage of premium, our member out-of-pocket costs are actually declining. So on the pharmacy side, we see a trend that is accelerating, and it is accelerating at a rate that exceeds the rest of our benefit on the medical side, inching up to 12 or 13% increases every year, and it's consuming a larger and larger share of the benefit that we provide. So we want to be able to continue to cover our members with comprehensive coverage, but we have on the pharmacy side just some enormous challenges coming at us. GLP-1s for weight loss is certainly one that we have struggled with and many others have. I'm sure we'll have the opportunity to talk about that a little bit more. But I do want to say on the pharmacy side, it's not only GLP-1s. So we look at cost increases for a wide variety of other drugs that continue to put a lot of pressure on our budget for diabetes, for dermatological conditions, anticoagulants, cancer treatments, many of which, incidentally, have higher prevalence among BIPOC communities. So I would say that, you mentioned at the outset the principles of affordability. Really, I think you said sustainability, access, and equity, and balancing those. I would say they are not in balance today, and we need to rectify that. So it puts plan sponsors like the GIC in a position of having to really choose one over the other, right? So if we're going to continue to cover GLP-1s to treat obesity, which has high prevalence in BIPOC communities, it makes it a lot more difficult for us to have a budget that's balanced and we live within our means and we can actually say it's sustainable.
Thank you. So Tracy, we made it 3 minutes into the panel before GLP-1s. I know for you, that's probably the longest you've gone all day without hearing that, so welcome.
Thank you very much. And I'd like to recognize and thank the chair and all of the commissioners, as well as my co-panelists, for the opportunity to join you all here today. This question on access, affordability, and equity is an extraordinarily important one. And as I think about what does Eli Lilly and Company do in those areas, first, the core of our entity is science. One of our main responsibilities is to continue to invest in leading research and development to find medications to help resolve serious health conditions. Last year, Eli Lilly and Company invested $11 billion in research and development. And proximal to our discussion, one of the outputs of that is a new oral treatment for obesity,
which, if approved by the FDA, will come to market at even a lower price than the existent modern medications. I think a second responsibility of our organization is data generation. Health policy, health delivery are complicated. And in order to engage that complicated environment, we need data to inform better and more precise decision-making. To give a few examples, in just the last year, 4 different New England Journal of Medicine studies supported through our clinical trials reported on findings in a 94% reduction in risk for type 2 diabetes for individuals who had prediabetes who were treated with tirzepatide. Over a 60% reduction in the indices used to measure sleep apnea. A separate study reporting 38% reduction in secondary issues caused by HFpEF and a 52% reduction in hospitalizations. A separate study still showing, as it relates to liver disease, MASH, significant reductions. I'll highlight one other on a much broader scale. Right now, we're about halfway through a 5-year study with tirzepatide that includes 15,000 patients and over a dozen outcome measures. More to the policy discussion, we have supported work specific on the economic impact of obesity to the state of Massachusetts. Be happy to share more on that as we continue our discussion. We have also published separate studies on the impact of the disease economically to employers, and it is the only study to report on the impact by sector. Interestingly, the sector that suffers the highest costs is the government sector. As it relates to health equity, we have released the most in-depth report on the economic impact of obesity by race and ethnicity. And finally, just this week, we have released the first literature review of all literature examining cost savings associated with obesity care, publicly available. As a final and important comment, our responsibility is to bring these medications to market in a fashion that is broadly affordable. We do that through collaboration with leaders such as yourselves and by making bold decisions, such as the announcement our company made this week, significantly reducing the price of tirzepatide and making an additional bold decision about our forthcoming medication, orforglipron, if approved by the FDA, representing over a 70% reduction from the launch price in the medicines in less than 2 years. Thank you.
Thank you, Teresa. Welcome, Marissa.
Thank you. So OptumRx's role as a pharmacy benefit manager is focused on making sure that patients can get most safe and effective medications, but doing it in a way that's both affordable for patients and affordable for the payers that cover the majority of the cost of those medications. PBMs, with so many new medications coming to market and the affordability issue, as you allude to, PBM's role is trying to make sure that these medications stay affordable for our clients and the payers that have to cover them, whether those payers be small employers, large employers, unions, government payers, health plans. Our role is to negotiate with pharmaceutical manufacturers who set the price of drugs, and then we have the opportunity to negotiate on behalf of our clients to try and get medications to be more affordable. As you've alluded to, and I think as others have, the cost of drugs in this country continues to increase. In 2023, the median annual cost for a new medicine was $300,000, which is a 40% increase over just 2 years. And so each of these medications, and we definitely want to acknowledge that each of these medications bring new clinical opportunities to treat diseases that may not have been treatable in the past. But they come at a cost that may not be affordable for our clients and for payers, other payers and patients. OptumRx's role is to aggressively negotiate with pharmaceutical manufacturers to try and make drugs more affordable. Our negotiated discounts and clinical tools deliver more than $2,000 per person in annual drug savings. And it's important that PBMs are the only entity in the drug supply chain that are focused on keeping medications affordable for payers and for patients. Although more than 90% of prescriptions today are generic medications, negotiated discounts are the only check on manufacturers' prices being set for brand name medications. So our job in that supply chain is to keep the medications affordable for patients and for the clients that we serve.
Thanks, Marissa. Welcome, Patrick.
Thank you, Commissioner. Thank you to all the commissioners for having me here. Very happy to be here today, and this is a very important topic. I'm the president and CEO of Point 32 Health. We operate 2 brands in New England, Harvard Pilgrim Healthcare, which offers commercial insurance to individuals, small groups, large groups, both on a fully insured and a self-insured basis. And then under the Tufts Health Plan brand, we offer Medicare Advantage plans. We offer dual eligible plans and participate with the Medicaid ACOs here in Massachusetts and in the Rhode Island Medicaid program. We operate in 5 states, and I've been in this position for 4 months, and my charge is to keep us a regional, local, not-for-profit health plan, and that's what I'm focused on. So as a health plan, our job is to offer accessible care that's affordable and that's equitable. That's what we do for our customers, whether they're individuals, the government, or they're large or small employers. On the access side, I would say we do a pretty good job. We've got very broad networks. We have national coverage, by the way, even though we're a regional payer. We are making investments in places where access is a little bit challenged, perhaps in behavioral health and primary care, which it sounds like you all talked about this morning. And we're very focused on that, and our customers want that. I'll save affordability to last. On the equity side, we have a number of robust programs around maternity care and postpartum care, around substance use disorder, and other equity issues. We were the first health plan in New England to be accredited by the NCQA for health equity, and we're very proud of that. But right now, our focus is on affordability. And Director Sells, I really appreciate the presentation that you just gave before this and the fact that you focused on the commercial population. Because while we're all worried about the government programs that we operate in, it's the commercial lives, the members that we serve and the employers that we serve that are really suffering economically at this time. For 2026, the range of rate increases that we put out, premium increases, was between 11% and 40%. Okay, many were 15, 18, 28% increases they were giving. 1-year increases on January 1st that we're putting into the marketplace. It's not good enough. We're all feeling like we're in a place right now where both providers, health plans, and other actors are suffering economically, not performing well, and all wondering what we need to do. Now's the time to focus on affordability. We're seeing issues coming from the federal government around coverage for Medicaid, and we're all concerned about the impacts of these. We should be. But all of this just points me to the fact that we have to focus on healthcare costs. Everything we do, all the levers that we pull tend to focus on revenue. How much of a rate increase can I get from a payer? How much more premium can I put into the marketplace? We're failing on affordability across the country, but especially as Director Sells showed, that we're failing here. And we need to improve on that. And we need to focus on costs. We need to partner better together. We need to innovate on cost savings. My whole career, the estimate of the waste in healthcare has been between 25 and 30%, and it's still around 25%, and we're not doing anything to get at that waste. We see large trends coming in medication costs and new medications, and we all want that for our family, friends, and loved ones, but they are literally becoming unaffordable, and we're having to make very difficult decisions like deciding to back off of GLP-1 coverage for obesity in January 1 for many of our customers. You asked Commissioner Liebman sort of what are the challenges, and I could go on for a while on the challenges, but I'll just say two important challenges which I think we need to recognize, and they're both around what I call cost shifting, okay? In the United States, the government programs, Medicare and Medicaid, basically set the rates that they pay providers. And if providers see costs going up more than that, they try to cost shift onto the health plan and give larger increases, such that right now, on average, across our markets, for hospitals and physicians, we are paying 200% of Medicare, 2 times what Medicare pays. When I started in this business, HMOs were going to hospitals offering 98% of Medicare, trying to get a 2% discount off of Medicare. Now we've paid for all the Medicare inflation and doubled the rate, over that 25-year period. On the pharmacy side, I see a different cost shift, okay? And it's more international, okay? Most other developed countries have laws in place that they will only pay for the cost of medications, okay? There is tremendous innovation going on in the pharmacy space with Eli Lilly and others, and we all benefit from that. But this country is paying for all of that innovation. A RAND study from 2024 showed that for brand name drugs in America, we're paying 4.22 times what it paid in other developed countries, 400% more. So all the innovation is here. So that's another cost shift that is coming to our government programs and our commercial programs. And I think those are 2 of the things we need to focus on going forward. Thanks for having me here.
Thank you, Patrick. Yeah, having spent half my career outside the U.S., it's a unique system that we have here, certainly, and I think that'll be part of the questions and the discussion here. So thank you. And finally, welcome, Sarah.
Thanks. Unique is one word for it, Chris. I sometimes say hilariously American when we're trying to talk about the differences and how we do things. It's a real pleasure. Thank you to the Commission for the opportunity to be here. For those who don't know, ICER is an independent research organization that's producing information to help us know what a fair price is for what we pay for in healthcare. We do most of our work in the prescription drug space because it offers a unique opportunity, tremendous innovation coming with a government-granted monopoly. And so sometimes that makes us go, and then how do we decide what we pay for that during that monopoly pricing period when there's no competition? Our work is anchored on the idea that prices can reflect how much better the drugs are helping patients feel and live. And you can do that by looking at the data produced by the manufacturer themselves. And a lot of times our research shows that those prices are fair. About 30% of the time when we do our research, the manufacturer has priced the drug in line with the benefit patients are receiving. And that means 75% of the time they're not. And what we have is a situation where we have been poking at this problem with a set of solutions that have not centered affordable access for patients for so long that we get to the moment where we have some tremendous innovation like the GLP-1s, and we're freaking out about how to pay for it because there's so many people who are eligible and we have overspent on pharmaceuticals for so long. And so I am here today ringing the same alarm bell that y'all have been ringing all day. I was watching from my desk this morning. This is an affordability crisis. We cannot sustain the premium increases that are here in front of us. As a small business myself, our premiums have increased double in 4 years. This is real for those of us trying to do right by our employees who are trying to do right by their patients. And so one of the key challenges that I see in this particular space is that we don't have a lot of transparency into what's actually happening in the drug pricing supply chain. With all respect to my colleagues who are here from the PBM industry and from the manufacturers, they sign secret contracts about what the net price is that they're willing to pay that none of us have access to. And so then it gets really hard to actually know, are we paying for value? What are we getting for that spend? So there is actually something to be commended about the recent announcement on the prices for the GLP-1s, because now we know. So there we have an example of some net prices that we're all kind of aware of and what we're paying. And we need to see more leadership from all of the entities in the supply chain so that we can at least start to answer that question of, are we paying for value? And we need to recognize the market power that exists throughout this ecosystem. I mentioned the government-granted monopoly that allows the manufacturer to pick any price they want and enter into the negotiations. And we also have to acknowledge that the vertical integration that's happened, we have 3 PBMs who are doing the majority of the negotiating. Not that that is necessarily a bad thing, but it is worth paying attention to know what kind of power is being wielded and are they centering paying for value and making things more affordable. So those are questions that we need to ask. And I'll just offer that I think there's an opportunity for Massachusetts to lead here as it has in other areas. We can show how to de-escalate this arms race. There is a price that we can pay as a society that should come with very little prior authorization and hurdles and very little to no cost sharing. And if we commit to that type of grand bargain, then we can stop pointing fingers at each other about whose fault it is that we're in this situation. And it will take leadership from those who have benefited from the status quo to this point to do that. But we can make different choices. We are in this situation because of the choices we have made. It's time to start making different ones.
Thank you, Sarah, and thank you all for being here. I think you certainly have framed the issues around access, affordability, and innovation, and we can all hope that several years from now we'll be talking about different challenges, but they won't be the same medicines. That we can promise. 2015, we would have been talking about Hep C medicines. Now we're talking about GLP-1s. That's one thing that changes, but the challenges still remain. I will say also, Director Seltz, I didn't realize how challenging it would be to be the moderator for this session. I'm not good at a moderator. I'm much better on the panel. So many of you are friends, and I've been on other panels. So I just want to make my own comments. But I have other commissioners now giving me the question and answer, and so I have already a short list of individuals. But I'll start with Commissioner Kapad.
Thank you very much, and thank you for your comments. If you think the pharmacy supply chain is not transparent for all of you, imagine how it is for us. You know, it's even worse. So I fully appreciate your comment. Since the topic of GLP-1 was brought up, I want to start there as a lessons learned. I'd be interested in your thoughts on looking back at GLP-1, and that won't be the only blockbuster drug, right? Because you've got hypertension coming, that's 3 years out, it's going to be huge. How, as an industry, should we start thinking about affordability? Okay, and I mean, I can be provocative. I could say, you know, some of this could be if we take a multi-year approach in how we price for these drugs, we might be able to manage the affordability a lot better. So just think out loud for us a bit about, let's rethink how we might approach transparency, how we might approach pricing, and help us prepare for what's coming based on what we've learned from GLP-1.
I'm happy to jump in first there. Excellent points. I think that I often talk about how if we don't figure out how to provide affordable access for GLP-1s, we're shooting ourselves in the foot for that innovation that you're mentioning. Imagine an effective therapy for Alzheimer's, the hypertension, some of these other incredibly important public health needs and clinical health needs that could be addressed for a large population. We had a white paper out in April of this year talking about some of the policy solutions specific to GLP-1s because it will take some creativity. Now, step in the right direction with the lowering of the price that was announced last week. Also, the availability direct to consumer. That's not a perfect solution. It's going to work for some patients, not all. I do have health equity concerns about DTC, so please don't think that I'm saying that's the solution to everything. However, it is a part of the solution. There are also some innovative things that were tried with hepatitis C. Thank you for that, Commissioner, that reference, like Netflix models, subscription models, fixed budget approaches for purchasers, because what I hear from purchasers and plans is it's the uncertainty of how much they're going to have to spend in the GLP-1 space that's really driving the challenge. And so in exchange for a fixed amount, can a manufacturer provide as much as possible? The other thing that's happening in the GLP-1 space that I think is worth watching is the overlap with digital health solutions. There are companies that are offering purchasers the ability to manage the all of their employees with obesity And it doesn't mean they all jump to a GLP-1 immediately. There are some patients for whom other interventions are going to be more appropriate, that will work better, that are sometimes cheaper or generic, and it comes with some lifestyle management approaches that really help even those who go on GLP-1s manage their side effects, stay on therapy, because that's another key part of the GLP-1 issue, is we want patients to stay on therapy probably for their lifetime in order for the health system and for them personally to get the most benefit. So there are some creative solutions that are being discussed, and I can't not mention also the role of competition. We have a robust pipeline here where we may see prices come down in a way that makes them more affordable.
Yep. If I may, just in follow-up to that, first endorse everything that Sarah just said. And look, I think where the pricing of these drugs, and I say sort of net pricing as it comes to the health plan sponsor at the end of the day, if it were a sustainable price, we should all be celebrating this innovation and all the value that it brings to our members. I feel very strongly that we should continue to cover GLP-1s for weight loss. I'm going to do everything I can to do that in my role, but I certainly understand why others make a different decision, because we are, the pricing of these drugs puts us really at a breaking point. And just think about that we're now talking about eliminating coverage for a drug that we all acknowledge is highly effective, for a condition with high prevalence and enormous downstream costs. We're making a decision not to cover that drug. Like I said, I understand why some have to make that decision. I may ultimately have to make that decision. I hope I don't. But that's the starting point here. At the GIC, of course, we cover state employees. We frequently have members who are with us their entire career and their entire adult lives, right into retirement. So if any plan sponsor is going to benefit from the long-term downstream greater health and cost avoidance, it's us, right? And I think to Sarah's point about a robust pipeline of alternatives, they can't come soon enough, but it does. I'm encouraged to see that the market may bring more options that can bring our costs down. The challenge for us, I think, I have a budget this year, and if my budget goes up 10%, that's an additional $300 million draw from the state budget at a time when we all know that that's a really difficult ask. So my hope is that we can, that the grand bargain that Sarah talks about could be on the table. What I would encourage manufacturers to think about is to ditch the old model. I'm hoping that GLP-1s sort of highlights the problems and the deficiencies of the traditional market strategy on these drugs, which is you hit the lottery with this one drug that is amazing and effective, right? You gain maximum profit and revenue to the company as long as you can until the market adapts and evolves. My hope is that this will change some of that thinking. Subscription models, global budget models. What I want is stability and predictability for GLP-1s. It's been, was published about the GIC's budget deficiency at the end of the last fiscal year, $240 million deficient to our budget. A quarter of that was the incremental, unexpected additional cost for GLP-1s. So that is not sustainable. So that sort of, solutions that can get us towards predictability, a rational pricing of these drugs, and the transparency that we need that Sarah mentioned, critical. So if there's a 70% decrease in the price of the Lilly drug off of list price, tell me what the list price is. Like 70% off of what, right? So the transparency is critically needed.
I'm happy to build on Matt and Sarah's very important comments. The list prices are all public. $1,086 is the list price for Zepbound. This is such an important component of the overall discussion. I think one thing that is helpful in the discussion, and then I'd like to get into a little bit more detail, is what is the economic foundation for previously suboptimally treated obesity that this conversation is happening on? Those kinds of questions are important to us because they're part of the policy framing for the path ahead. In collaboration with a leading economist at Global Data, we've conducted economic impact analysis of suboptimally treated obesity for every state in the United States. Here are the figures for the state of Massachusetts. Suboptimally treated obesity in the state of Massachusetts reduces the GDP by $11.8 billion per year. It has a negative impact on the state budget of approximately $1.5 billion per year. About $454 million of that is due to increased costs borne by related diseases from Medicaid. So Medicaid costs in the state are almost $500 million higher due to suboptimally treated obesity. The state's revenue from tax income has been reduced by about $791 million per year. This is related to a very important fact. There are 55,000 people estimated in the state of Massachusetts who are unable to work due to their obesity. This most significantly impacts women. Our research finds that a woman with a larger body has a 20% lower odds of being employed. And when she is employed, she tends to make 9% less than a woman with a smaller body. Leveraging a microsimulation model, we looked out over 10 years for weight reduction across the population with obesity in the state of Massachusetts, the range reduction between 5% in body weight and 25% in body weight. Over 10 years, the potential savings is between $5 and $20 billion. So that's the economic foundation this discussion is happening on, specific to the state of Massachusetts. But let's look very specifically at pricing and price modification. It may have been lost to history. I certainly understand if it would have been, because it's a very specific detail. But when our medication was launched, Zepbound, tirzepatide, if you were just to simply compare the clinical trials between it and its nearest competitor, tirzepatide was a more efficacious medication. That has been proven in head-to-head studies as well. However, we launched our more efficacious medicine at a 20% discount to the first product in the market. So from the very first step, we recognize making every opportunity we can to improve access to the medication. Subsequently, the development and launch of Lilly Direct, which represented over a 50% discount to the medication if somebody does not have coverage for it from their employer and therefore their insurer. Last week, more specifically, the announcement we made will be $245 for Medicare, Medicaid. And as you look at our direct program, when approved by the FDA, the starting dose of the injectable version will be $299, with the other doses, the higher doses, being $449. When you look at the new oral option, if approved by the FDA, we have stated publicly, the starting dose will be $149. Other doses will be $399. So coming back to my earliest comments about our responsibility to drive research and development, orforglipron, I think, is a powerful recognition of that. Drive data to inform effective policy discussions. And then additionally, be collaborative and find methodologies to improve sustainable access to these medicines. If I may, just two other important points, I think. Number one, obesity is a complex disease in a population that has significant heterogeneity. There is an underutilization of every form of obesity care today. That means there's an underutilization in evidence-based behavioral therapy, there's an underutilization of surgical interventions, and there is an underutilization of both first-generation and modern medications. So I really want to put an exclamation point on Sarah's comment that to treat obesity effectively, we need to do a better job of leveraging every tool in the toolkit, which is now comprehensive, and get the right therapy based on the needs of the patient. That helps improve value in the overall treatment of the disease. Next, we need to use evidence-based treatment guidelines, which is not something that I've heard come up in any panel today. For diabetes, the American Diabetes Association is an example that has evidence-based, clear treatment guidelines. For obesity, the Obesity Medicine Association, the Canadian Association, which others are mimicking, and the Obesity Association, which is a new arm of the ADA, has put out the first 2 chapters of its clinical care guidelines. We've been happy to support work at Tufts, which just in June of this year released a pathway for the effective and efficient treatment of obesity. So we're happy to do that work right here in the state of Massachusetts. Thank you.
So we've got other commissioner questions, but because we gave so much time there, I know, Marissa, I could see you leaning in. I'll give it to you, and I'll ask when the other commissioners ask your questions, maybe direct it to one member on the panel so we can kind of get to a few more.
I'll try and keep it short. And I think I just wanted to reflect on some of the things that my counterparts on the panel have mentioned. And the biggest thing is these drugs truly have value and such important value. And are bringing, as we look at our clinical work, the work that ICER and others do, cost effectiveness is these medications are bringing a lot and are cost effective. The problem is that cost effectiveness and affordability don't necessarily correlate. And that's one of the things as we work with clients. Our clients and our customers are struggling with, we know these are good drugs, but that doesn't mean that they're within our budget. So, ours is how to deal with cost considerations that our clients have. And I think as we do that, we need to make sure that regulators allow us as PBMs the ability to work with each of our clients and figure out how these medications fit into what they can do. People aren't not covering GLP-1s because they don't think they're good medications. They're not covering GLP-1s because they can't afford it. And I think PBMs bring tools to the table, let us work with individual patients and tailor how we cover these medications in a way that works for a payer and in a way that works for patients. So I think making sure that PBMs have that flexibility. And then just to talk just a little bit about the transparency side, we know the list price of these drugs. Our clients know what we negotiate in rebates and how much we give back to them in rebates. So that information on what the net price is to our clients, that's not some black box. It's not hidden. It is available to those who are paying for the drugs.
Commissioner Erickson.
Thank you. Marissa, I want to dive in a little deeper into an affordability challenge, which is rebate and formulary design. So I share the goal of wanting affordability for both patients and payers. And as I look at formulary design and pharmaceutical benefit managers, and including OptumRx in particular, there's this really interesting complaint by the Federal Trade Commission about OptumRx, excluding low-cost drugs in favor of high list price, high rebate drugs from its formularies. That doesn't seem to be in the interest of payers or patients who then face this high cost sharing. And so I'm wondering, is there any economic logic for excluding these low list price drugs, sometimes even from the same manufacturer, that would be cheaper for the payer, cheaper for the patient, from their formularies? And is there any rationale for not passing through those rebates to the patient and instead making those patients bear those higher costs?
I'll try and hit a couple of those questions all at once. I think, first of all, just to speak in general, not specific necessarily to any one drug, our decisions about formularies, first of all, just always start with a clinical basis. Our P&T committee, which is our Pharmacy and Therapeutics Committee, which is made up of 12 outside physicians and pharmacists, do the basis. That's the first cut on any formulary decision we make. And those P&T committees meetings are held in a way that's open to our clients. Our clients have the opportunity to sit in and listen to the discussions that the pharmacists and physicians on that committee make. Once we hear from the clinical side the most safe and effective medications, then it goes to that fact where we negotiate with pharmaceutical manufacturers to get to the lowest net cost. Our goal is always to get our client the lowest net cost. Sometimes we would love it if pharmaceutical manufacturers would lower the list price, as we are somewhat seeing in this week. We're all of a sudden seeing for the first time pharmaceutical manufacturers lower list prices. If pharmaceutical manufacturers will lower list price to where that is the lowest net price for our client, then that's the medications that are chosen. But if there is a lower net price, a drug that may have a higher list price, but because of the rebates are most cost effective for our clients, we make sure that our clients get the lowest net price of the drug. So
But that's not always in your interest, right? If you look at the way you are making money on these contracts, it indicates that you have an incentive to get high rebates. So it may be the case that you would like to deliver it to the payer. Maybe you are delivering it to the payer the lowest net price, but your incentives aren't always aligned that way.
So OptumRx negotiates rebates with manufacturers. Across the board, over the last several years, 98% of those rebates are transferred back to our clients. Of our 5,000 clients, there's about 200 of them that have chosen to have us retain some of the rebate rather than them pay us administrative fees. But we did make an announcement this January that we are moving to a place where 100% of all rebates that we negotiate with manufacturers are being passed back to our clients. We don't keep those rebates, or we will not be keeping any of those rebates. And at this point in time, we only keep rebates for those small number of clients that have asked us to do so instead of them paying us administrative fees.
Commissioner Caljo? Oh, sorry, please go ahead,
Let me
Patrick.
defer to Mr. Gilligan before I ask my question.
Please.
Thank you. Just to follow up on Marissa's comments, we're a customer of OptumRx.
Pat, can
so
you
they
just
are-
pick up the mic?
They are our PBM, and we do negotiate rebates as part of that. But I think to the basis of the question, we really need to think about whether rebates should still be in the equation. Okay? I talked about in my opening remarks that we don't focus on costs enough, we focus on revenue. And in a weird way, what happened with rebates is they became revenue to different entities, whether the PBM kept them or they went to the health plan and or they went to the employer. I had a customer once that was self-insured, much like Matt is at the GIC. And one of their executives wanted to go to a low-cost, no-rebate model. But the HR executive said, well, no, those rebates, I get $150,000 a year in my HR department, and that helps me pay for another program, so I don't want to get rid of those rebates. They just became twisted, and we all got too used to them, and they're making the cost much more opaque. And so I think it's just time to move on for rebates and get to the lowest cost.
I'll start just by saying thank you to the panelists for being here. Two of you are licensees of the Division of Insurance, so it's nice to see you here. I appreciate and was interested in watching the show 440 miles southwest of here down in D.C. last week. I look forward, since most of our residents are in commercial coverage, look forward to seeing those same price concessions being put forward here in Massachusetts and across the market. It's a question for Sarah, and I call it MISER in my mind. Is there a way that we could create a Massachusetts version of ICER as a gating mechanism for the introduction of innovation and therapies and treatments? We're at a stage now where we've left behind in the era of hard choices. We're at the era of bad choices. And what are your thoughts? And maybe explain a little bit about ICER's role.
Yeah, and I appreciate that question. And I didn't mention this in my opening remarks, but all of our information is free and available on our website right now for people to use. And so we do have a number of states, purchasers, the size of MATS, and other big employers that are using our work and trying to get to that de-escalation that I was talking about, moving away from rebates in a lot of cases, paying for value, having that transparency, and then making sure that's also coming with, and I just want to make this point again, addressing some of the administrative burden that we heard about this morning from the provider groups who don't want to have to spend a lot of their time and energy on paperwork and prior authorization, and then of course the cost sharing that we're seeing shift to patients. And so there is the ability to choose a different path. So if you would like a Massachusetts Institute for Clinical Economic Review, let's talk some more. And we're ready and willing to work with anyone who's interested in trying to make different choices. And like I said, the information's freely available, and however we can be supportive for the commission, the division, excuse me, we'd like to be.
Question.
Please.
Hi, thank you very much for your comments and your contributions. So I want to revisit the topic of GLP-1s and obesity because obesity is clearly, it's a health issue that impacts all of us, but its impacts aren't distributed evenly across the population. And I wonder, I have actually two questions. So first, can you speak to the sort of the mismatch between who in the population is impacted by obesity, because we know that it impacts Black and Latino populations and other populations more so than white populations, versus who has access to GLP-1 drugs and who's on those drugs. I've seen some of that research, but I haven't seen the most up-to-date figures. So would appreciate if anyone on the panel could give us those numbers. And also, I just want to highlight the sort of prospect of plans dropping GLP-1s and the outsized impact that might have on communities of color, especially in Massachusetts. So turning to some of the numbers that David presented and some of the numbers from the cost trends report so far, we know that the families that are most impacted by healthcare costs as being a substantial share of their household expenses overall tend to be Black and Hispanic households. So the loss of coverage for GLP-1s, I imagine, will have a much more devastating impact for communities of color than for other communities. So the question I have is, how does each of your organizations envision that you'll be able to work to ensure equity in access to GLP-1s? And can you speak to any work that you've done already? So for example, Optum, in your negotiations, have you been able to leverage your size to negotiate lower rates or discounts in this regard? And that might also be a question for the drug manufacturer as well. Thank you.
Do you want to start down the line?
Well, I'll certainly leave it to others who may have more information about the specific data points. I will tell you that from my perspective at the Group Insurance Commission, the concern you express about equity, the equity of access to these drugs, is core to the decision that we've made to date to continue to provide coverage for these drugs for all of our members. If were we to make a different decision and eliminate coverage and leave it to individuals who wanted to gain access to the drugs through the direct-to-consumer channels offered by the manufacturers, we know how that will play out. Those with fewer resources simply will not have access, and we will not close equity gaps, we'll be expanding equity gaps. So even if the price of the drug is $150, $200, $250 direct to consumer, our copay for the drug today is $50. That is a substantial difference. And but let's be clear, like we are leaning into the equity element of this decision. We are paying elsewhere, right? There are other things that we cannot do at the GIC. There are other equity initiatives that we would like to put into place. I would like to be able to live within my budgeted spending authority over the course of a year. So you've put your finger on what I think is a really critical element of GLP-1 coverage.
As a health insurer who made that decision to stop coverage, maybe I could just explain a little bit more, because I realize our discussion around GLP-1s has been specific around the pricing. And yes, we are eager for lower pricing and think competition will do that. And we'll be looking at that very carefully. But I want to be clear that this was not an isolated, the GLP-1s weren't an isolated drivers to say, I can't afford that anymore. In 2024, most insurers across the country, not-for-profit, large for-profits, saw unsustainable trends that were not priced into their premium around other things besides medications, other medications besides GLP-1s, high-cost medications, as well as more surgeries, inpatient care, et cetera. And it was the combination of those two things hitting at the same time that put us in a very difficult place in terms of trying to figure out how we could course correct. And for that reason, we and many others sort of backed off on the GLP-1s. Like you, we share the concerns around equity, and we think these, to other people's points, are very high value. But Marissa touched on it a little bit. There's a difference between being cost efficient and being affordable, because the people paying the cost are not always the people that are getting the benefit. And we need to align and get incentives together over time so that we can equate those things. Sarah has pointed out in some of her work that while these drugs are cost efficient, much of the benefit will accrue to Medicare as people ages. And so, but Medicare didn't pay for that. And so I think there's ways to get creative around how we pay for some of these expensive therapies over time and find different payment algorithms to align that to put us in a better position to cover these for everyone.
Oh, please go ahead.
Either way. I want to address your question about the coverage of the various GLP-1s. I don't want to misspeak, so I'm not going to speak exactly to the exact cost because I don't have that information with me. But I do think it's really important. The way we do our job is if there's 2 or 3 products out there, 2 or 3 GLP-1s, 2 manufacturers, we have the ability to go out and negotiate with both companies. First of all, we go back to our P&T committee and we say, are these drugs equal? Is one better than the other? If they tell us one is better than the other, then that, we follow that clinical direction. But if they tell us that both drugs are equal and that they say you need 1 or you need 2 on formulary, but you don't need all on formulary, that gives us the opportunity to go and negotiate with the pharmaceutical manufacturers, get those rebates to lower from that high list price to a lower net price, and make that more affordable to our payers. Not necessarily that every payer will then decide to cover it, but it makes it more affordable for the payers. We have to have that ability to negotiate between the 2 companies, and then we have to have the ability to direct, to use the formularies, to use prior authorization, to identify a way to prefer the medication that is most cost effective. So yes, if there's more than 1 product out there, we can use our negotiating ability to lower that net price, which is what the payer, the employer, the health plan, the union ultimately pays. And therefore that usually lowers what the member pays, depending on that benefit design that is designed by the labor union or the employer or the payer. I don't know if does that somewhat answer your question?
It does, partially, but the element about equity, does Optum have any programs, initiatives, any way in which you're considering equity of access as
We do have programs where we're looking at the impact of GLP-1s on various groups and consider that that equity information. We share that with our payers. Ultimately, the payer, whether it be the health plan or the union or the employer, designs their benefit and makes the ultimate decision on whether or not they can afford these drugs. So that information is all part of what we share, but benefit design is very much the decision of the employers and unions and payers that we work with.
Okay. Thank you.
Dr. McGregor, thank you very much for that question. I'll just very briefly add that we are committed to working directly with decision makers on access to medications. I and other members of our team spend a lot of time on the road. I was joking with colleagues that right now it's all cities that start with B. In the last couple of weeks, I was in Baton Rouge, and then I was in Birmingham, and I'm glad to be in Boston this week. But we are dedicated, and I think the recent announcement that our company made on the updated pricing is a strong example of that. We're ready to sit down in an ongoing basis, because we have been, with leaders in Medicaid, Part D plans for Medicare, and commercial organizations to find pathways to broaden sustainable access. So I'm ready to be back in Boston and have that conversation anytime.
Thank you.
So maybe I use the opportunity to ask the last question, since I don't see any new nods coming from the commissioners, and it's to use the GLP-1 to kind of move us to a future forward discussion briefly, and that is, I made the comment earlier, and Sarah had a good response, which was unique on Europe versus U.S., and it was never to suggest that our system is better or worse. And I would never, if I had the country to point to, I would. And they are just as perverse and have all the challenges we're facing here they're wrestling with. So I don't want to give the impression that we have challenges that they don't face. They most certainly do. There is one thing I noticed being there, though, that they put effort into, and it is very much around horizon scanning, specifically to pharmaceuticals, and trying to look out 2 or 3 years, 4 years in the future to understand what do we need to be ready for. And so I'll ask, for any of you who'd like to comment, GLP-1s feel kind of like we used to talk about the hepatitis C medication. Like, where did these come from? When everyone had known they were coming for many years, and suddenly we act as if they were suddenly discovered when the science had been going on for 15 years in labs in Cambridge. And so I look at this situation, just think 3 to 4 years. Would it be more helpful? Is there some opportunity there for us to be more forward-looking with regards to what challenges we will see specifically? And this doesn't address the immediate cost curve, but it could talk to solutions for the future, for how do we get ahead of some of these challenges. So I don't know if any of you have thoughts on that. I know, Sarah, you've given thoughts to these topics before. Maybe you help with that.
Really appreciate that question, Chris. Cell and gene therapy, as we didn't touch on today, but continue to be something that's important to pay attention to as an area, because this is another area where our payment system has not evolved to meet the science. In a lot of these therapies, you're getting a tremendous amount of value for patients in a one-time treatment, which, using a value assessment approach like ICER has, means it can command millions of dollars for that therapy in terms of the benefit it's delivering. But our health system or our payment system has reacted in a freak out kind of reaction of I can't pay $3 million for this. I can't afford this year, even though it is a high value. So there's work. I think Tracy was referring to the New Digs program at Tufts to definitely pay attention to some of the policy innovation that they're putting forth for how to evolve our payment system to pay for cell and gene therapies. I would also pay attention to oncology as a particular therapeutic area where there's tremendous innovation, and there's a lot of talk of combination products. And I don't know that we've done a good job as a pharmaceutical policy area to understand how to think about the value of combination products. What if something's part of it is generic? What if it's two generics that they combine? I think there could be some really interesting questions that come up for the system on how to pay for some of those therapies. So that's another area that I would watch. But I think it's a great way to be thinking forward. Chris.
I think I would just briefly add that there's a lot of benefit to proactivity, and I know that we'd be open to discussions with individuals looking at pipeline. I think that's what you're really alluding to, and what is the science forthcoming. my colleague Sarah, expert in so many areas, mentioning cell and gene therapy. I think that is a fascinating area of science, bringing remarkable cures, essentially, for complex diseases. I know that we've released information recently on our wholly owned subsidiary, Akuos, and a gene therapy for hearing loss, and the remarkable effects it's having on children who otherwise would not have the sense of hearing. So I think proactively, having conversations and looking at what's forthcoming is something we certainly would be open to.
Commissioner, I appreciate the way you framed the question, because we spent a lot of time in this panel around the GLP-1s. My head went right to where Sarah's did in terms of cell and gene therapy. We've been talking about medications that cost maybe $8,000 a month and that are valuable to, a large percentage of the population. If you go to cell and gene therapies, you're talking about medications that could cost $1 million to $4 million for one dose that will be curative for the rest of your life. And so any work that we can do around affordability and payment mechanisms to make GLP-1s available, I think will set us up for the horizon that you were talking about. I'm told there's only about 43 approved cell and gene therapies, FDA approved in the United States today. There are 4,000 in the global pipeline. And so I think in terms of your horizon, we should all be looking there.
Yeah, and I would just say, to your point about GLP-1s, we knew this was coming. I mean, I knew probably 2 years ago that this wave was coming. So knowing in advance didn't help me a whole lot. All it did is give me a scale and a sense and a magnitude of the bill that was coming, and it came. So look, I think having that longer-term view, I think generally, sure, helpful. But if it's not paired with a different way of thinking about how we pay for these drugs and getting away from what Sarah described as this arms race mentality, we'll only get a better sense of the trouble that's to come, right? Without really being prepared to actually do that, or to handle that problem. So risk-based payment methodologies, subscription-based models, something that can give me sort of predictability, sustainability over a multi-year period. Those are things that I'm all ears on, and they're the sorts of solutions that, the way the market is set up today, both the manufacturing market and the PBM market, just don't lend themselves to those kind of conversations. So my hope is that the GLP-1 kind of crash of this wave on payers will prompt different kind of thinking, right? We are certainly, as a purchaser of 467,000 insurance for 467,000 people, we're interested in those sorts of conversations. We're somewhat hemmed in by our PBM contract, but we're going to be reprocuring that in the not too distant future, precisely to give us the opportunity to do these sorts of innovative things.
Thank you.
Thank you.
I think to wrap up, if I would say many of the same cell and gene therapy comments that were made earlier, but in respect of time, I won't repeat the things that Sarah and Patrick have said, but I think what's most fascinating to me, and this is not so much 3 to 5 years as maybe hopefully 1 to 2 years, is it's been really interesting for us to follow, and don't have enough information yet because of announcements just made in the past week. But some of those announcements that have come out of the announcements last week about a lower MFN price for the GLP-1s and other medications, and how all of a sudden manufacturers have lowered the list price, or lowered the price that they're talking to the government about so significantly. And in the last administration, the average manufacturer price and the caps on those, we've seen manufacturers lower prices. And so to see where that takes us in the next coming year, I do think there is the potential, or we're starting to see the potential in the last couple of weeks, for manufacturers to lower list prices. And ultimately, that's what we want to see. We would love to see manufacturers lower list prices and not have the net prices and the list prices be such a differential.
Okay. With that, let me say to the first panel on this type of topic ever at the cost trends hearing, thank you. Thank you for your time. Thank you for your candor. I didn't promise you a fun experience, but I did promise you a productive one, a constructive one, and ultimately, I hope, a positive one. So I genuinely want to thank each and every one of you for your time, open candor, and participation.
Thank you.
Turn it back
Thank
over
you.
to Chair DeVoe.
Thank you. Thank you, Panel 4. We'd now like to welcome the members of Panel 5.
Hanging in there, Michael?
Hanging in there.
Terrific. Welcome. Welcome to the members of our final panel. And the focus of this panel is moving forward together, how CEOs are maintaining a focus on affordability in a time of uncertainty. The purpose of this panel is to welcome the leaders of healthcare organizations in Massachusetts who are navigating headwinds with the existing challenges of access and affordability, and to have an opportunity to reflect on how you and government together can work collaboratively to stabilize the healthcare system and address our pressing challenges. The themes for the members of this panel who weren't able to be here for the whole day, the themes, so that you know, were that while we all expressed that we were grateful to be living in Massachusetts and recognizing that the challenges that we face, given the level of collaboration between our state government and yourselves, the leaders of the healthcare system and the employers and organizations in Massachusetts, is very good. That we are the state in our country that has the highest healthcare costs, highest insurance premiums, highest costs for care, and yet our access is not ideal. So one could reflect that at the highest cost, if we saw that our access and our services were actually much better than the rest of the country, we might feel a little differently. That isn't our circumstance. So that's really led the discussion for most of the day to be around recognizing that there is not additional money to put into the system from anyone, from insurers, providers, governments, federal, state, probably less going forward from government, federal government. What can we do creatively, perhaps differently, both your organizations and government together? What can we do to make progress? So very much appreciate your being here to engage in that discussion. I'll ask the first question, and I'll ask each panelist if you could speak to this. Really a two-part question. First, what's your assessment of our healthcare system, meaning the Commonwealth? And secondly, what can we do? And I mean that collaboratively. What collaborative strategies could we pursue to address both affordability and access? And if I could start with you, Doug.
Hi, Doug Howgate, Massachusetts Taxpayers Foundation, and this is my inaugural cost trends hearing testimony, so very excited to be here today, and also know far less about healthcare policy than anyone else sitting on this panel, so thank you for having me go first. So to me, from a state fiscal standpoint, I think there are two things that are top of mind for me, right, which is the One Big Beautiful Bill, right, according to the Congressional Budget Office, that's going to reduce healthcare expenditures from the federal government by more than $1 trillion over the next 10 years, right? And so let's just prorate that out to Massachusetts. You're talking about $25 billion or so of reduced expenditure on healthcare from one of the major payers, the federal government in Massachusetts. That ramps up. It's not significant in these first couple of years, but it ramps up pretty quickly to about $3 billion per year, right? So to level set, you're taking $3 billion a year out of the healthcare system. And then I also think of the state budget, where the fiscal year 2026 budget that Governor Healy signed, put forward, which probably underfunds the state's Medicaid program, grew healthcare spending budgets that was signed the year prior to this year by 10%, right? And pick whatever revenue base you want, pick whatever tax base you want, it's not going to sustainably grow at 10%, right? And so when you think about reduced federal expenditure and growing pressure on the state budget, I think that's the public finance reality of the healthcare cost crunch. I think the thing where that's going to materialize in the first instance from a, again, public sector standpoint, that I do think affords an opportunity for, exactly as you say, a conversation about creative solutions about how we move forward here is, due to the changes in One Big Beautiful Bill Act, OB3, I'll call it from now on, we put out a report about 6 weeks ago where we estimate about 255,000 people will lose access to coverage either through Medicaid or through the state's Health Connector, right? And that doesn't include the subsidies that are set to sunset at the end of this year. The first thing that should, I think, create an environment for us all to talk together and work together is, it should be in all of our best interests to keep that number as low as possible in terms of people losing subsidized access to care, and to maximize federal resources still coming to Massachusetts for healthcare, right? And a lot of the changes that were made in OB3, certainly some of them we can't do anything about, but when you think about our policies related to how we use provider taxes, for example, effectively, how we set up the engagement requirements for Medicaid, those are things that we need to be working together collaboratively to figure out how do we mitigate those impacts. Those impacts are never going to be zero, and they're going to be significant. But I do think that the way that we can work together to kind of maximize continued federal support in Massachusetts, minimize those impacts, hopefully can also lead to a conversation where the reality is there are a lot of healthcare providers who are in tough fiscal shape right now, right? I think our payer community is dealing with some big challenges right now. And I think most importantly for all of us, residents in Massachusetts and employers are dealing with healthcare challenges in terms of both cost and in terms of access of what they want to get, right? So we're not going to get out of here free in terms of how we think about what those solutions are. And so how do we start to create an environment in which we can talk together about the shared sacrifice it's going to take to mitigate impacts? And I think that starting with the fact that it's in all of our best interests to reduce coverage loss and maximize federal resources could be a jumping off point for how we try to build some coalition of solutions here that are going to require sacrifice from everyone involved, but hopefully can kind of move the ball forward.
Thank you. And Sarah Islin, who's President and CEO of Blue Cross Blue Shield of Massachusetts.
Thank you. First, I just want to say thank you for the opportunity to testify. I hope you get to come back. I really, in all sincerity, look forward to this conversation and having the opportunity to be here and talk about what I think is one of the most pressing challenges we face as a Commonwealth. So it's a privilege to be here with Doug, with Zandra, with Manny, and with Kevin to be a part of this conversation. And, you know, Commissioner DeVoe, as you framed up, I do think there are some reasons for optimism that in spite of the challenges, there's nowhere I'd rather be doing this work. There's no community I'd rather be a part of when we're faced with something that's daunting than this one. And the way that you framed it up, this is going to be really challenging. It requires rethinking the role of government, how we work together, and how we pay for care. Not only in addition to all the challenges that Doug just so well framed up, more people are getting more care. So I know I heard in some of the earlier panels the observation about this cost trend that we're facing that's contributing to why we are not only back in that unenviable, most expensive place to get health care in the country, But there's, I don't think, any real sign of this abating, this pressure that we're all feeling. Our trend, compared this kind of rolling 3-month period to a year ago, has been running at about 14%. It's extraordinary. I've been doing this for 30 plus years, and I've never seen anything like it, where every month when our CFO comes into our company, for the last year and a quarter, every month has been a higher trend than the month before. And so for us as a plan, and was just alluded to, we will have collectively lost close to $1 billion on operations between 24 and our projections for 2025, because we just can't price premiums fast enough relative to this trend that we're experiencing. So that's right. But exactly as you just said, private employers can't make up the difference in the fact that there is going to be less money flowing into the state. Municipal employers can't make it up. They're already making hard choices in terms of buying new and needed fire trucks for their firehouses, not to mention the impact that it's having on residents of the Commonwealth. We've done a lot of polling, and in this state, even with the lowest uninsurance rate in the country, 40% of residents of the state report that they are avoiding or not getting care because of the cost of care, because they can't afford their deductibles, their co-payments. And so we really, I think, exactly just coming to terms with our only choice then is to do things differently. And that's going to require all of us thinking differently. It's going to require taking costs out of the system. It's going to require sacrifice and creativity from all of us, payers, providers. I love that inaugural panel that included representatives of the pharmaceutical industry. We're all going to have to put our heads together and give some things up. So we're working on it. About 10 cents of every premium dollar is retained by us as a health plan. 90% of it comes in and goes back out to pay for health care. But we're making some hard choices ourselves. We've sold real estate. We just put out to all of our employees, we have about 4,000 employees, a voluntary separation program that makes almost 20% of our entire workforce eligible to leave this year. Okay, I'm getting closer to the microphone. To retire, either at the end of this year or in early 2026, to try to take our own administrative costs down. We've communicated to the provider network. The cost trend benchmark that you have all set is something that we're taking very seriously, because the one thing that we can control, in addition to our administrative costs, are the prices that we negotiate to pay providers. And sending that message has resulted in some really tough provider negotiations, notably with UMass. So there was a Globe story I'm sure you woke up to this morning. This is not where we want to be. And yet I think it's just a reflection of the challenges that UMass, and I'm sure we'll hear about this from Zandra and Kevin, are really facing. These are real, but balance then between our job as a payer is not just to sit here as the CEO of a health plan, it's to represent the interests of employers, of consumers around what they can afford to pay for healthcare. So I'll kind of leave you with, I think there are 4 things. They're going to sound familiar because I think they're not dissimilar to what I said last year that I think we can do. And one is we need the state healthcare benchmark to be more than a target. It needs to be one that we are collectively as a community taking seriously, that has teeth and consequences for all of us, including us as a payer, if we don't honor, respect it, and adhere to it. So strengthening that role for government. The second is we need to continue to rethink how we pay for care. We've made a lot of progress in the state on value-based care. I think we've got farther still to go to align economic incentives to reward providers for doing this hard work, to change the way care is provided. The health planning work, I was thrilled to see that additional authority given to the Health Policy Commission, and we're leaning in with our foundation to partner so that we're really making good decisions for the long term as a state about the healthcare system we need. And then finally, the pain that we hear often about from providers about the administrative complexity and frustration of our healthcare system is real. We can do better. And I think it will be hard to do better if we don't have a data infrastructure that allows data to flow between all payers and all providers in this state in real time so that we can automate and simplify that administrative complexity. And I believe that's going to require a mandate. I think it will likely require a law from the state. That is something that we'd be willing to invest in and really lean in there. So again, there's nowhere I'd rather be doing this than here and with this, the leaders on this panel and in this community.
Thank you. Thank you, Sarah. Dr. Zandra Kelly, who's the CEO of the Greater Lawrence Family Health Center. Welcome, Dr. Kelly.
Thank you so much, and it's so great to be here. I really appreciate the opportunity. I think my being here also indicates that the Commission is very well aware of the role that primary care plays in decreasing the overall cost of care, and it's been shown over and over again to do so, especially community health centers, 50 across the state. So I would say one of the top things in my mind to help continue to decrease the cost of care is to make sure that our health safety net, those 50 community health centers across the state, do not close and are there to continue to see their patients and provide the primary care that's absolutely necessary for many, many of the people who live in Massachusetts. I think the other thing that struck me today, listening to a lot of the panels, was that there are a lot of cooks in the kitchen. And just as a healthcare provider myself, as a family physician, I definitely see every time there's a transfer of care from one person to another person, things are lost and the administrative burden gets higher. I'm just imagining, listening to so many people, there must be ways to make things more efficient that would cut costs out of the system without actually making enormous changes. I mean, even within our own community health center, we're constantly looking for ways to take the burdens away from the patients, taking the burdens away from the clinicians. And I would imagine that with so many interests, if there was to be a group that worked together to figure out what happens when I put this order in, how many people does it touch? And does it need to touch all of those people? Or can we simplify our systems to make it easier to get people what they need so that we can continue? I mean, it seems like we have a lot of money in the system. That's what I keep hearing. The people are paying it, the state's paying it. We have a lot of money. And it's amazing that we are still in this situation where we have such trouble, and it just screams to me inefficiencies in the way the system is designed. And I'm sure that if we had people come together and collaborating from all the different areas, there must be waste that we can find. Somebody else mentioned it earlier, the waste in the system that we could find to quickly, low-hanging fruit, what can we use to decrease that overall cost?
Love that. I hear that scream too, that scream you're hearing about waste, and particularly around administrative simplicity, because as the effort seems wasted, it's also so incredibly frustrating for both plans and providers. And I haven't been able to make a lot of progress on that in my time in healthcare, despite the fact that I completely agree with you that it's a huge issue. Thank you. And Manny Lopes, who's the president and CEO of Fallon Health. Welcome, Manny.
Thank you, Madam Chair, and it's great to be here. And thank you to all the commissioners for the opportunity to testify this afternoon. First, a little bit about Fallon Health, because we are a small, mission-driven, nonprofit, community-based provider and health plan. So we consider ourselves a health system. And we've been doing this for over 50 years, serving the most vulnerable populations within our state, from Berkshire County to Suffolk County. Our focus today is on government-sponsored programs. So we are rate takers, not rate setters. That gives us a unique perspective, not only being on the provider side of the business, which I'll talk about shortly, but also being a partner with government as we try to make sure our other partners can deliver the care that is needed to our communities. Our sponsored solutions include Medicare, Medicaid, senior care options, also known as SCO, and one of my favorites that many of you heard me talk about quite often here is the Program of All-Inclusive Care for the Elderly, also known as PACE. And I highlight PACE because, and I hate to put the commissioners on the spot, but has anyone visited a PACE Center,
Yes.
excluding the secretary. If you haven't visited the PACE Center, commissioners, as well as members of the audience and those who are watching remotely, I strongly encourage you to do so, because there's a promising program here that, quite frankly, Massachusetts was the first demonstration, PACE demonstration project in the country, bringing that program to Massachusetts in 1990. And what makes that program unique is that it is one payment system for all the members, for the care team. So we're not talking within the PACE program about prior authorization. We're not talking in the PACE program about referrals. What the team talks about within the PACE program is what's best for that patient and what's best for those families. Now, I know sometimes we can get caught up, and it's a very important part of the cost of care, which is the unit cost. But we can't forget about care management and utilization management. Because as much as we're paying, as we heard earlier, we're still not getting the outcomes we expect. So if we just change and really focus on the other variable of utilization, making sure people get the care when they need it, the care that they deserve, particularly in underserved communities, being a founding member of Health Equity Compact, we've done a lot of work thus far to bring and highlight and bring Massachusetts, making it the first in the country to pass legislation that would really bring greater focus to closing those healthcare disparities. But part of that is to make sure that, again, our focus is making sure people get the care they need, when they need it, at the right place, at the right time, at the right cost. And earlier this afternoon, the panel before us, or the program that the commission highlighted, which is fabulous, Hospital at Home, I'll highlight the PACE program again. It's been doing hospital at home for over 35 years. And in fact, the goal of the program is to keep these nursing home certified frail elderly individuals, 55 plus, is to keep them living happily at home and out of institutions. And I'm proud to say that Fallon has saved the state $55 million per year in making sure those individuals are remaining at home and families are happier and there are better outcomes because of it. So I look forward to continuing the discussion and providing you with more examples such as the PACE program. Thank you.
Great, thank you. And Dr. Kevin Tabb, who's the president and CEO of Beth Israel Lahey Health. Welcome, Dr. Tabb.
Thank you. Thank you for having me. It's good to be here. I have to be careful because I'm under oath, but I believe that I may be the longest standing witness that you've had in front of you. I think I've testified somewhere between 10 and 12 times in front of this commission over the many years. So good to be here.
So you're a greatest hits. We must really like you. We must really like you.
I was reflecting back on what is the same and what has changed over time. So you asked that we give our own assessment of where we stand and then to talk a little bit about what we should do. Let me start with the assessment. I would start, I think we should not ignore the fact that we do have a lot to be proud of. And there is a great deal to fix, but before we get to that, there's a lot to be proud of. I think when we look at access to care in the state, when we look at the quality of care in the state, it's really unrivaled around the country. And I travel a fair amount and hear from others, and I'm proud and glad to be part of a system and a state that is providing the kind of care it provides, but I'm also well aware that it is very, very expensive, and more expensive than most, if not all, other places in the country. And there's no way of getting away from that. You know, just still in terms of my assessment, there's a lot that I'm worried about too. I will say, thinking back to 2011 when I started in my role, there are fewer hospitals and healthcare resources in this state now than there were when I got here. And yet there are more patients, and they are more complex to take care of, and they are more expensive to take care of than when I got here. So we're facing the paradox of greater demand with fewer resources. And that burden falls on everybody in this system, first and foremost on patients and their families. But it falls on those who provide the care also. And we're seeing that every day. So there's a lot to be proud of, but there's also a lot to be worried about. When I think about, so what should we do about it? I think some of the things have been brought up already. There's certainly administrative simplification. There's certainly investment in primary care. I'll just point out, for instance, that my system has grown primary care by 30% over the last 3 years. I don't think there's another system in the state that has done that, and we intend to further grow it. So there are lots of things like that, but I don't think that's going to be enough. And I would suggest that at some point we're going to have to get beyond magical thinking. And I think that there has been, by all of us, some level of magical thinking for many years that we can put less money into the system and provide more care. And I don't actually believe that that's true. Sarah mentioned the fact that Blue Cross has lost, and Blue Cross is not the only one, lost staggering sums of money over the last year, and also mentioned that it was important to send a message to the providers. I would just suggest that in the last year alone, 16 of 22 hospitals in this state ran in the red and lost $1.4 billion collectively. So I don't think it's that we need a message sent to us. I think something needs to be done differently, and a message isn't going to do it. When I talk about magical thinking, what I'm talking about is the fact that I think that we're going to need to acknowledge that there's not going to be more money in the system, however much I would like to have it. And if there's not going to be more money in the system, something is going to have to give. And I'm all in favor of simplification, and we will do that. And I'm all in favor of us being more efficient, and we are pretty efficient, and we will continue to work on that. But that is not going to get us there either. I think the truth is that we're going to have a tough conversation about what services do we continue to provide and where. And I think the truth is that there's a massive duplication of services throughout the state. And I know for a fact that every time that we attempt to address it as a system and say, let's rationalize this, there's pushback. And I understand that pushback, but I don't know any other way of dealing with the larger issue than dealing with this. And, I think that there may be some members of the panel or of the commission who would say, let's just pay hospitals less. And that's a conversation we should have. But if we're going to have that conversation, then let's be honest about what the result is. And the result of that, even in the face of more efficiency, even in the face of new technologies, even in the face of new payment models, is going to be less provision of services. And if that's the case, let's get serious about that and talk together about how do we do that in a rational fashion. Because I think that there is a way to do that, but we've not done it to date.
Thank you. And very important point to reflect on the fact that it is challenging for any system on their own to try to rationalize because an individual community is concerned about any attempts to consolidate or manage services differently. Very helpful. Thank you. Thank you to each of the panelists on that question. Other commissioners, a question for panel? Yes.
I'll throw this out for anyone, but We're at a stage now where we know we need to do things differently. The status quo is not just unacceptable, but it's broken. People on the panel mentioned the need to take costs out of the system and make different decisions. What are some tangible steps that we should take as a group of stakeholders, both collectively within the private market on your own, but also what's a role that is really specific to government, where you need government to draw the map or change the rules so that we can do this effectively? And these are really hard questions, so I appreciate the fact that you're tangible and direct in your answers. I'll start with Doug.
Sure. So great question. And let me answer that in the context of the state budget, because obviously there's a lot more in the healthcare system than the state budget. But Mass Health is $22 billion of the state budget, right? And it's going to be under more pressure. The state budget broadly is going to be under more pressure as folks lose access to whether it's Mass Health or Connected Care. And, you know, we've seen some examples in recent years of, I think, how challenging effectuating even small levels of savings in the state budget as they relate to healthcare. And this is not unique to healthcare, right? Anything that the state does, I think this relates to what Kevin was saying, is if you pick a targeted thing to change and say, we're not going to do this anymore, the specific benefit of that to the broader system is usually less than the harm to the unique interest who cares about that thing, right? Like that's true. That's not an earth-shattering statement, right? And so, and the minor things that are going to take you from 10% Mass Health spending cost growth year to year to 5%, if we're lucky, let alone 4% or 3%, is a lot of those 30, 40, 50, 60, $80 million singles and doubles, right? And every single one of those has a very understandable constituency in terms of a patient community, a provider community, you name it, right? And one of the things the state in trying times, I think, can do well is start with the big picture number goal and then provide some level of flexibility with guardrails in terms of managing within that, right? So one of the things I would say to that is, as we look at the fiscal year 2027 budget process, which is about to start, is to say, and I'm not going to give you a specific percentage right now because I think that depends, but we need to live within an appropriation of X amount for the Mass Health program, right? And it's based on whatever assumptions of acuity and enrollment and things like that. And there are certain things related to patient coverages and programs that we provide that we are going to make sure are guardrails. And there needs to be some level of notification to the relevant stakeholders about when policies are going to change. But within that envelope, we need to empower Mass Health and EOHHS to develop a strategy to live within that larger appropriation. Because I think if you don't start from the big number and work backwards, and instead you say, hey, good news, we're going to save a lot of money, and here are the 19 things that are going to add up to that number, you are going to end up with 3 things or 2 things or 1 thing if you're lucky. And instead, it needs to be a little bit of a collective action. And the second point I would make from that, and this is, again, not unique to healthcare, there's no, in my opinion, no good guys and bad guys here, right? That we have a complicated system that provides care to every single person who lives in Massachusetts and tries to pay for it, right? That's complicated. There is not going to be any solution that is, and that's the group that's going to pay for it, or this is the group that's going to do well, and this is the group that's not going to do well. And that's why I like the idea of starting with the 255,000, 300,000, pick a number, a large number of folks who are potentially going to lose coverage through OB3 action. Can we start with, let's try to get that number as low as possible, right? Because 1, that's theoretically in all of our best interests. And 2, hopefully the policy decisions that get us there in terms of how we pay for the care of the people who are going to lose services, how we're going to change administrative structures to keep those people on care, it can start getting people with some level of comfort, which is never easy, that we're all going to have to sacrifice for this. So that it's not just going to be on the provider community. It's not just going to be on the payer community. It's not just going to be on the state. It's not just going to be on the life sciences community, right? That everyone's going to have to be a part of this. And so how do you build up a little bit of that, I won't say goodwill, but at least some level of trust that if we take these steps together, we're all part of a solution that can be tangible. And that's why I like the loss of insurance as a way to do that. So I don't know if that's as specific as you're looking for, but those would be a couple ideas.
So I agree with everything Doug just said, and I'll just layer on top of it. You talked about a budget in the context of state spending and the programs that the state administers, Medicaid, connector care, and I would just expand it to say, I think we need that signal, that alignment for the whole sector. We need, and that's really what I was intending to communicate when I talked about sending us a message is that let's agree to what we think is an acceptable level for healthcare cost growth that responds to all of these challenges, and then we can figure out together, all of us, because it is going to take everybody coming to the table with different specific ideas and solutions about how we evolve this system together. But I think without that kind of budget, without that kind of target, and without that having consequences, I think we need that forcing function to be able to make good choices inside of a budget that will serve the Commonwealth well on a long-term basis. And so I think some of this is also going to be about taking that long-term view, thinking about what are the needs as the population of the Commonwealth evolves over the next 10 years, 15 years. These are things that we can reasonably predict. How are the demographics going to change? What do we know about where people are moving? And so I think this gets at, Kevin, some of what you were talking about, so that with fewer resources and a system that's going to have to change, we're making thoughtful, intentional, planful decisions so that we're not just letting the market do what the market does, which might not actually align to the healthcare needs. And the last thing, I said it earlier, but I think we're on this theme of what can the state do. I really do think that to get to scale around how do we address the administrative complexity, the frustration that impacts providers, but impacts consumers, impacts patients. We've talked about this for a long time as a Commonwealth, 20 plus years. How do we get data flowing in a way that allows us to automate this and doesn't just have every payer individually connecting into every provider? We need a shared data infrastructure. And I think that's a really significant role that the state can play. And I do think it needs to be a mandate on all of us so that we can actually move past this being something we talk about and all nod to making it happen. And as I said earlier, I think this is something you'll find folks in the private sector. We're spending money on this right now, doing that individual wiring, that it may be a conversation that we should have about how do we pay for this together in service of the common good so that we can actually automate these things that we've just been talking about for a long time in terms of contributing to waste. Zandra, your point, we're just contributing to endless frustration. Every Monday report I wake up to and I read them, Steve, and I'm like, I know, it's real. It's a frustrating process. And yet these things are also necessary to make sure that people are getting, as Manny said, the right care in the right place at the right time. So,
Is there another panelist that wants to respond to that, Dr. Tapp?
So I think the question was, what can the government do? And maybe I'll...
And what can private actors do?
Right. So I think it's both. I think just to state the obvious, if it were simple, I would only have had to testify once. So clearly it's not simple. And I think that there is some that the state can do, and the state can't do this on its own, just like no other component of this system can do it on its own. So I'll give it as an example. What are we doing as a system? We provide care to about 25% of the population of the state. So it has an effect overall on the state. We're doing a lot, right? We're investing significantly in community-based care, virtual care, urgent care. What does that mean when I say investing significantly? When we came together as a system in 2019, 55% of the care that we provided within our system was care in the community. That was already more than almost any other system in the state. We're now at 70% of the care that we provide, and that will rise even further. And we think that that's where things need to go. So we're doing that, and that affects affordability. We're, as I mentioned already, investing in and expanding access to primary care. And we think that will affect affordability. We'd love help from the state on further incentivizing that, but we're doing that with or without the state. We're ourselves, and this has been mentioned by others, using technology ourselves, not waiting for government. We're saying, how can we reduce the administrative burden on our own providers and patients? And so we're using technologies to do that. We're behaving as a system of care, meaning attempting to bring patients to lower cost sites of care within our own system. You know, we're doing all of those things, and yet it's not enough. And I think what additionally needs to be done is we need to get the stakeholders, the leaders of the institutions together in a room to talk about, again, I'm going to go back to what I mentioned in my first statement. How do we rationalize care? Not how do we figure out how I'm going to extract more money from somebody else, because that's a fool's errand. But how do we acknowledge that given that this is the amount of money that we have, we're going to have to figure out rationally where we provide care and what type of care that we provide and where we don't continue to duplicate services. And there, I think the state has a role to play in helping convene all of that.
Yep. Thank you.
Thank you. Did you want to comment?
I would love to respond. So I'd love to share some of the things that we are doing at our community health center that may not be very well known, that I think contribute exactly to these specific cost-saving measures. One is that we have a family medicine residency program that I graduated from. I've been there 22 years. And 50%, over 50% of our physicians graduated from our own family medicine residency program. So we are training the primary care clinicians that are going to stay in your health safety net system and continue to provide primary care, mostly in Massachusetts, but around the nation as well. And we have a 75% Spanish-speaking population, so they also learn Spanish and graduate fluent to do their medical visits in Spanish, so that we don't have the increased cost of interpreters. So we are just looking at what our population needs and addressing those specific needs. I want to give a couple other examples. We were gifted a FibroScan machine a few years ago. Actually, it's probably 10 years ago now. So we were able to treat patients with hepatitis with the medications by being able to do a test that is not available, I think, anywhere in the Merrimack Valley except with us or in Boston, and saving the patient a trip, saving the cost of doing that very high-cost study in a Boston hospital, doing it on our mobile health unit, which is where the patients most need it, who have and can transmit hepatitis C, hepatitis B, HIV, helping to decrease those outbreaks so that we don't have many more patients. We have had multiple outbreaks in the last 10 years of HIV. We just recently had a hepatitis B outbreak, so we are there on the front lines to decrease that transmission and be able to prevent those costs coming in the future. We also have a clinical pharmacy program where we are able to have clinical pharmacists work with patients. And I'll just give an example of a patient years ago who was in the emergency room multiple times every month for months with seizures. She was not taking her medication appropriately, didn't understand how to do it. We set her up with the clinical pharmacist, and she has been years and years and years seizure-free, just taking her medication appropriately, making sure the doses were adjusted appropriately. So we have so many things that we are innovating on and continue to innovate on. We are utilizing the opportunity to develop doula program. So we are training a lot of the doulas in Massachusetts at our health center as well. And we would love to be a continued part of the solution in Massachusetts. Unfortunately, with a lot of the federal changes, especially in Medicaid, we are looking to lose probably 16% of our revenue within the next couple of years, because assuming those patients go uninsured, because we will continue to see everyone who walks through our doors who needs care. So we are definitely facing some significant headwinds and look forward to working with everyone in Massachusetts on how we can contribute even further to decreasing cost of care. I'll also say that we are going to be working very closely with our hospital partners and our community-based organizations to figure out where we can do the right care at the right time for patients, because that's exactly what's needed. We still see many of our patients go to the emergency room when we really could have taken care of them. So trying to expand our own access and also working with our neighboring hospitals to try to have better transitions between hospital and outpatient care.
Thank you. Sure. Mr.
Guess I'll be
Vogt.
the final one to answer the question, and thinking boldly and just deregulation. In the last few minutes here, I listed 15 government and private agencies that request information from healthcare providers today. And I'm sure if we went around the table, that list could grow to 25 very easily. So when we look at waste and simplification, particularly on the government side, I would encourage us to come together and say, do we need all this information? And is there duplication? To Kevin's point, and there's quite a bit of duplication in the requests that are coming in, and yet we're sitting here still talking about the same things, poor outcomes, inequity in the system at a higher cost. The second, I would say, and this is, I'm getting really bold here, so I'll apologize right now. But if we really want to think about simplification, could we think about one electronic health record? Meaningful use was a great thing, and it gave us, on the provider side, coming from the provider side, gave us all the ability to incentivize us to implement. But the promise that this new systems that we would implement would be integrated has failed. And we failed, to Sarah's point, it's failed to bring the data together to help us be more efficient. So whether you're a payer, provider, community partner, a behavioral health partner, we're all entering, and in some cases, repeating tests on our patients and our members. So the question becomes, as a state, and if we want to be bold, we want to be courageous, is it time to say we will have one electronic health system in our state? And then finally, I mentioned PACE program. I can go on. There are the value-based programs, the Medicaid ACO, the SCO program. Could we come up with one payment system? I'm not saying one single payer because I'll be out of a job. I'm talking about one payment system, a subcap for primary care. We haven't really unlocked the potential that primary care really has. When I say primary care, I'm not talking about the advanced practitioners or the MDs. I'm talking about the medical assistant, the medical secretary, the navigators, the outreach workers, who have tremendous amount of potential, but there's really not a reimbursement system for that. And as well, we're forcing primary care providers to live in multiple boats. For some patients, they're able to get all of these services. For others, they struggle. Different formularies. It drives, and I'm speaking on your behalf because they let me into the payer world as someone who grew up in the provider world. But there is an opportunity here for simplification. And I do believe there is significant, we would find and recover significant amount of dollars that could go back to better care and better outcomes.
Thank you. And just to clarify and educate me, when you talk about one electronic health record, is that the same general idea that you're raising, Sarah, that of data flowing in a shared data infrastructure? You're not specifying the mechanism, but is this the same goal, or is this the same goal? Okay.
Yeah, I
So
think
then
the outcome
you're-
is the same.
right.
It's a matter of,
Right.
do you integrate
It's
all
right.
the disparate
How do you
systems?
get there is the
or
question. Yeah.
Or do we
Okay.
come together
I
as a
just
state
wanted-
and say, we're going to invest in one system for the entire, for all the residents of our state?
That would surely bankrupt the state to invest in a single electronic record, but, you know.
We said be bold and creative, right? We said be bold and creative.
I think this is one of those areas where technology is changing so fast.
Yeah.
I think this could be a great application of, AI that wouldn't necessarily, I think the fastest path might be to create a centralized clearinghouse. We've
Yeah.
made some strides in that direction with our HIE in the state, but I think this is about taking it to the next level so you get real-time flow of information, which is what you need to respond to the points that both Zandra and Mandy made and Kevin have made around getting people the right care and not duplicating tests,
Right.
and would allow us to do real-time prior authorizations and, deal with denial, all these other aspects of the administravia of healthcare. So.
Thank you.
And can I just say that just to illustrate the scope and magnitude of the problem, any problem where the solution is a state IT project that integrates care for millions of people is the solution, it gives you a sense of the scope. But what I will say, going back to where all these things come in, is starting I won't say small because the challenges are real, but starting with something that's more definable and building from there. The good news is we're not going to solve these problems overnight, right? Don't worry about it. There will still be challenges tomorrow. Kevin will be here next year too, my guess is. But can we identify some of these more tangible things that we can build some momentum on? Because otherwise, if setting up something that is ambition is good, but you also want to make sure there's demonstrated and demonstrable progress in some of these areas. And I'm sure there's a lot of ways to do that on the IT side as well.
Yeah, thank you, absolutely. And let me just, because I know we have several commissioners who have questions, and this is a great discussion. Thank you. So let me just say that we'll have Commissioner Wilmoth, Commissioner McGregor, Commissioner Mahania. And then I'm going to suggest that we not ask each of our panelists to address every question. If a commissioner wants to address to a specific panelist, please do. Or if there's a panelist who feels strongly that you want to speak on a topic, just to enable us to have a little more. Okay, but Commissioner Wilmoth?
All right. So this is a question for you, Sarah. I wanted to explore a little bit more about your thoughts on the benchmark and the use of the benchmark. I think you said we need to take note of the benchmark. I think you said it should be more than a target. I think you said it a couple other ways too that I didn't write down. And I wanted to explore it in the context of the Globe article that I think most of the people in the room read last night and the difficult negotiations you're having with at least one provider. I'm sure others. And without getting into the specifics of that negotiation, it seems to me that you seem to be using the benchmark. The Globe, you said to the Globe that you're offering 3.58%, which is awfully close to 3.6%, and seemingly not a coincidence. But I guess my concern with that is that the benchmark was never intended to be a cap on the amount of rate and reimbursement increase that you give to an individual provider. And I want to ask you, we'll give you an opportunity one more time to say whether that's what you would like it to be, or whether you have something else in mind for it should be more than a target. And I guess my concern is that if you're talking about a firm target of the amount that you can increase annually, the amount you reimburse each provider, then we're no longer addressing commercial provider price variation. In fact, we're baking it in, most likely, making it worse every year. We're no longer better supporting what we used to call disproportionate share hospitals. I think Lauren and David renamed them high public payer hospitals. Somebody renamed them high public payer hospitals. And we're no longer supporting the lower income BIPOC communities that those hospitals serve. At least we're not doing so disproportionately, right? If you're giving the same 3% increase every year to every provider. And I think we understand that there are providers that are in different financial shape and that are in different abilities to absorb smaller increases than 3.58%, and others that maybe need to see more than that. And I think that's why I've heard the HPC say many, many times that the benchmark is not meant to be a cap or a specific, it's meant to be a target and a goal, which I think is, you said it should be more than a target. So I just want to, with that said, I want to give you an opportunity to sort of speak more to that.
Sure. I mean, I think you've heard it from, certainly Doug made that. I think it is very hard in an environment where we're looking at trend, as I said earlier, that's running year over year at about 14%, to get to something that we all consider affordable in terms of what we collectively as a community can afford for the state that has the highest cost of health insurance to go up. How much more? And so what my comments are really intended to indicate is, I think we as a community, and this happens to be the role that the legislature gave you, is to communicate that to all of us as participants in the healthcare system in Massachusetts, so that within that, we can work together to figure out how do we make good decisions about how to allocate those funds in a way that gets us the healthcare system we need in the long term to support the needs of the Commonwealth. The reality is right now, the things that are very hard for us as a payer to control are things like how sick residents of this state are. And therefore, the cost of the services, you heard Kevin talk about this, over his 15 plus years, he's seeing more people and more people who are sicker. Their care costs more. That is something that is very hard for any of us, whether you're sitting in a provider seat or you're sitting in a payer seat, to influence. The thing that we can influence is the unit price. And so we are mindful of that role that we play as payers in negotiating that unit price, and doing that in a way that is mindful of what that total medical expenditure target or budget you set is. Our intention is not to pay everybody exactly the same rate. But it so happens that we do have to be mindful, to the point that you made, about where are people in terms of their relative price in this state. And so what we are doing in the letter, I think you partially are alluding to, I referenced, that we sent to all of the hospital CEOs to say, this is the thing we can control, and it is our intention to have an average price increase that allows us more, frankly, ability to respond to the signal that we have been sent about what is the expectation of this body around how much we can as a community afford for healthcare costs, whether it's expressed in premiums, whether it's expressed in total medical expenses, to go up year over year. And that is, I think we need that kind of a budget so that we can figure things out in between. And all of the issues that you raised are real, and they're things that we consider in every negotiation with a provider. What's their relative price position? The one thing that is a particular challenge that we are heading into, and I know it came up in the last panel, is as the federal government takes money away, we cannot expect employers and consumers to make up the difference. We just can't. There's no more money. And that is going to make for increasingly challenging negotiations and contracts between payers and providers. So I'm neither Eric nor I want to be in the position that we're in. It is creating an incredible amount of angst and fear for residents of the Commonwealth all over the state. None of us want to be in this position. His challenges are real, as he anticipates the loss of federal funds or the underpayment relative to his costs from state programs. And we can't expect the difference to be made up on the backs of small businesses, employers, and consumers in the state. And so I think this is just, as I said, a symptom of the challenges that we face as a system. And I thought this were the last really tricky negotiation. I don't. I think it's the first. I think we're going to see more and more of this as we wrestle with how do we make this whole system and the financing of the system hang together.
Just to follow up real quick, do you have reforms to the benchmark process itself that you think, I hear what you're saying in terms of it needs to be a more universally understood concept and sort of followed by all actors in the system. But are you suggesting that there should be, I think at one point you did say it needs to be enforced, which I'm not sure what that means.
I think it has to have consequences.
And how would we go about doing that?
I mean, I think you don't have that many levers, but I think there are penalties. I think right now you've got authority to use performance improvement plans, but there's really only been one that's actually been leveraged and used within existing authority. I think part of the conversation that we need to have as a community is, how do you have more teeth behind, that, whatever you want to call it, target, budget. But I think that's what it's going to take moving forward for us to get together. It's a forcing function to really figure out how do we do this hard work we're all talking about to kind of rationalize and make the system work better. And we're seeing that there are lessons to learn from other states. I mean, there are interesting things happening into the north in Vermont, which is a system that I think is at a different level of crisis point. They've got 2 health plans in their state right now. The biggest is the Blue Plan in Vermont that has a risk-based capital right now of 200%. And if they had not been merged with the Blue Plan in Michigan, their underlying RBC right now is 100. They have a surplus note from another Blue Plan that's allowed their risk-based capital to be at 200%. And they're having a conversation much like this one about really creating a different kind of affordability budget and target so that the players in that system can come together and talk about, okay, what kind of a system do we need to have a system that the residents of the state can afford. You've got much stronger price controls in Rhode Island to our south, in Maryland, which is the longest running demonstration of how you use targets, and expectations for the health system. And you talk to the Centers for Medicare and Medicaid Services, they will tell you it is the most successful demonstration project they've had in the history of CMS to manage the growth of healthcare costs. Are these things perfect? They're not. But those are the kinds of things I think we need to be talking about here as a forcing function to do this hard work as a community.
Thank you. Commissioner McGregor?
Yes, thank you. I have two questions, and my first question is for Dr. Kelly. First of all, thanks for your testimony and thanks for your work in the Merrimack Valley. So just last year, we devoted, I would say, the majority of the cost trends hearing to discussing the fallout from the Steward crisis and ways forward. It was sort of a where do we go from here moment. But since a year ago, there has been significant changes. So in addition to the closings that we saw at Kearney and Neshoba Valley Medical Center, there was a change in leadership at Lawrence General Hospital. And I know that Steward and sort of the fallout there had a pretty big footprint in the Merrimack Valley. And I was just wondering if you could speak to what the impact on those shifts and those changes have been to healthcare delivery, to access, quality, affordability. And then I have another question, and I don't know if I should just ask them both now while I have my opportunity.
Are they both of?
They're different. They're different. So how about I'll let you respond, and then hope I still have a chance to ask my next question.
Oh, yeah. Yeah.
Yeah, so we've been working very closely because our physicians work at both hospitals, the inpatient at what was Holy Family Hospital and at Lawrence General Hospital. So we've been involved in working with them quite a bit, especially since Diana Richardson took over there and is now permanent CEO. So the impact of the change was significant. They had to merge their EMR systems, even though they had the same one, they were differently put together. So they had a whole merging that happened with that, all of their radiology systems, et cetera. Lots of challenges with delays in what was happening within that system. So luckily, we are on the other side of many of those issues. And then, of course, there's the merging of two hospital staffs, whether it's the nursing staff or the medical staff. So we're working with them right now on how they are planning to shift where care happens because they're only like 5-10 minutes apart, the two major inpatient hospitals. So they're doing a lot of work on figuring out how to help streamline care and make sure that the patients get the right care in the right place and that there's not duplicative services across those hospitals. Am I answering your question, or did you ask a different one? Okay. So we're working very closely with them on that, since we are some of the physicians who staff their hospital as well.
Okay. And you haven't noticed any major differences in access or perhaps the patient pool that's showing up at Lawrence Family Health Center?
I haven't seen much change in the patient pool that's showing up. I think they did have some challenge with because of the challenge with the way Steward left at their Haverhill and Methuen sites. There was definitely a challenge with trust of the system. So there was an influx of patients over to the Lawrence location instead of a balance between the two hospitals. I think that has more evened out by this point, but initially there was certainly a challenge with patients feeling like they could trust the systems with everything that was happening in the news. But that seems to have stabilized a fair amount. In terms of our community health center, our patient population has not changed and continues to grow. There are many more patients that need care than we're really able to provide right at this moment, so we do our best. Hopefully that answers your question. I think the most issue we've had with patients showing up is the ones that are scared to come, honestly, and those who have lost insurance and are doing the waiting game to see if they can get it back. And hopefully they won't have an issue that winds them up in the emergency room prior to that. But those are a lot of the challenges that we see in terms of patients not coming in who actually do need care.
Thank you. And then my other question touches on technology. And so, Sarah Iceland, you just mentioned AI, which is really, I think, at the center of so many discussions right now. I mean, it's hard not to turn on the TV and see something about this AI so-called bubble that we're in. Even though it's not new, it's the concept and, you know, the topic has been with us for several years, but I would say in recent years, there's been a rapid uptake in the healthcare sector. So a survey from this year found that 2 out of 3 physician practices are now using AI as of 2024, and I think somewhere around 86% of hospitals. However, even though AI comes with a tremendous amount of promise, such as increased productivity, lower cognitive burdens, et cetera, there are also dangers associated with AI, such as the dangerous errors and mistakes that it's been found to make, and that at times its output can reproduce discriminatory information and biases. And so my question to all of you is, what do you think the future role of AI in healthcare will be? And what are the most promising uses for improving patient care and potentially reducing administrative burdens? And then how do we ensure that AI tools in healthcare are accessible to all types of providers, that there's no big inequity in sort of institutional access, and that they ultimately promote equity rather than reinforce entrenched biases? So, sure.
That is such a huge topic. And so I'm not going to be able to do it justice, but I will at least kind of start us off. It's here. Your point is well taken. We've been using AI for a long time before we got generative AI, this latest generation of artificial intelligence. And I think it has great promise and great risk. And so I will just say, as a health plan, we are not letting AI make clinical decisions. So I think that's one way that we will mitigate some of the potential risk of bias. And I think there's other risk associated with AI that we need to be talking about as a community. That I think gets to the kind of theme we started with, which is the only way through this challenging moment we're in is with deeper collaboration. It's with building trust between the folks who finance care, whether they're in the government, whether they're private payers, and all of the folks who work in the delivery system. And one of the reasons I'm emphasizing that point in the context of AI is one of the ways AI is starting to show up relates to things that sound like a good thing on their surface, productivity enhancers on the provider side of the world, responding to all of the justified complaints about the pressure. Let's just talk about primary care, that you can use ambient listening to do a first draft of a clinical note. Some of these uses of AI turn out that the AI is a better coder than the humans were. And we are starting to see an escalation in the use of AI to improve revenue capture by providers. It may not, in fact, actually be, there may not be anything wrong with it. It might be just better coding. But it is, and we're starting to see evidence of it's contributing to this cost trend. And we're only in the early days. And so I think there's just so many different ways AI is going to show up that could create both more opportunities to respond to some of the challenges in the healthcare system, but could also create additional challenges that I think the only way through is for all of us as a community to come together to talk about how do we use it in a way that creates the most value on behalf of Zandra and Kevin's patients and doesn't create more problems, whether it's bias and contributing more to the inequities that already exist in the system, or having other effects. You're hearing people talk more and more, and I want us to avoid what could become an AI arms race between payers and providers, and I think that's a very real risk that is facing us if we don't come together and decide to do things differently. So there's a lot there. And then there are huge efficiencies tools. I'm going to a meeting later on this week. We're starting to have AI take member service calls. It's tremendous. We're doing this in one of our lines of business right now. I just listened to a sample call. And for some simple calls where people call us to ask about eligibility, it's actually a bot that is answering their questions. And the consumer, we do a survey afterwards to ask about the consumer experience. Believe it or not, it's often better than humans. And people will always have the option to drop back to a human. So I can't do the whole topic justice, but there's so much potential and there's risk. And the only way through it is if we work on this with great intentionality together.
Dr. Tim?
I just say AI is here, and I think whether we like it or not, it will have a larger impact on the way that we practice, deliver, and pay for healthcare than anything that we've seen maybe since the 1960s and the introduction of Medicare. I mean, I think this is going to be revolutionary for better and for worse. There are definitely positives. So you described ambient listening, ambient scribes. Our providers say this is one of the best things that we have given, one of the best tools we have given to them that they can remember. We're talking about, on average, our own providers having an extra hour to hour and a half a day. They're worried that what we will do is simply increase their productivity standards, and we need to be careful about that. But on the face of it, they are happier with the introduction of AI for that purpose than anything else that we've done in the last 5+ years. Is there a danger of inherent biases and mistakes being put in? Absolutely. But let's not kid ourselves. I'm not convinced that there were not more mistakes without ambient scribe than there are now with ambient scribe. I'm not convinced that the biases that were there that people were putting in by using their pen were any better than biases there with AI. So we need to be on guard against it, but I don't think that it's potentially worse. And then as it relates to cost, I absolutely hear the concern about the potential for it, what we would call appropriately code or do other things. We're concerned as providers about bots being used to automatically deny claims without anybody laying eyes on them. And so, I think there's a lot to be concerned about.
Yeah.
Huge topic.
I would just
Huge topic.
I would just add, we've established an AI task force and working very closely with WPI to really develop rules of the road. And one of those, as Sarah and Kevin mentioned, today we, just like the internet was 20, 30, 40 years ago, a human has to remain involved in the process. But it does make you think differently, everything from claims processing to care management, planning, and other programs. So this isn't the way we're taking an approach at it. This isn't just putting AI over a fax machine. This should really, and I would encourage all of us to think differently of the power that AI can bring, as well as the challenges and risks, to redesign the system in a way that will better serve the patients, as well as potentially bring down the costs. One example of that is, for many of us, we always think about the patients that are at the highest risk, the 10% that spend 80% of the cost. Well, with an AI in proper use, with oversight, now you're really talking about touching all of the patients, all of the members, and really providing more navigation, more guidance, again, right care, right place, right time. And AI potentially could do that more efficiently than any human possibly can. So that's the potential, but with risk.
Thank you. Commissioner Mahania?
Yes, and this is for Doug Howgate, and I'm asking for a friend. When you mentioned shared sacrifice and the potential role of the state as a convener, Are you thinking that's because we simply have the relationships and we're able to call people to a table? Or are you thinking it's also because we can threaten the players if they don't come up with sort of solutions to make things more affordable?
So I think it's both of those to some extent, but I think there's also a third practical reason, which is the state budget is a challenge we have to confront writ large outside of the healthcare construct, right? And so the state has a vested interest in trying to make sure it weathers, especially the next couple fiscal years, in a way that allows us to continue to have reserves and continue investments that have been made in healthcare and other places. I think of behavioral health and substance use in the healthcare front over the last few years, where more can always be done. But when you look at what has been done in the budget, there have been significant new investments there. And presumably the goal should be to maintain and enhance what we've been able to do in those places. And so I think the state has a very vested interest at the same time in helping to convene constructive decisions around healthcare cost, because that enables them to put a balanced budget on the books in a given year that they need to do everything else folks want to do. But I do think that the convening power of the state generally, and the fact that there's I won't say seamless by any means, but there's at least a direct connection between how the state convenes people and then the policymaking process at the state level that's very powerful. And the other part of it, I think, if I'm on the non-state side as well, is the state has some real blind spots, right? One of which is the state budgets from year to year to year to year to year. And so the ability to make some of the longer term changes, some of the longer term improvements that everyone on this panel has talked about, that's often not a really, it's easy for that to not be a big factor in annual state budget processes, because at the end of the day, you got to balance this year's budget and then you'll see it next year, right? And so I think that having a conversation that includes the provider, the payer community, the life sciences community, that can be about getting through this year's budget, but also with a view, again, towards the longer-term impact of some of these federal policy changes. My hope is that can also incorporate a little more medium and long-term thinking in the budgeting process at the state level that I think would be helpful to everyone up here, that if it's just about how we're going to balance the fiscal year 27 budget, sometimes the state is not incentivized to do that because of the nature of an annual appropriations process.
Your question? Is there a last question from any commissioner before we close? Thank you. Let me take a moment to just play back what I've heard. And actually what I'm going to focus on is your discussion and input about what could be done together. I hugely appreciate your comments about what you're each doing individually as leaders within your own organizations, but I won't play those back. They are very inspiring, though. First, I want to say that the input to do everything we can together to maintain coverage, absolutely. There was a lot of discussion in the panels earlier today to just that point, to make sure that everybody who's eligible for coverage can maintain it, and how various organizations can come together to make sure that happens, but we'll debrief further about that. Secondly, hear you loud and clear on the HPC's new responsibility for healthcare planning and the importance around an organization that can look statewide doing that if we are in a circumstance, as Dr. Tabb reflected, where we all know that there will not be more dollars in the system, and in fact could be fewer dollars going forward, and looking at what services are provided and where is not something that any one system can do on its own effectively, or certainly any payer. So that comes at a very important time, because we're extremely energized around the responsibility to look in that longer-term time frame that Sarah and Dr. Tabb both reflected around looking out to the future and looking at what our needs are and where we might need to rationalize. Also heard about the need for data to flow in a different way, whether it's whatever the vehicle for that is, and more that there's potential for more discussion on that and the ability to improve care and lower cost in that way. Important idea around multiple government agencies, and can we consolidate the information that's being requested. It strikes me that that is also something that the development of, new types of systems could help. And looking at that. And then we, I think, very much appreciate the discussion around potential payment changes, future of AI, other things that require exploration. I won't summarize those here because I just won't do them justice, but really appreciate that. We will spend more time within the commission at our next meeting debriefing on our takeaways from this and how we move forward. And really want to thank you for your participation and the discussion. Much appreciated. Thank you. Great. Okay, two. Pardon? Just two to testimony. So we'd like to proceed around two other agenda items before we adjourn. One is that I'd like to ask each commissioner to reflect on one thing that you would like to comment on today, either something that you've learned that you feel is important to you, a theme that we need to focus on, or any other reflection. And then the other is that we have two items of public testimony, and we will look forward to hearing from both Lindsay Tucker at the Health Equity Compact and Wayne Altman from the Family Practice Group. So let us take a few moments to discuss the hearing, and then we'll move to the public testimony. And I wonder if I can start at your end of the table, Sandra, with just one reflection or comment on the day, if you would.
Sure. Thank you. I want to thank all of the panelists, the HPC commissioners, and the staff for a really excellent and thought-provoking hearing today. I think that my takeaways land around the shared commitment I heard to mitigate harms from federal actions that are threatening our healthcare system, the importance of primary care, and agreement that we're facing an affordability crisis that's going to require shared responsibility to address. I'll say I really appreciated the last panel's focus on specific policy ideas, and look forward to using future convenings to talk about how we move from ideas to action. Thanks, everyone.
So I would just echo Sandy's thanks to the commissioners, the panelists, and of course the HPC staff for putting on another really insightful and I think by and large optimistic, although a little sobering, cost trends hearing. So I think my key reflection would be to sort of lift up the theme that I heard throughout all of the panels around shared responsibility, and in some ways circle back to my earlier question. There was a lot of talk and discussion and focus on how do we keep as many people covered under Mass Health and the connector. And I think that's critically important. But I also think with equal weight and equal imperative, we need to be solving for how do we make healthcare more affordable to incentivize employers to not only offer coverage, but keep employees on their coverage, so that we are shifting the large populations of folks that shifted to public programs, shifting them back to the commercial market, or at the very least, mitigating the continued deterioration and decrease in enrollment in the commercial market. And I say this because I think increasing shifts into the commercial market and employer-sponsored coverage is really a win-win all around. It's a win for payers, it's a win for providers from a payer mix standpoint, it's a win for state government, and most importantly, it's a win for residents who may otherwise go uncovered due to the federal impacts and landscape shifts. So that would be my reflection.
So thank you. The Attorney General said something to start the day that has stuck with me when being asked something we're all wrestling with, which is how do you deal with the uncertainty in this moment of challenge? And she said something which stuck with me all day, which she said, being yourself is enough. Just get up and do that. And I like that. So just hearing and spending the whole day with just the variety of experts and the discussion here and thinking about what this means for the Health Policy Commission, it just reminds me that being yourself is enough. And what I mean by that is the cost trend curve, the cost trend hearing, even a cost benchmark is important, but it's what's underneath that that's critical. And we heard a lot of testimony today on what's underneath that, and it just speaks to what really is under that. Is it truly price? Is it utilization, which may be a good thing? What are the different elements that we as a state are investing in? Some of those impacts might be investments in costs that are saving money. Others, maybe there is efficiency options. And so I would just harken back to the call for the HPC, which is the diagnosis of what's underneath that is critical. I think we learned a lot today that can be used for that. But the diagnosis, as it is in helping patients to get the right outcome, is critical here to inform policy. So I hope we get that piece right.
Thank you. So I heard the need for a cost reduction agenda. The legislature has a goal for a benchmark for our cost growth, but we need to figure out what we're going to do. And that means taking a detailed look. And I think the state policy has an important role in that. So if you look backwards, advanced practice nursing and people practicing at the top of their license, that's a cost reduction opportunity that we took. If we look present, we heard about the hospital at home program that people liked better than brick and mortar hospitals and cost the same as brick and mortar hospitals. Maybe there's an option out there that people like the same as brick and mortar hospitals and cost less. That's an option that the state could be pushing and considering. We heard about formularies where these divergent incentives between the PBMs and the payers and patients and what kind of high cost versus low cost drugs are available to patients. Regulations that might enable AI to enable clinicians to stretch their time and money further, those would be really important things for our state to be looking at. Competition is good. I'm an economist. I like competition, but it also costs in healthcare, costs and fragmentation. And so what kind of coordination can the state do to reduce those administrative burdens, reduce duplicity in the systems? I think the state policy has a really important role in catalyzing these investments and figuring things out that any given payer or provider wouldn't figure out on their own.
So this was my first. I found the testimonies very informative. And just, I don't want to repeat what's already been said, but the key theme that I took away was a desire to do something bold. And I also think that with that theme is when you do something bold and do something different, the resilience that that's going to take and how we navigate through that and how we show up and take on that challenge. And so, you know, I feel like I am leaving, and I hope we are all leaving with a sense of optimism that desire to do something to correct and solve for something that we've been talking about for a while exists, and the fact that we want to do it together. So I'm looking forward to the ongoing discussions and the debriefing and looking at ways that we can really tackle this as we show up every day to solve for this and make care affordable for our consumers. And as a nurse, it did resonate with me that everybody was looking at patient-centric solutions. Oftentimes that gets lost when you have to do and make hard decisions. So the fact that that was still a conversation front and center was important and resonated with me today. So.
So if, excuse me, if Kevin Tabb is the oldest person testifying, I guess I'm the oldest person hearing the testimony. So I want to go back to quotes I heard in our first panel, actually starting with the Attorney General, who said, we're paying more for less. Our employer then said, we're spending more, getting less. And then Liliana Patino from Elliott Community Health said systems are complicated and community agencies are overwhelmed. I think at our last panel, we heard of the need for rationalization of care. And I think that's absolutely right. I think we're at a really difficult place in healthcare in Massachusetts, which will only get worse. And so we need to really come together, as was said, to really think about how we rationalize care in a different way. I worry about the other, that may deal with the affordability. It may also raise new issues around access and equity, which scares me. And I think we got to be careful because we've seen some rationalization in the system that wasn't planned or thoughtful, particularly with the Stewart crisis. And we saw the impact on communities of color, rural communities, and I worry about what the impacts may be for those with behavioral health or those who are unhoused or who have other disabilities in our system.
Well, thank you so much to the HPC team for putting together an incredible day for all of us and to the panelists for their participation. What I'm reflecting on a lot is the HPC's new responsibility that the legislature and the government gave us at the beginning of this year around health planning. And what I'm hearing loud and clear is that we're a state where the leadership is open to that, feels a need to collaborate on that, feels that the outlook around rationalization needs to be carefully managed, as Commissioner Cohen has just said. And I'm very excited about that. I'm very excited coming away from today with hearing loud and clear that people recognize if we don't want to provide fewer benefits or provide care to less people, we have to rationalize the way we provide the care to make it more efficient, both administratively and clinically.
All right, so I am walking away with really just thinking back on one comment that a panelist made, which it was made in humor, but it was interesting to me because he said that I might advocate for single payer, but I might lose my job, right? And I know that that's a joke, and I know we can all understand it to some extent. And we don't have a single payer system or a national health system or socialized medicine, unless you're looking at the VA, which I guess is one payer and one delivery system. But I think at the same time, when we look at the private sector, we have so many sort of unlikely bedfellows working together. We have, I'm thinking of CVS, Aetna, Caremark, Minute Clinic. Are you an insurer? Are you a retail pharmacist? Are you a provider? Are you a PBM, right? So we're not coordinating it and providing it in the public sector, but we've now have all of this complexity in the private sector to regulate. So I guess in the spirit of bold moves and making bold proposals, I would say let's not leave anything off the table at this moment. Thanks.
So this is also my first hearing, and really learned a lot today. I'll boil it down to two things. One is I was really blown away by Secretary Levine's presentation on how proactively the state is going about to ensure mass health eligibility. Yes. That is this state punching well above its weight, all right? It's terrific. The second, the affordability issue. We are in an affordability crisis moment. It will not be solved by incrementalism. It will require bold policy choices. And I'll throw one out there, which is one fee schedule. You know, as an example of a policy choice you make to really move the whole health system in the right direction. Thank you.
Thank you. I agree with a lot of what my fellow commissioners have said already, so I won't repeat. Just to say, Madam Chair, I think it was a great meeting, and I learned a lot as well. My first chance to be up here at the dais. I guess I'll just make one point, which is, I think we heard last spring at the benchmark hearing from the hospital community that the benchmark wasn't really working for them. And I think we heard this morning or this afternoon from the pretty major player in the payer community that the benchmark's not really working for them. And I'm not sure how well it's working for the state, to be honest. So I guess I would urge, and I think I've done this before, but I would urge all of us to, and the HPC staff and the experts that we have there, to really take another look at the benchmark and how it's working, whether it can be tweaked, whether we can make some major changes to it, or whether it's outlived its usefulness. I mean, we also heard from David's presentation this morning that we haven't met the benchmark in a couple of years, and I think you said you don't expect us to meet it for a couple of more years. And I think you said we'll never get back to the 2010s, or may not. So, yeah, I just want to say that and say that I think it's a critical and central part of the work that the HPC does, but it may need reform at this point, given what we've heard over the past year or two.
Thanks. I came in with the thought that the delivery system wasn't working. Certainly leaving with the thought that the delivery system isn't working. And I think maybe we have to ask a different question, because David, you referenced earlier the AG's quote around it can't be business as usual, and maybe it's the same thing for the HPC, and maybe we should be asking people to bring their best idea on innovation to us to discuss, because the last panel was absolutely right. You cannot cost shift your way out of this problem. That system was developed 65 years ago, but that's business as usual, because that's what has worked for 65 years, and it just isn't working anymore. And like Commissioner Cohen, I also was very moved by the first panel because it was the most real. But I guess I didn't see a businessman in that moment. I saw a brother and an uncle. And I think that it's the reminder of how personal this is, which is why it's so hard oftentimes to make change. So I think the panelists were all courageous and transparent and honest. And I think that those that said if it can be done here are correct. But I think we have to take that mantra that David mentioned after lunch, can't be business as usual.
Thank you, Madam Chair. I think that, number one, congratulations to all the people here who lasted here the whole day, including Chair Lon and Chair Friedman in the back there. That's very, very impressive. Like, we have to be here, right? But
So true.
and my son is a sound engineer who wanted to be a rock music sound engineer, but instead got stuck doing sound for conferences. So I can feel your pain. So thank you for your work. I think I heard loud and clear something that it's been clear to me since I joined government about 2 years ago, which is that, and it's a very difficult thing, and I don't know that we've all accepted it, but we have an affordability issue that's throughout our state. And we're not just talking healthcare, right? We're talking public education, we're talking public infrastructures, we're talking transportation, we're talking housing, right? And what's difficult, and I think this is what Doug Howgate was talking about, shared pain and shared sacrifice, is that politically, it means us accepting that what we thought of as a normal society, we're no longer able to afford. Or we're not willing to pay for what that means. And I think that's a difficult thing, and I think that's what makes, the shared sacrifices difficult. I mean, I heard loud and clear that the state has really is being pushed by all the stakeholders to really help form this convening so these difficult conversations can happen. Of course, I always worry that it's like a marriage, right, where there's a need for change, but obviously it's the other person that has to change. And so I do worry about that dynamic, and that's why I was wondering about what is the forcing mechanism, like the way Sarah Eisling talked about. What is the forcing function that we have to get people to actually, because we're not talking about 1% shared sacrifice, right? If we're 30% above our benchmark, and we're talking about 30% shared sacrifice, and what makes people, what I hear from stakeholders is that they're ready to have that conversation. I'm not sure that I heard everybody's willingness to take that sacrifice on behalf of their particular industry, but they want to have that conversation, and I think we're going to have that. But so I was struck by the fact that people really want to talk, they really want to engage in a serious matter, and I think that was an uplifting part of the day, meaning that all the people who were involved in the process really know how difficult this is, how the difficult decisions that we face. And I was really grateful, particularly for members of my team. I thought Mike Levine was excellent in his presentation of the problem, and I really do think that HPC and the health cost trend hearing really serves a great purpose in terms of galvanizing us towards action.
First of all, thank you to the Health Policy Commission staff and leadership for just a tremendous job putting together what is an essential conversation tempoed to the time each year. And this year is, I think we use the phrase sobering, not just because of the impact of the federal changes, which will be immense, but for the fact that even apart from those federal changes, we've reached an inflection point that needs to change. It's very clear to me, and I've been at all 13 of these, that we can't do this again the way that we've done it in the past. That requires us to get together and talk, but talk is cheap, and we need to actually change things. As to the benchmark's sort of like the homework that gets assigned to the student. He may or may not do it, but the teacher never asks for the homework. So how do you know if the benchmark works if you don't have performance improvement plans that test the benchmark over time? I think the system needs a performance improvement plan collectively. That means all the major players in the market, both plans and providers, need to be pulled together and identify the steps that they can take on their own to effectuate change in terms of cost improvement. But at the same time, government needs a performance improvement plan. We need to revisit the statutory constructs that we have in place right now, the changes that we need and should take to effectuate affordability without losing access. And it's not good enough that we just protect against the losses of access that I think are imperiled by the federal government. If we don't tackle the larger system issues, then next year will be 25% premium increases hitting the market, and our businesses will no longer offer insurance. So I benefited from this conversation. I'm certainly not optimistic.
Thank you. Thank you, commissioners. More to come. I now want to move to the two individuals who will be providing public testimony. Could I invite Lindsay Tucker from the Health Equity Compact to come up to testify? And then we'll hear from Wayne Altman from the Family Practice Group. Welcome.
Good afternoon. I'm Lindsay Tucker, and I am honored to be the Managing Director of the Health Equity Compact. The Health Equity Compact is a coalition of leaders across the Commonwealth who bring their lived experience and professional expertise to dismantle systemic barriers to equitable health outcomes for all residents of the Commonwealth. Compact members are high-level executives and experts from a diverse set of health, business, labor, life science, and philanthropic organizations, including hospitals, health centers, payers, academic institutions, and public health. We want to eliminate inequities as the next chapter of health reform. Thank you so much for giving me the opportunity to speak. Thank you to HPC and your staff for this incredible day. Thank you to all of you for being here all day, and to all of our speakers. The Compact really appreciates the HPC's focus on access and affordability, and increasingly your emphasis that equity is essential to both. I so appreciate the opening panel and the opportunity to hear from experts closer to the community, people who brought their own stories and the stories of their employees, their patients, their workers, their families. Health equity is about the health of the population and the health of different groups, and whether or not the people in those different groups have the same opportunities to receive optimal health. We all know, and we've heard today, multiple examples where certain populations in Massachusetts don't have the same opportunities. We started hearing that with the AG this morning as she talked about healthcare affordability costs impacting Massachusetts communities of color disproportionately from other communities. And then Julie's story on the first panel about ensuring the availability of blood pressure cuffs regardless of size and in multiple languages, that is equity. Equity should be integrated into our critical policy choices, our budget decisions, and our practice changes as government and as a system here in Massachusetts, and not as a separate issue. We need to address the system as a whole system. I have heard all of you say that today, rather than leaving some groups out or some decisions out or for later, and then wondering why we have higher costs and worse health outcomes. When affordability pressures become as acute as they are now, even more than last year when I think we all thought they were almost as bad as they could get, it can be easy to lose the focus on equity. We acknowledge the urgency of the affordability issues, and it does not lessen the need to focus on equity in this time as you are focusing on affordability. They are inextricably linked. Many of you are familiar with the 2023 report that we commissioned in partnership with the Blue Cross Blue Shield of Massachusetts Foundation, The Economic Cost of Health Inequities. It found that racial health disparities among communities of color here in Massachusetts cost the state an estimated $5.9 billion annually. This was 2 years ago. And this is through premature death, lost labor, and avoidable healthcare spending. This will double by 2050 if we don't do anything. And as Commissioner Caljo has said also multiple times today, this is unsustainable for people and for our economy. Incremental change won't fix our system, certainly not at the scale or speed that we need. And I've heard all of you say today that it will take courage for the disruption that is needed to make the change that we need. So I come with a recommendation and a request. We need a shared vision for the health system that we actually want. And I invite you to consider statewide health equity goals as you think about that vision. We need a North Star to guide us through our current crisis and to ensure measurable progress and long-term impact. The idea of statewide goals has come up before from the HPC. It has come up from the Legislative Health Equity Task Force that was created during COVID, and the Attorney General's office also put it out in a report. These benchmarks, different from the cost benchmark, these goals will provide a framework for statewide collaboration, accountability, and targeted investment across the public and private sectors to reduce persistent health disparities. Establishing these benchmarks will complement existing quality and cost containment efforts by driving progress in reducing avoidable costs and improving health outcomes for all residents. There are multiple ways to take this action, such as a new task force, through executive order, through legislation, to my friends in the back of the room, an interagency initiative or expansion of ongoing work. Whatever the approach, it's critical to act now as the crises are deepening for the Commonwealth. That was the recommendation. The request is just to urge you all to act boldly. We need it for all of our communities. The shared sacrifice and the shared responsibility that was discussed today cannot be borne equally among all of the stakeholders at the table. And I think that that's a really important point as we think about who has skin in this game and what it means for different people and different communities across the Commonwealth. I have in my ear Secretary Walsh's comments from last year that we are admiring the problem and that we need to stop doing that. You have a tremendous platform and a tremendous opportunity. I think a lot of us think of this as the health policy wonk Super Bowl. So please keep this energy and this momentum to make change that we need. We have an incredible legacy of leadership here in the Commonwealth around health reform for many decades. We can do hard things when we work together. Thank you so much for leading us forward. We welcome the opportunity to collaborate.
Thank you. Thank you. Thank you for your testimony. And Wayne Altman, welcome.
Thank you so much. I recognize that I stand between everyone going home, so I'll try and make it good. I'll do the best I can. I'm Dr. Wayne Altman. I am Vice President of the Massachusetts Academy of Family Physicians. I'm Professor and Chair of Family Medicine at Tufts Medical School, co-owner of a private family medicine practice in Arlington, and founder of MAPCAP, Massachusetts Primary Care Alliance for Patients. It's been working for 7 years on primary care legislation that we call Primary Care for You, or PC for You. I'd like to thank Senator Friedman, who's been an incredible champion for primary care over these 7 years that we've been working. I'd like to thank the Health Policy Commission for an incredible day. I'd like to thank Chairs Lon and Friedman for championing legislation last session that created the Primary Care Task Force. Some people were skeptical that 25 people could sit around the table and actually accomplish something, but in a pretty short time, we've actually accomplished a great deal. So things are actually happening. We are all aware of the crises. I won't belabor them. Certainly there's an access crisis for primary care. If you lose your primary care clinician, I wish you the best of luck finding a new primary care clinician. It is not for the faint of heart. Obviously, cost and affordability, equity. Don't forget health. We are not nearly as healthy as we could and should be. And pipeline. I have 2 medical students by my side every clinic session that I have teaching them. I enjoy teaching very much. And the medical students tell us in primary care, you're doing God's work. Good luck to you. We'll see you from our cardiology perch or some other specialty perch. And that's the reality. And the only way we do that, change that, is by fixing the job and fixing the pay. So we have a solution. The solution, several of you said we need a plan. We need a solution. We have the solution. And it is primary care. Primary care has an evidence-based triple superpower. It delivers better health, it decreases health disparities, and it does it all at an overall lower cost. We deliver more for less, and yet in our infinite wisdom, we pay about a nickel for every healthcare dollar on primary care, while our peer nations who perform so much better than we do pay 15 cents per dollar for primary care. So our solution is primary care, and our solution is PC for You, this legislation that we've been working on for 7 years. And there are 3 excellent bills this session that promote 5 major components of primary care for you. One is doubling primary care investment in the state. One is shifting the primitive and toxic fee-for-service payment mechanism to a value-based prospective monthly payment. One is not delivering that double investment with no strings attached, but asking primary care also to work harder and sacrifice by delivering an advanced primary care, by delivering what we call the transformers, 20 different items that deliver higher quality care, by removing copays and deductibles from primary care. If primary care is so damn good, why do we create an obstacle course between our patients and the provision of primary care? The 5th item, of course, has already been accomplished with our primary care task force. There's one bill, H 1370, that also features what we call the Primary Care Stabilization Fund, a fund that would be overseen by the state that delivers payments directly to primary care practices. This is that single payer for primary care that Manny Lopes was calling for. Not specifically, but conceptually. And the key to this primary care stabilization fund is that we have about 4 million commercial patients in Massachusetts. And if we pass legislation for a new payment model for primary care, but don't have this stabilization fund as a mechanism, we exclude the 2.4 million, or 60% of these 4 million commercial patients. And then we're left with about 20% of the residents of Massachusetts benefiting from this legislation. To work this hard for close to a decade and then end up with legislation that only helps about 1 in 5 people is not good enough. It's what Delaware did, and they're regretting it. And several other states have been learning this lesson. The other thing that the Primary Care Stabilization Fund delivers, and some of you were talking about this, is it addresses rate inequities in a way that nobody else can from provider to provider. So in conclusion, Audrey Shelton asked us earlier this morning,
How do we pay for health services for people without insurance? So in addition to this legislation, I ask you to consider a bold new idea. Why not establish an emergency primary care stabilization fund that pays for primary care for every uninsured person in the Commonwealth of Massachusetts? This addresses the burning fires that we are about to have in our Commonwealth, and the amount of money saved through preventing unnecessary emergency department visits and hospitalizations would be dramatically higher than the relatively small amount of money it would cost to provide primary care to all of these folks. I will add that Audrey Shelto also said that because of the devastating effects of OB3, we need to be bolder and go to places that we were not originally willing to go. These are the places that we need to go. Sarah Islin said that, that our only choice is to do things differently, fundamentally differently. These are the things that we need to do. We've talked about affordability all day, but sort of without a plan. As you all said, the plan is primary care. I'll just add one other thing about GLP-1As, because we had the word cloud of the day was affordability all day until about 2 o'clock when it was GLP-1As for about an hour. In a medical school class that I teach, I ask folks to compare two plans. You have 100 patients over here who have uncontrolled diabetes and 100 patients over here. These folks, each set of folks get $1 million budget. These folks over here get doctor's visits, metformin, and GLP-1As. And by the way, it's about $10,000 a year, so 100 times 10,000, $1 million, the budget's over, okay? These folks over here don't get GLP-1As, but you can use that $1 million for free vegetables, cooking classes, a personal chef, free gym memberships, a personal trainer, and all kinds of things. You can imagine how far this money could go. And I ask the medical students each time, if you measured outcomes for these two groups over 5 years, who would have the better outcomes? And every medical school class raises their hand almost unanimously that the lifestyle group, if you really gave them the things that they needed to help overcome these barriers, it's the lifestyle group that would win out. And what would that teach us about how we over-pharmaceuticalize? And that's we've got to look at the root cause of this affordability problem. And the root cause is that we approach things the wrong way and we don't invest enough in primary care. So I'll say finally, Michael Loff from Cape Cod Healthcare and Kevin Garnett from the Celtics both said anything is possible. And so we talked all day about how great Massachusetts is, and believe me, for those of you who know me, I think Massachusetts is pretty great too. But if we're so damn great, it's time we get bold and actually talk about real solutions and how we solve this affordability, equity, and primary care crisis. Thank you.
Thank you. Thank you for your testimony. And I'm glad to hear what KG says about it, too. That's good. Always good to quote Kevin Garnett. Well, let me second Commissioner Mahanya's thanks to everyone who has stayed with us throughout the day. It makes a huge difference to have you here and to feel you as part of the process. And yes.
I want to.
Please.
Thank you. Sorry, you were doing your wrap up. I just want to take a moment to thank all of you commissioners. This was, for many of you, this was your first cost trends hearing. We can have amazing panelists. We can set up the best themes. We can have the best titles for all of these and write the best questions, but it's really you who lead the discussion, who press and pull out the best ideas, the best thoughts. You guys did amazing today. I'm so proud to be a part of this team, to work with all of you. This was a really great day. Thank you so much, commissioners. And I also want to recognize the fact that so much work goes into creating this day and making this day what it is. And a lot of that work is HPC staff. And so if you'll just indulge me quickly, I just want to recognize them quickly by name. So much of the organization and that goes into this, Hannah Klumak, Ashley Conter, Haley Reed, Mickey O'Neill, Ashley Johnston, Becky Wilmer, Andrew Carleen, Susie Roberts, Lindsay Lawrence, Colleen Murphy. This is a huge team that puts this together. David Auerbach gave me all of that data that I got to present on affordability. And of course, I can't do this without Lois Johnson and Colleen Elsmeyer. Thank you guys so much.
Hear, hear.
Now we can adjourn. Thanks.
Hear, hear. And let's not forget our executive director, David South. Woo! We love you, David. We know how lucky we are. With that, thank you so much. We will adjourn.
Thank you.
Good